Hello. Okay. ఇదే చెప్పండి. తెలుసు. ఆ కెమెరాకి వచ్చేసి అదే మీరు వచ్చేసి అది కొడితే వెళ్తుంది ప్రోగ్రాంలోకి మీద కెమెరా ఉన్నా ఉంది. స్క్రీన్ బ్లాక్ స్క్రీన్ ఉంది. Testing 1 2 3. Testing 1 2 3. Checking. Testing 1 2 3. Testing 1 2 3. Checking. Hello, checking. 1 2 3. Testing 1 2 3. Testing. వచ్చిందా? ఒకసారి ఇది చెప్పవా? స్క్రీన్ షేర్ చేయాలా? కాపీ చేస్తా కదా. ఓకే రైట్. ఇప్పుడు సెండ్ చేశాను అన్నా. ఇప్పుడు ఈ కెమెరా కంట్రోల్ ఉంది కదా, అది ఎలాగో ఒకసారి చెప్పు. ఎక్కడ ఎందులోనా సెలెక్ట్ చేయాలి? మిక్సర్లోనే కెమెరా ఉన్నా ఇదే. చూడు చూపిస్తున్నాను చూడు. జాయిస్టిక్ ఇదే. ఓకే. ఓకే వచ్చింది. ఓకే అవుతుంది. సెండ్ చేశాను వాట్సాప్, వేరే వాట్సాప్. ఓకే డన్. ఇది అలా మినిమైజ్ చేసి ఉంచేయాలా? ఒకసారి ఒకసారి. ఇందాక మిస్డ్ కాల్ వచ్చేసింది. హలో అన్న, మేడం ఏదైనా మాట్లాడండి మైక్ లో.
అనుష ఏమైనా మాట్లాడు మైక్ లో. ఆన్ చేయి
అక్కడ పవర్ బటన్ ఉంటుంది.
ఇప్పుడు మాట్లాడు.
గుడ్ మార్నింగ్ సార్.
హలో హలో, అర్థం కదా? చెప్పన్నా. ఓకే ఓకే ఓకే. ఏ మైక్? ఇది పొడి ఈ మైక్, మన మైక్. ఓకే, అది కొంచెం డిస్టెన్స్ లో పెట్టాను. ఈ రిసీవర్ మీద పెట్టాను అయితే. డిస్టెన్స్ లో పెట్టిన పర్లేదు కదా. మన ఏంటిది ఇది ఉంది కదా, మన ఓకే సరే. ఏదైనా డౌట్ అయితే కాల్ చేస్తాను.
Smith. Okay. టీవీ కనిపిస్తుంది. అది కింద మరి స్పీకర్ తీసుకుంటే మసాలా స్పీకర్ చేంజ్ చేయాలి. టీవీ ఉందా ఇప్పుడు శ్రీజ మ్యామ్ మనం అలా పెట్టాం. నెక్స్ట్ స్పీకర్కి మీరు ఎలా పెట్టుకోవాలంటున్నారు. అదే మరి ఎవరు చేంజ్ చేస్తారు, ఎవరు అది మన టెక్నీషియన్ ఒకసారి రాహుల్ కన్నా చెప్పండి. రాహుల్ కన్నా రాహుల్ స్పీకర్లో కంఫర్ట్గా వచ్చేసరికి ఎలా తిప్పాలి, ఆ స్పీకర్ టీవీ తిప్పాలి. ఎవరు తిప్పుతారు ఏంటో చూసుకోవాలి. టీవీ తిప్పడానికి ఏంటి తిప్పండి. అడ్జస్ట్ చేయడం స్పీడ్ చాలా కంఫర్ట్. చూడండి చేంజ్ చేయాలి. ఎవరో పోయి పెట్టించు. ఓకేనా?
Good morning, everyone. Myself, Dr. Amisha Vaishnavi, postgraduate.
And myself, Dr. Adashwin Mahabhadra, postgraduate GEM Srikakulam. We, on behalf of Department of Anesthesiology, GEM Srikakulam, cordially invite all the respected dignitaries, speakers, and fellow postgraduates to today's lunar CME on the topic Critical Insights into Perioperative Anesthetic Complications.
Anesthesia is often described as the silent backbone of the hospital. Our work is precise, moment to moment, and unforgivable with access. Despite the advances in the monitoring, drugs, and guidelines, perioperative complications still remain as a major cause of morbidity and mortality worldwide.
The topic, Clinical Insights into Perioperative Anesthetic Complications, includes several relevant factors in today's perioperative scenarios, which include increasing surgical load, evolution of anesthetic practices, AI advancement, and patient expectations.
Today's CME aims to understand the spectrum of perioperative complications, recognize early warning signs, discuss prevention strategies, strengthen crisis management, and to become better clinicians worldwide.
Let us now start our session with a presentation by our faculty, Dr. T. Shrija ma'am. T. Shrija ma'am on the topic
To begin today's event on an auspicious note, I now request Dr. Sujna, first year postgraduate, to have a prayer song. I request the audience to please stand for the prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणवन्दिताय गणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानावताय गानोत्सुकमनसे गुरुपूजिताय गुरुदेवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुरगुरवे गुरुदैत्यकलाक्षेत्रे गुरुधर्मसदानाथाय गुरुपुत्र पवित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीतगोत्राय गीततत्त्वाय धीमहि गूढगुल्फाय गुण्डमत्ताय गोचयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि.
Thank you, Dr. Sujna, for the divine prayer song.
Let us now start our session with a presentation by our faculty, Dr. T. Shrija ma'am on the topic Pharmacogenetics in Anesthesia, understanding genetic risks and complications. Dr. T. Srija ma'am, currently working as an assistant professor in GEM Srikakulam, completed her undergraduation from ZSMU Medical University, UK, and post-graduation from SRMC Medical College, Bagalkot, Karnataka. She has a work ex of 5 years post-MD, and her areas of interest are pain and regional anesthesia. Please welcome.
Namaskaram to all the delegates, faculty, and my dear PGs. Today I am going to tell about pharmacogenetics in anesthesia. I am Dr. Tapi Srija, Assistant Professor from GEMS, Srikakulam. So this topic would be incomplete if I don't talk about the Human Genome Project. Hello. So a few points about Human Genome Project. This Human Genome Project was started in 1990. This was the first international project, scientific project, which was done overall. So overall, scientists around the world, they have come together and they have spent millions and billions of dollars, and they have done, and it's like a mapping and a blueprint of a human gene. Okay, so and they have what they have done is they have submitted their project in 2003. In 2003, they have uploaded all the blueprint of the genome free online, so that the scientists all over the world, whenever they are doing any research about the genes, they can utilize this Human Genome Project blueprint, and they have done so much of research on the genetic material. And surprisingly, like it is only 20,000 to 25,000 of genes in our human genome. Among that, 99.9% of the genome is similar in all the population over the world. So whether it is American, Asian, we only have 0.1% of the difference in our human genome. That 0.1% of the difference is what is making us all unique. So you and me have only 0.1% of difference. Okay, and also it is surprising to know that 98% of the human genome is matching with the chimpanzee, and also 75% is matching with a rat. So this is all the information they have given, and also this information was used previously and now they are using also to prevent and treat the inherited diseases. Okay, and also they have used the information available from there in advancing developments in pharmacogenetics and personalized medicine. So what is pharmacogenetics actually? Pharmacogenetics is nothing but the study of changes. So variability, study of variability of the individual's response to a particular drug due to the inherited factors. Okay, if we study it in a person, it is called as a pharmacogenetics. Whereas if we study it in individuals as a whole genome across the population, it is called as pharmacogenomics. Did you understand? Difference between pharmacogenetics and pharmacogenomics. Now, coming to the next topic. So nowadays, how do we give the induction agents or any drugs? It is only calculated according to weight, right? For example, say propofol, I'll be just giving 2 mg per kg. But we have seen so many, like we are experiencing daily that propofol will not be acting as the same to all the individuals. Yeah, loss of consciousness depends on the person's own individual factors, right? So that is not the only variable. We are taking only weight, age, and medical history into consideration. But that is not the only factors which is going to affect the drug. So that is the reason now we are going to study the pharmacogenomic variabilities. That means differences from person to person. That is all today's topic is about. Going to the next slide. So when we want to learn about the pharmacogenetic changes, we have to know what are the changes where we can see the drug differences, variabilities from person to person. So first one is pharmacokinetic variabilities. Variabilities means differences. Kinetics means, as we all know, drug movement. From the time we have given the drug till it is getting excreted. Pharmacokinetics, absorption, circulation, metabolism and excretion. So all this comes under pharmacogenomic variability, pharmacokinetic variabilities. So how can we define it? We can define it by how soon the time after administration of a drug therapy to effect site concentration is reached and how long it is taking to maintain. That is what the variabilities we see under pharmacokinetic. Coming to pharmacodynamic, dynamic is effect of the drug at the site. So pharmacodynamic variabilities is seen the differences in the response to equal effect site concentration. Okay. So now we are going to see all the all the pharmacological agents which we use in the daily life. The first one is opioid. In opioid, we are going to see all the pharmacodynamic variabilities. So the differences from the individual to individual. Why the difference is there? First one is pharmacodynamics. We are going to see where the opioid receptors act, where the opioids act on the most commonly on the mu receptors, right? So you all have to be attentive. Don't talk. You all have to be attentive. Please listen. This is a very different topic. You should understand. Okay. See these mu opioid receptors. How do they act? They act by inhibiting the G proteins and they initiate the cascade of complex neuromodulatory processes. So what happens if these mu opioid receptors get mutated? Obviously there will be altered binding to the endogenous and also exogenous opioid drugs. So these mu opioid receptors are actually given by the gene OPR, opioid receptor M1 gene. This opioid receptor M1 gene is there. If it gets mutated, by the way, what is the most common mutation which we see in the individuals? It is single nucleotide polymorphism, SNP. Okay, single nucleotide polymorphism is the most common mutation which we see individually. So this SNP of only one nucleotide change will be there, which is in C118AG, adenine guanine. Okay, adenosine and guanine. So if the change in this nucleotide happens, the mutation because of which the gene will be altered and the mu1 receptors will be changed. So after this one, so they have done various studies, among which Orator and colleagues, they have done a study where they have seen the homozygous carriers for this mutation, which is SNP mutation of 118AG gene, they are requiring 2 to 4 more times of olfentanyl compared to normal individuals, who don't have that mutation. So they are requiring 2 to 4 times of more olfentanyl in order to get that analgesic effect. And also they have seen that they are requiring 10 to 12 times of more drug compared to the normal individual in order to get respiratory depression. Okay, this is what they have studied and they have documented. And the second most important protein which is mutated is beta-anesthetic. Okay, this is a protein which actually desensitizes the opioid receptors after prolonged exposure to drugs, opioid drugs. For example, now as we all know, in chronic cancer patients, in chronic cancer treatment, will be using opioids most commonly. So if this beta-arrestin protein is there, they will have poor tolerance to this opioid. Okay, so if by assessing that beta to arrestin 2 gene, if it is there, we can switch over the opioid from morphine or whatever it is to the next opioid. Understood? No. Next most common genetic mutation which we see is catechol O-methyl transferase enzyme. What does this enzyme do? This enzyme is helps in metabolizing the catecholamines, norepinephrine, epinephrine, and dopamine, such kind of catecholamines. So if this gene gets mutated, if the gene which codes for this catechol O-methyl transferase enzyme gets mutated, so there will be altered regulation. So transferase will not work. So what will happen? All the catecholamines will be increasing in the blood. What are the catecholamines? Norepinephrine, epinephrine, dopamine. If this increase, what will happen? The pain perception will be more. They will be pain sensitive. Patient will be more pain sensitive, and also there will be decreased activation of endogenous opioids. Endogenous opioids will be having decreased activity. So what happens to compensate this? There will be upregulation of the opioid receptors. So if such patient comes to us, what will happen? Even if we give little bit of opioid also, they will go into complications such as respiratory depression, as there is upregulation of these opioid receptors. So that is what we will be facing inside our OTs. One more mutation which is most common is melanocortin 1 receptors, which mediates by kappa opioid receptor sensitivity. So this is all pharmacodynamics. Coming to pharmacokinetics, um, pharmacokinetics is, drug movement, right? Absorption and distribution. So for absorbing, we must have a protein. What is a protein which is most commonly involved in absorbing the opioids? It is P glycoprotein. Okay, P glycoprotein, which is most commonly used, which is most commonly substrate for efflux transporter, including morphine, fentanyl, methadone, and sufentanil, and also SLC, organic anion transporting polypeptides. These polypeptides are proteins. They just work on the concentration gradient. Okay, it is solute concentration, organic anion transporting polypeptides. These are all the proteins which helps in distributing the drug within the organs. For example, liver, brain, or any organ. So you can imagine, if there is no absorption and distribution, what will happen to the drug? The drug will not act. So if any mutation is there within this absorption and distributing polypeptide genes, what happens? There won't be any absorption and distribution of the drug. So this is how the drug will be hampering. And the next most common mutation which we all say is for metabolism. Actually, what is the most common enzyme? Most common enzyme is? You should tell me. What is the most common enzyme? Huh? Cytochrome P450, it is there on slide. Yeah, cytochrome P450 family enzymes, which is most commonly involved in metabolizing all the drugs. Okay, some of the enzymes are CYP2D6, CYP2C9, CYP3A4. All these are types of enzymes which come from that family. So if the gene if the gene gets altered, okay, of that enzyme, for example, say CYP2D6, then what happens? That enzyme will be less and the metabolism will be less. So, and also they have done this study, human genomic study. In that, they have seen that this enzyme exhibits so many genetic polymorphisms. Okay, and so they have divided the persons into 4 categories based on this enzyme metabolism. One is ultra rapid metabolizers, extensive metabolizers, intermediate metabolizers, and poor metabolizers. Okay, ultra rapid metabolizers. Ultra rapid metabolizers में क्या है? Multiple copies of activated gene enzymes will be there. So multiple copies will be there. So what happens? The enzyme production will be very high, and there is rapid elimination and rapid metabolism of the drugs. Okay. Next is extensive metabolizers. Extensive metabolizers are commonly what we see in our population. They exhibit normal enzyme activity. Okay. Intermediate metabolizers, little bit decreased compared to the normal individuals. Poor metabolizers, there will be very slow drug metabolism because there will be little or no enzyme activity at all. So we will see some examples. For example, I have got a patient with CYP2D6 error. So what happens? If he is a poor metabolizer, what happens? There will be no analgesic effect at all. You are able to understand my point? If you have any doubts, please ask. Okay, they will not be able to experience a little or no analgesic. If they are ultra fast metabolizers, what do they? They will have overdose of the drug, like respiratory depression. We can see respiratory, even if we give little amount of drug also, they will go into respiratory depression. Similarly, CYP2C9, which is involved in metabolizing warfarin. So either they will be increase in coagulation or there will be decrease in coagulation. Okay, lastly, CYP3A4. This is the most common enzyme for metabolizing broad spectrum of drugs, including midazolam. So what happens if midazolam is not metabolized? What happens? It gets accumulated and patient will have prolonged sedation and prolonged complications. Okay. Okay. So this is how we can see whether the patient is intermediate or poor metabolizer, and we can scale the drug according to the patient. Okay. So drug selection and dosage also we can vary according to the patient's and also we can tailor the drug dosage. So this is the table, which mutations, which genes are hampered. Next, coming to malignant hyperthermia. Malignant hyperthermia, I think all of you know that malignant hyperthermia is related to ryanodine receptor 1 gene. What happens if this gene is getting mutated? See, if the gene gets mutated, this is properly. This is sarcoplasmic reticulum. Okay. So if this gene is exposed to our drugs like inhalational anesthetics or scoline or what happens? It gets sensitized and the calcium channels will be open. So the calcium which is there in the sarcoplasmic reticulum will go out into the cytoplasm. So there will be calcium ion accumulation in the cytoplasm. So what happens due to this accumulation? There will be sustained muscle activity. Sustained contractions will be there and muscle cell metabolism will be more. So due to that what happens? Oxygen consumption. As the metabolism increases, oxygen consumption will be there and CO2 will be eliminated. Excessive CO2 will be there and heat production also will be there because of the muscular contractions. So we can see muscle rigidity, hypercapnia, hypoxemia, acidosis, hyperkalemia and hypothermia. Okay, we'll go back. So what are the genes involved in malignant hypothermia? It is ryanodine receptor genes in 70% of the cases and CAT-NA1S gene, which is seen in 1% of the patients. So nowadays, that is the reason we are keeping dandrolinum in our stations, so that the dandrolinum, it helps by a skeletal muscle relaxant, which inhibits the calcium release from sarcoplasmic reticulum. So if we suspect any patient having malignant hypothermia, what can we do? How can we prophylactically avoid it? We can take a muscle biopsy from the patient, and to that specimen, we can expose that specimen to halogen and caffeine. If muscle contractions is there for that specimen, that means he is malignant hypothermia positive. He is positive for malignant hypothermia. So we give him medicolored bracelet, and they should receive malignant hypothermia safe anesthesia. What is malignant hypothermia safe anesthesia? Just to avoid the drugs which will trigger malignant hypothermia. That is the reason we can give TIVA for this patient instead of using gaseous anesthesia. Okay. Next, coming to scoline, which is most common. This is also the most common complication which we see. Scoline are the muscle relaxant during intubation, which is metabolized by, as you all know, pseudocholinesterase. The genetic variant is butyrylcholinesterase gene. This can lead to pseudocholinesterase deficiencies. You know this, right? So what happens if this deficiency is there, if the gene mutation happens and this pseudocholinesterase is deficient, this choline will not be metabolized. So what happens? This choline will be in the plasma continuously and this prolonged paralysis will be seen. And they have studied that with the patients with lower levels of HDL, especially this apolipoprotein A1 will have higher risk for low levels of butyrylcholinesterase. This butyrylcholinesterase is a beneficial enzyme that metabolizes not only scoline and mivacurium but also ester local anesthetics like procaine and tetracaine. So what is the test we can do? What is the test we can do? We can do a Debukane test, Debukane number test. What is Debukane? You should tell me what is Debukane. Debukane is a local anesthetic which we give intravenously to see how much proportion of the pseudocholinesterase is functioning. Okay, if the fraction is 80% or if the fraction is 0.8, that means it is normal phenotype and they will have normal pseudocholinesterase functioning. If it is 40 to 60, it means that is heterozygous atypical. They will have moderate impairment of pseudocholinesterase formation. Okay, if it is less than 20, they are homozygous atypical. They will have significant impairment of pseudocholinesterase levels. Okay. Next, what is next most common disorder which we see is congenital long QT syndrome. This congenital long QT syndrome is due to the mutation of the genes such as KCNQ1, KCNH2 and SCN5A. So what happens in these genetic mutations? They will have ventricular repolarization, prolonged ventricular repolarization phase. So due to this, QT will be prolonged. So as we all know, some of our anesthetic drugs and also the other drugs will prolong the QTs, right? For example, volatile anesthetics, ondansetron, and some other drugs can prolong QT. So if we come to know that the patient has these mutations, it is better we should avoid these drugs. Otherwise, there will be that prolonged QT will be converted to arrhythmias like tortious, deportis, and also the patient can get arrested. Okay. Okay. Next most common genetic variant is like PONV. Obviously, we can assess by checking the gene mutations in domperidone D2 receptor genes and serotonin 3 receptor genes, and we can preventively give PONV treatment. The next enzyme is CYP2A1, and they have seen that halogen hepatitis, as we all know, that is not common for all the individuals, right? But why only few people are getting that halogen hepatitis? Because of this genetic mutation. Okay, genetic mutation by which this enzyme will be reduced, CYP2E1 enzyme. Okay, this is the enzyme. If it get reduced, the metabolism will not happen, and they will have prolonged exposure and also serious complications we can see. So if we are able to screen these genetic disorders before itself, we can avoid the patients to give this drugs. Okay, sodium channels. Next is ion channels such as TASC1 and TREC. These also have a effect on volatile anesthetics like isoflurane. Coming to nitrous oxide toxicity. So we all know that nitrous oxide will inhibit vitamin B12, which is a coenzyme which is required for the formation of methionine and also tetrahydrofolate. So this tetrahydrofolate demethylation should be happening, right? So methyl tetrahydrofolate reductase. This reductase enzyme is very important and necessary for the formation of methionine. Yes, if this reductase enzyme is not there within the body, then what happens? Obviously, there will not be any methionine and there will not be any tetrahydrofolate, which is very useful in the formation of neurons and myelination of the neurons. So once the patient is exposed, they have done a study where they have seen that there is catastrophic acute demyelination after short duration of exposure of nitrous oxide in children, especially in pediatric population. When they are exposed to nitrous oxide, they have seen sudden demyelination. So why? Due to this deficiency of methyl tetrahydrofolate reductase. If that gene is there, and if they are having that reductase deficiency, then they will have demyelination. So before only if we get to know that they have that gene, so it is better to avoid nitrous oxide, right? So what not all the receptors have mutations here. Telling you, GABA also have receptor mutations. So all our propofol, etomitate, everything will be acting on that receptor, no? So all that is getting. So and also propofol infusion syndrome. As we all know, that propofol infusion syndrome also will not come to all the individuals. So they are all still ongoing processes. The research is that which gene is related to this PRIS. Okay, and coming to this is the table where genetic mutations, genetic variants are given. Coming to conclusion, personalized anesthesia care is essential for minimizing perioperative complications by tailoring anesthetic management to patient's genetic profile, which can significantly reduce the risk of adverse events such as drug-induced organ toxicity, severe allergic reactions, and anaphylactic reactions, which is most dreadful complication, is also related to the human leukocytic antigen. So once we trace that human leukocytic antigen which is causing that anaphylactic reaction, we can prevent giving the drugs which will cause anaphylaxis to the patient. So that is what we are expected to do. So that is what precision medicine is all about. So precision medicine in anesthesia, which is driven by pharmacogenomics, holds a promising revolutionizing anesthetic care by providing personalized patient-centered approaches. By tailoring drug selection and dosage to individual genetic profiles, this approach can significantly enhance the patient safety, reduce perioperative complications, and optimize recovery. As the field continues to evolve, the integration of pharmacogenomics into clinical practice will play a pivotal role in advancing the future of anesthesia, making it safer and more effective for every patient. These are my references. So this slide, why I have kept this slide is our great grandparents, whom we do not know how they look, what their name is, are still on our head. They are still our backbone and in our blood, everything. Whenever they want to take over us, they can. So consciously, we have to make sure that the positivity of theirs is okay, but the negative effects of them, we should not take them to control over ourselves. So we can prophylactically, by seeing our genetic makeup, by understanding our genetic makeup, we can prophylactically treat ourselves. Okay? Thank you all. Thank HOD sir and Ashok sir, Pratik sir for giving me opportunity. Thank you, sir. Thank you.
Thank you, ma'am, for introducing us to this new topic. Your expertise for sure has added great value to today's session. Now the session is open for any queries and discussions.
It is still growing, sir. Just I think in abroad, like in the United States and all, they are still researching and that especially malignant hypothermia, because the cases are more there. So they are trying their level best to screen the patients before itself. And you can see in the slide also that the mortality rate is decreased from 8% to 5% because of the screening of malignant hypothermia. It is just an example, sir. So they are trying to inculcate that by checking the enzymes and all. They are trying to inculcate that. I think it is still going to take time for us to, because the screening panel and all is very costly. Actually, that is the issue. But if it comes to the patient's life, I think it would be a very good source of, as prophylaxis is better than treatment. So we can avoid the complications perioperatively by doing this genetic screening well before. Yes. Yes, sir. Previously, to take this blueprint and all, they have a blueprint of our genome. They have taken almost 13 years to 14 years to take out this blueprint. But after we get that blueprint and after that is there online for all the researchers and all, scientific approaches and all, now it is just 30 minutes. In that 30 minutes duration, we can screen all the genetic variations from a genome. I think so. Yes, sir. Cost effective.
So, good morning, Judge. So, if you face the complication regarding this pharmacogenetics with some drug, how will you counsel the parents?
So, I don't think parents can.
How will you convince them that it is not due to my
Yes.
fault, it was due to some genetic problem? How will you convince them?
Yes, sir. If that is the reason, sir, that we are trying to get this screening done more. But as this is not available in India, as we cannot screen all the patients, we can just explain them that due to the exposure, this might have happened. That is just a query. For example, if we take malignant hypothermia, we can send that for biopsy because of the evidence. Evidence, which always the patients trust in the evidence. So we can show them that because of this muscle contractions and not because of the reason, we can show the reason that maybe because of this issue has happened. Otherwise, usually we cannot explain to the attenders or we cannot explain why that has happened, as to my knowledge.
Thank you, ma'am. We request you to kindly stay back for a moment. Now, I request Dr. B. Muralikrishna, sir, Professor and HOD of Emergency Medicine, GEM Srikakulam, to kindly connect ma'am with the moment. 。 。 。 。 。 。 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 . 。 . 。 . 。 . 。 . 。
Thank you, sir and ma'am. Now, we will continue into the academic section of today's seminar. We would like to invite Dr. TDP Subalakshmi Madam on the dais for a presentation on the topic Neurological Complications Associated with Perioperative Anesthesia, Mechanisms, Prevention and Management. Dr. TDP Subalakshmi, Professor and HOD, GMC Srikakulam, completed her UG from AMC Visakhapatnam and PG from AMC Visakhapatnam. She has a working experience in the field of anesthesia for over 20 years. She has an areas of interest in pediatric anesthesia, critical care, and obstetric anesthesia, and she also has a publications in 8 national and 4 international journals. Welcome, ma'am.
Thank you very much for this opportunity. I'm sorry if my voice is cracking. Am I audible? Today my topic is perioperative neuroemergencies, the diagnosis and management. Perioperative emergencies might arise both due to surgery or anesthesia. They may be complicated by both surgical procedure or anesthesia procedure. The root causes being ischemia, hemorrhage, hypoxia, metabolic disorders, leading to results which can be devastating, and these results might result in increased morbidity, increased length of stay in the hospital, decreased quality of life, and increased mortality. As we all know, the main therapeutic targets for both our anesthetic drugs and analgesics is the brain and the spinal cord. And the spawns, brain and the spinal cord, they form the most important physiological system and comprised organs when it comes to anesthesia. But at the same time, we have no standard monitor for the brain or other neural structures during anesthesia and surgery. And there is no alternative, or the healing process is not as good as we see in other structures like kidney, heart, lungs, skeletal system, and liver. And there is no replacement for the function of the brain as we see in these organs. The neurological symptoms, as we know, can be easily identified when the complications or emergencies occur when during regional anesthesia than in general anesthesia. And when we identify these symptoms, we can assess them early. We can make an early assessment coming to a prompt diagnosis, and we can treat them during regional anesthesia. I will deal with this on the two heads, regional anesthesia and general anesthesia. First, coming to the emergencies during regional anesthesia. Ulnar nerve is the most commonly implicated followed by brachial plexus, followed by lumbosacral nerve roots, and spinal cord in the anesthesia-related nerve injuries. And when coming to neuraxial blockade, these are all the heads I'm going to deal with: seizures, total spinal paraparesis, epidural hematoma, cauda equina, and I'm going to deal in detail, a little bit in detail, about brachial plexus injuries. Seizures, they can be convulsive or non-convulsive based on the activity we see on the EEG. Any type of convulsion will lead to altered mental status like coma, lethargy, or confusion. And this can occur when we resort to any type of peripheral nerve blocks in the neck, thorax, upper limb, and abdomen. And most commonly, we perform peripheral nerve blocks in the upper limb. And there's a special concept. There was a special concept known as intravenous regional anesthesia, or the bias block, which was used for upper limb surgeries. When the ketamine was used in this during this anesthesia, when the tourniquet was released, there will be high flow of ketamine into the general vascular compartment, leading to its high concentration, and this might lead to seizures. So this is a table. These two are tables of the commonly used local anesthetics and the maximum doses which can be used with and without epinephrine. So that there is a concept called local anesthetic toxicity. If we cross the upper limit of these local anesthetic dosages, we may land up in the patient may land up in local anesthetic toxicity. Local anesthetics are safe, relatively safe, when they are used in appropriate dosage and when they are placed or deposited in the correct anatomic location. We tend to step into systemic and localized toxic reactions if given in different planes, in like intravascular, intrathecal, or in excessive dosages. And systemic toxicity will result in CNS and severe symptoms. So, and central nervous system is more susceptible, and the dose required to produce central nervous system symptoms is much less than that required to produce circulatory collapse. And classic sequence of toxic symptoms, they range from minor to major. Minor being, it starts with perioral tingling, metallic taste, tinnitus, and leading to major symptoms like seizures and cardiovascular collapse. Symptoms can be when the patient is still able to converse with us. He becomes disoriented and he becomes drowsy, and he will complain of difficulty in focusing or tinnitus. And then, when we try to elicit signs, the first signs will be excitatory in nature, first seen in the facial muscles and also in the peripheral parts of the body, distal parts of the body. This might progress to generalized tonic-clonic seizures. When we don't stop, when there is further increase in the dose of the local anesthetic, this leads to generalized state of CNS depression, and this leads to respiratory depression and arrest. How do we treat it? When there is inadvertent intravenous local anesthetic injection, which leads to convulsions, first we resort to small doses, IV doses of benzodiazepine like midazolam. Propofol can also be used as it is faster acting, but we have to use with caution in patients with hemodynamic instability. When seizures occur, what are the consequences? This leads to hypoventilation, leading to hypercarbia, hypoxemia, and acidosis. This in turn leads to respiratory and metabolic acidosis. This further exacerbates the CNS toxicity. So what do we have to do? We have to provide prompt assisted ventilation and circulatory support. When we plan a neuraxial block or a peripheral nerve block with high doses of local anesthetics, we have to keep monitoring equipment, oxygen supply, airway equipment, drugs like midazolam, thiopentol, or propofol, muscle relaxants, and intralipid 20% ready. What is intralipid 20%? Let's talk a little bit in detail about this. When cardiovascular depression or circulatory arrest occurs, we have to initiate basic life support, and we have to also progress to ACLS protocol. Along with, when it is due to local anesthetic toxicity, we have to go for rapid bolus of intralipid 20% at a dose of 1.5 ml per kg, approximately 100 ml in adults. And this can be followed, if necessary, by an infusion of 0.25 ml per kg per minute over the next 10 minutes. This is how we deal with local anesthetic toxicity. Coming to total spinal block, I don't know how many have experienced this, but I have in my career experienced 3 episodes of this total spinal block. This occurs when we go for a neuraxial block or a peripheral nerve block with large volumes of local anesthetics as epidural or nerve block in proximity to the spine. When there is an accidental injection of local anesthetic into the subarachnoid space, the drug, it spreads into the not only the CSF in the spinal cord, but also it spreads into the brain. The patient loses consciousness gradually. So how do we first have to identify the condition and control the ventilation, and we sometimes have to stabilize the hemodynamics if they become impaired or if they become disturbed. We have to use vasopressors if necessary, and the marvel of this situation is the patient recovers spontaneously once the drug is metabolized. But in the duration of surgery, during the duration of surgery, if a muscle relaxant is used, we have to administer reversal also. Then the next, though an uncommon emergency, paresis or paraplegia. This luckily, fortunately, the instance is 1 in 1 lakh. And pertaining to anesthesia, the most common etiology is direct needle trauma to the spinal cord or injection of any foreign substance into the subarachnoid space. In the past, then local anesthetic, chlorprocaine was ester local anesthetic, chlorprocaine was used intrathecally. There was development of adhesive arachnoiditis, cauda equina syndrome, and also there was development of, in some cases, permanent paresis. It was thought that it was related to the low pH and the antioxidant sodium bisulfite, which was used as preservative in this local anesthetic. Another unique feature with the spinal cord is the anterior spinal cord is supplied by single and tenuous arterial blood supply, the artery of Adamantines. Due to this, intraoperatively, if there is profound hypotension, mechanical obstruction, vasculopathy, or hemorrhage, this leads to ischemia of the spinal cord. So, whatever functions are carried by the anterior spinal cord, like motor function and sensory function, they are lost. And paraplegia might occur with neuraxial blockade. But there will be sparing of proprioception as this is carried by the posterior column. So, how do we deal with this? How do we prevent this? We have to prevent profound hypotension during the neuraxial block, and any mechanical obstruction or vasculopathy should be avoided, and hemorrhage should be evacuated. Epidural hematoma. This is one dreaded complication we talk about in patients who are on anticoagulants most commonly nowadays. The incidence is less than 0.6 per 10,000, and this occurs with bleeding within the vertebral canal, leading to ischemic compression of the spinal cord. This leads to the neurological deficit. If not recognized and evacuated immediately, the neurological deficit becomes permanent. The risk factors who may land up in epidural hematoma or in cases where there is difficult or traumatic needle or catheter insertion in patients with coagulopathy, female gender is more prone, and elderly age group is more prone. So the presentation, they present with radicular back pain, the neuraxial block doesn't wean off, bowel and bladder dysfunction. So we have to go for an MRI and diagnose it, and we have to promptly evacuate on emergency basis so that the deficit does not become permanent. Cauda equina syndrome. This is another emergency which we see. Cauda equina syndrome, when coming to the etiology, in this, first of all, the lumbosacral roots are more vulnerable. And coming to the etiology, spinal catheters, which are less than 24 gauge, are implicated. And spinal anesthesia is also implicated in this. And spinal hemorrhages, if occur, either subarachnoid, subdural, or epidural, they are also implicated in the causation of Cauda equina syndrome. There are two types of onset, acute and chronic. Acute within 10 hours, which is an emergency, and chronic, it develops over weeks or months. Mechanism, how does it happen? It might be because direct exposure to large doses of local anesthetics, or high concentration of local anesthetics, or prolonged exposure by the catheter leading to pooling of the local anesthetics. What are the red flag signs? Urinary retention is the most common symptoms, which in turn leads to urinary or fecal incontinence and saddle anesthesia, a sensory disturbance involving the anus, genitals, and the buttock region. And weakness or paralysis may be there, affecting the lower extremities, pain in the back or legs, also known as like in the sciatica, and sexual dysfunction. If we see any of these red flag symptoms, we have to go for urgent or emergent surgery to free up the compressed nerve roots and give them the best chance of a recovery possible. So among the peripheral nerve blocks, we resort to brachial plexus block is the most common block we resort to when coming to anesthesia and analgesia of the upper limbs, surgical anesthesia and analgesia of the upper limbs. Basically, I just want to recap the structure of a peripheral nerve. There are fascicles containing axons, which is surrounded by the endoneurium, and which in turn many fascicles are many in between. Fascicles are intertwined by perineural septae, and all these are compactly covered by epineurium. So coming to classification of peripheral nerve injuries, neuropraxia. Mostly this is seen in position induced peripheral nerve injuries, type 1. Local myelin damage with the nerve still intact. This is what we see most commonly in position induced nerve damages. Axonotmesis, that is crush injuries, type 2. The continuity of the axons is lost. The endoneurium, the perineurum, epineurium, they remain intact. But loss of continuity of axons with Valerian degeneration due to disruption of the exoplasmic flow is seen here. Type 3 is type 2. There is no in type 2 there is no injury to endoneurium. Here there is type 2 with endoneurial injury. Type 4 is type 2 with endoneurial and perineural injury, but with an intact epineurium. Type 5 neurotmesis. It is complete transection. It is complete physiological disruption of the entire nerve trunk. This needs early surgical intervention, and the prognosis is guarded. I just want everyone to know the classification so that we can talk about the treatment and management later. So, as we all know, brachial plexus block is very routinely used for operative anesthesia and pain control of the upper extremities. And as per the research, during the brachial plexus block, the relative incidence of neurological dysfunction is more common in interscalene blocks than in axillary blocks. That is, it is 4% and it is 1% in case of axillary block. And also, brachial plexus injuries occur during vessel puncture, which we do very commonly as anesthetists. We do central venous catheterizations, like subclavian or jugular venous catheterizations. They also occur during the course of these cannulations. And sometimes when femoral root is not available, axillary arteriography is used for diagnostic or therapeutic purposes. Even then, brachial plexus injuries occur. These are the causes. What are the risk factors? Sometimes we resort to brachial plexus block during giving sedation or general anesthesia to the patient. This, as per the literature, increases the risk of nerve injuries. And whenever possible, we have to keep the patient awake so that he may complain of intense paresthesia and we may be apprehended beforehand so that we can take care of any neurological injury which might have occurred during eliciting of the paresthesia. So what are the mechanisms of injury? Direct needle trauma, chemical neurotoxicity, and hematoma or pseudoaneurysm or medial brachial facial compartment syndrome. Direct needle trauma, as we all know, paresthesia is a marker for a potentially traumatic needle contact. It doesn't mean that in all the patients we elicit paresthesia, they have traumatic needle contact or they will land up in brachial plexus injury. But it is one of the implicating factors. And when we resort to central venous catheterization, direct needle trauma, after repeated attempts, of subclavian vein catheterization, they lead to brachial plexus injury. When there is a misdirection of the needle, such as when it is not parallel to the coronal plane, or when the needle is placed too far laterally or too deeply, this can also cause damage to the nerves. And any anatomical variations in the brachial plexus, though we resort to all norms, they might lead to brachial plexus injury during central venous catheterization. Chemical neurotoxicity is another mode of causing brachial plexus injury. It depends on the nature of the drug we are injecting. As per certain papers, dopamine is more neurotoxic than other local anesthetics we commonly use. And when coming to the studies, extravascular injections and extraneural placement of a neurological agent causes nerve damage with focal demyelination, but it causes less damage than intravascular injections of neurotoxic agents. They cause more damage. Intravascular injections cause more damage. And the degree of damage is directly proportional to the concentration of local anesthetics, the time of exposure of the nerve to the local anesthetics. And when we commonly use supplemental epinephrine, which causes vasoconstriction, it reduces the peripheral nerve blood flow. This in turn leads to nerve ischemia and potentiates the local anesthetic induced toxicity. So what do we have to do? We cannot stop using epinephrine. We have to lower the doses of adjuvant epinephrine in peripheral nerve block. And sometimes use of an unsterile or contaminated agent and oil-based preparations may lead to a nerve injury. Hematoma, brachial plexus block, or axillary arteriography, or subclavian or internal jugular catheterization. The puncture of them, they may lead to hematoma or pseudoaneurysm formation, which in turn enlarges in size as the time passes, giving pressure to the nerve, leading to ischemic changes in the nerve. Due to the ischemic changes, even trivial injury to the nerve causes damage to the myelin sheath, leading to conduction block. And when these injuries occur, Wallerian degeneration of the nerve occurs when the nerve remains compressed for 24 hours. And axonal death scarily occurs with even much shorter period of compression. So, coming to axillary block in brachial plexus block, median nerve alone or in combination with the ulnar nerve is involved in the brachial plexus injury. Why? There is a compartment called medial brachial facial compartment in the axilla, which extends from the axilla to the elbow. Nerves at the level of the upper arm, they exit this facial compartment in the sequence from proximal to distal. The musculocutaneous, the axillary, and the radial, they exit the compartment. But the median and the ulnar nerves, they travel within the compartment up to the elbow level. So when a hematoma forms, it compresses the nerves in this compartment. So the median and the ulnar nerves are preferentially involved if there is a hematoma within this compartment. So symptoms. First of all, when we elicit history, the patients give a history of painful paresthesia during the block procedure. And symptoms, they range from minor transient pain to severe sensory disturbance or motor loss with poor recovery. And a direct injection into the nerve, the patient gives a history of immediate severe pain radiating distally down the limb. And there will be neuromotor or sensory dysfunction in the distribution of this nerve. The patient may continue to complain of pain, paresthesia, or weakness on the affected side even after you remove the needle or the catheter. Hematoma, which is formed by the injury, the symptoms may be delayed because the hematoma has to expand to such a size that it compresses the nerve. So it can occur after hours or days. It might present with only mild numbness and tingling sensation, or the pain may be present in the majority of cases, which is shooting or burning in sensation, and it is exacerbated by pressure or touch. Chemical toxicity. of the local anesthetic, it leads to injury in small fibers. When small fibers are involved, neurosensory loss to pinprick, hyperalgesia, hyperesthesia, paresthesia, and disturbed sympathetic innervation. These are the symptoms they present. When it is due to hematoma formation causing excessive pressure, there will be injury in large fibers, leading to motor power disturbance and loss of touch or vibration sense. So we can differentiate whether the small fibers are involved or the large fibers are involved in this injury. So, what are the investigations we take up when we have to go for an investigation of a brachial plexus injury? The nerve conduction studies and EMG. They are complementary to each other and they help us to determine whether a lesion is complete or incomplete, to determine the basis of the clinical deficit, to localize the lesion, and define the severity and age of the lesion. And we can also know the prognosis and we can guide prognosis and the course of recovery. When the problem is prolonged, we can also go for 3 Tesla MRI to identify and confirm the site of the lesion. And nowadays, high resolution ultrasound is also proposed as an adjunct to electrodiagnosis. How do we manage? First of all, the management is individualized, depending on the patient's injury site, degree of damage, the lag period between injury and repair, the age, and also the occupation of the patient. When coming to neuropraxia or lesions which can be managed conservatively, if the lesions are in continuity and are non-degenerative, or if the fascicles are intact, we can resort to medications like opioid and non-opioid analgesics. To control acute neuropathic pain, we can go for antidepressants like tricyclic antidepressants, anti-epileptic drugs like gabapentin, phenytoin, and membrane stabilizers like intravenous lidocaine, ketamine and systemic glucocorticoid for decreasing the inflammatory reaction can also be used. But in spite of using all these drugs, interim physiotherapy has to be immediately initiated to prevent atonia. Galvanic stimulation to the affected muscles and nerve ganglion blocks are reported to provide symptom relief. When the cause is a hematoma, we have to promptly evacuate it. Surgical intervention, if sensory and motor disturbances persist, even with a severe degeneration or even with conservative treatment, if they persist, we have to go for a surgical intervention. And while going for surgery, when we can assess by intraoperative examination of the nerve action potential, if the action potential is preserved beyond the injury, it means there is preserved axonal function and we can think of good recovery. If there is no action potential beyond the injury, then we can think of bad prognosis and we can think of poor recovery. Most commonly, preganglionic injuries are usually treated with nerve transfers, and postganglionic lesions are treated with resection and repair or nerve graft. Prevention is the best cure in anything. Prevention, how do we prevent it? First, we have to have a comprehensive knowledge of the anatomy, and we have to have added skills. And whenever possible, the patient should not be heavily sedated because he will give us a good history of painful paresthesia. And ultrasonic guidance, we take nowadays, most of the blocks are performed with ultrasound guidance. But they definitely improve the success rate and reduce the block-related seizures. But there is a query whether they really reduce the incidence of neurological sequelae. And when coming to central venous catheterizations, percutaneous catheterizations of the internal jugular vein are relatively safer than the subclavian vein. Coming to the general anesthesia. we have to only look for signs suggestive of neurological injury during general anesthesia. And what are they? They are delayed emergence, variation in the size of the pupils, gross hemodynamic fluctuations, and absence of gag or carinal reflex on suction. So these are the heads which I'm going to deal with. Intraoperative brain bulge. We always have a complaint from the neurosurgeon during neurosurgery that there's a bulge. So this is one of the emergency which we encounter intraoperatively in the neurosurgical theatre. We know that ICP is nothing but pressure in the closed cranium. So when there is the greater the volume of the intracranial contents, the higher the ICP and vice versa. Elevated ICP, correlates with increased clinical brain swelling after dural opening. So, what are the simple measures we resort to for improving brain relaxation? First of all, hyperventilation, and first of all, we can go for a head-up tilt, then hyperventilation, and we can use drugs like mannitol, hypertonic saline, and furosemide, a diuretic, and we can switch to IV anesthetics instead of the inhalational anesthetics, and the surgeon might resort to CSF drainage, and steroids are useful in tumor edema and not in any other reason for raised ICP. So these are all the measures we take when we encounter raised ICP leading to brain bulge. Coming to delayed emergence. This can be defined as failure to regain consciousness within 30 to 60 minutes of stopping sedation or any type of our drugs. So when we very commonly encounter with this situation, when we encounter, what are the conditions, factors we have to consider? First of all, the age of the patient, any comorbidities, how was the patient's pre-op conscious level, and what was the duration and the nature of the surgery, and what were the anesthetic drugs used. We have to assess the patient by physical examination first, and we have to review the anesthetic records for any underlying cause. And during the delayed emergence, we have to give a support to the ABC, that is airway, breathing, and circulation. The first investigation we have to go for is ABG with electrolytes, and if it further the delayed emergence progresses, we have to go for a CT brain or EEG study. Suppose we have some reasons seen in the ABG report, we have to treat those causes, like we have to treat the metabolic disturbance if any, and if there is any chance of dosage of opioid or benzodiazepine during the intraoperative period, we have to resort to antidotes for these group of drugs. Emergence delirium is another emergency we see during the recovery of children. More prone are male preschool children who are undergoing ENT surgeries with sevoflurane or desflurane anesthesia. The predisposing factors are there will be preoperative anxiety of the baby, there will be history of parental anxiety also, and also the child temperament adds to this the risk factors. The symptoms we see are agitation, hyperactivity, confusion, failure to recognize people and surroundings. So how do we prevent? First of all, by counseling of the patient's parents, the child, if the child is elder enough to listen to us, and this alleviates all the anxiety of both of them. And we can go for drugs like midazolam and propofol, fentanyl, clonidine, dexmedetomidine, and gabapentin. These are the drugs we use. But prevention is the best cure. So we have to resort to counseling when we see apprehensive patients beforehand. Stroke. First clue to clinical suspicion of perioperative stroke is difficulty in awakening from anesthesia. So, what are the surgeries which are more prone to cause this? Cardiac surgeries and vascular surgeries. So, let us look at perioperative stroke risk mechanisms and management in this slide. What are the patient risk factors? Advanced age, smoking, prior history of smoke, the patient who has atrial fibrillation and other medical comorbidities like the kidney diseases, diabetes mellitus, and all these. So they are patient related risk factors. When coming to the procedure related risk factors, any vascular surgeries, cardiac surgeries, the neurological surgeries, when we hold anti-platelet drugs for a prolonged period of time, or intraoperative hypotension. So, we have to think that they are more at risk of stroke, post-operative stroke or perioperative stroke. So how do we manage it? First, we have to stratify. We have to go for risk stratification, and we have to plan anti-thrombotic drugs. And intraoperatively, we have to maintain perfusion and we have to avoid emboli. And post-operative management is periodic assessment of the conscious level and of the patient post-operatively. And if we detect the stroke, we have to consult the stroke specialist and give an early treatment. Post-operative visual loss, it is rare but devastating. This is again seen in cardiac and posterior spinal surgeries. When in prone position, there is a chance of developing of intraocular compartment syndrome. This leads to insufficient perfusion of the optic nerve, leading to ischemic optic neuropathy, which comprises 90% of the cause for post-operative vision loss. Central retinal artery occlusion comprises 6%, and which is embolic in nature, as in cardiac surgeries, and other causes are 4%. When we are going for a high risk patients, we have to counsel them, or we have to take consent, talking to them about the possibility of post-operative vision loss. We have to monitor arterial pressure, CVP in high risk patients. We have to use both colloids and crystalloids in order to maintain the intravascular volume. We have to keep monitoring hemoglobin or the hematocrit. And mainly, what's in our hands is we have to position the head at or above the level of the heart, or at least in neutral and forward position when possible, when resorting to spine surgeries. And we have to avoid direct pressure on the globe. We have, when there is a prolonged spinal procedure going to be taken up in high risk patients, we have to plan to stage these spine procedures. Positioning and peripheral nerve injuries, they are regrettable and preventable complications of positioning. These are pictures showing various positions and different pressure points, leading to compression of various nerves and various points. So as I have already dealt with in detail the brachial plexus injury, the same symptoms they provide with. The problem here is with positioning, mostly we position the patient after giving anesthesia. So whenever there is an abnormal movement of the limb or extensive movement of limbs, he won't be able to warn us of pain because he is already anesthetized. So the early warning symptoms of pain with the normal spontaneous repositioning is absent in these patients. So ulnar neuropathy is the most common lesion in position-induced injuries, followed by brachial plexus. And in lithotomy position, sciatic nerve and the common peroneal nerve are the most common ones injured. In lower abdominal surgical procedures with excessive retraction, femoral or obturator nerves are involved, leading to obturator neuropathy in case of difficult forceps delivery, and femoral neuropathy in cases of lower abdominal surgeries, leading to loss of sensation and motor deficits in the areas they innervate. So, what is the first thing we have to think about? prevention is the best cure here. By padding the pressure points and by preventing excessive movements of the limbs and abnormal positioning of the limbs. And I just forgot to include tourniquet-induced injury. Tourniquets are very commonly placed in upper limbs and lower limbs. In upper limbs, when tourniquets are placed lower down in the arm, there's a chance of radial nerve getting injured, leading to wrist drop. So the most good intervention we have to do is we have to place the tourniquet in the upper part of the arm where there's more muscle bulk, not injuring the nerve. And secondly, we have to limit the duration of the placement of the tourniquet to the minimum possible. And also usage of hydraulic tourniquet or the pneumatic tourniquet is better than using manual tourniquet, so that the pressures can be fixed by us, the specialists, taking into consideration not to have excessive pressures in the tourniquet. And without forgetting, in many a times it happens, we have to remove the tourniquet after the procedure is done. These are my references. Thank you, sir, for the opportunity.
Thank you, ma'am, for your inspiring presentation. Now the session is open for any queries or discussion.
Madam, good morning. Regarding thoracic spinal, how much we have saved to give the thoracic spinal?
Thoracic spinal, what is the volume?
What not volume, madam? How much we have saved? How much percentage we have saved? Or what is the, if injury was there, how I should follow the case? Patient complaining of weakness both lower limbs after I give thoracic spinal. How should I follow the case in the post-operative?
First of all, when coming to thoracic spinal injury, injury during thoracic spinal, we have to go for, as I have already said, the electromyographic studies involving the muscles which are involved in the weakness. And also, in order to know the level of the injury, we can go for MRIs. We can go for MRIs, and we can also go for nerve conduction studies. If it is because of the spinal cord injury, okay, if it is because of the spinal cord injury, we have to look for any hematoma formation also. And next, when coming to nerve conduction studies and electromyograms, they help a lot in identification or localization of the site of lesion. Because it is in thoracic spinal you're talking about and lower limb weakness, yeah, we have to go for nerve conduction studies and electromyograms only there. And also any seepage of hematoma into the lower segment should be looked for by MRIs. Any compression caused by hematoma formation because of bleeding and accumulation of the blood or hematoma formation should be looked for and evacuated immediately.
What if I give preservative-free drug? We have to give in the brachial plexus block, ma'am. If I accidentally give preservative drug at the brachial plexus block, like prednisolone or ketamine, neostimin, preservative drug.
Preservative.
What is the fate of the patient? Any injury?
Yeah, that is what I have spoken about in cases of chemical neurotoxicity. That is what I have dealt with. Chemical neurotoxicity. Actually, when we resort to intrathecal drugs, there is no preservative, right? And when coming to local anesthetics like lidocaine and bupivacaine, which we use in peripheral nerve blocks, there is methylparaben. Okay, but yeah, when it comes to chemical neurotoxicity, again, as I have said, we have to go in the line of chemical brachial plexus injury or anything in the line of the as one of the reasons for the brachial plexus injury. We we have to go for EMG and all that, and there is no antidote for the preservative which you have injected in for the brachial plexus. There's no such antidote or anything. There are no studies saying that an antidote can be given and you can reverse the preservative which you have injected to the brachial plexus. There's no such study saying that.
Thank you, sir. We sincerely thank ma'am for her insightful and inspiring presentation. Now, I would like to request ma'am to stay back on the dais, and I would like to request Dr. K. Sudhi, sir, Academic Director, GEMS, to kindly felicitate ma'am with a memento as a token of gratitude. Moving forward, now we would like to take the privilege to invite all our esteemed dignitaries to kindly come forward and grace the dais to start the inauguration program. First, I would like to request our head of the department, Dr. DVG Sankar Rao, sir, to kindly come on the dais. Next, I'd like to call Dr. B. Murli Krishnan, sir, Professor and Head of the Department, Emergency Medicine, GEMS, and our APMC observer for our CME today. Then I'd like to call Dr. K. Sudhi, sir, Academic Director, GEMS, to come upon the dais. Now, I would like to call upon Dr. V. Rama Rao, sir, PG Academic Coordinator, to kindly grace the dais. Lastly, but not the least, I'd like to call upon Dr. S. Sridhar Reddy, sir, Chief Operating Officer, GEMS, to kindly come on the dais.
To mark the beginning of today's CME, it is our privilege to commence with a light lampening ceremony, a tradition that symbolizes the dispelling of ignorance and illumination of knowledge. May I now respectfully invite our esteemed dignitaries to kindly come forward for the light lampening ceremony.
आरोग्यं धनसम्पदः शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्
Thank you, everyone. Now I'd like to request Dr. Subbalakshmi ma'am to also kindly grace the dais. Now, it is my honor to invite our HOD sir, Dr. DVG Sankarao sir, to address the gathering with a welcome speech. Sir, please.
Dignitaries on the dais, Dr. Sudhir Garu, Dr. Murali Krishna Garu, Dr. Sridhar Reddy Garu, Dr. Ramada Garu, Madam Subbalakshmi Garu, dignitaries of the dais, their faculty, and energetic PGs from all colleges. Namaskar to you all. It's my privilege and honor to invite you all for this great occasion. At the outset, I would like to thank our GEMS management and the administrators for their support, full support for this function to happen. Now, CME program on a holiday, it's a hard choice for you. Maybe hard choice, but not a bad choice. Of course, it's not a choice, it's mandatory now. Continuing medical education is lifeline for us. As like any other branch of medicine, our anesthesiology is progressing at very high speed. When I was PG, Dr. Murali Krishna sir, our observer sir was my first guru. He welcomed me to the department and he made me to put the tube, EDT tube first time. I'm very happy to have him here also. 2 decades ago, when we were PGs, when we go to hostel, all the hostelers used to say, "Oh, how is ENT OT?" I thought, and I asked them, "How do you know I am from ENT OT?" They used to tell, "You are smelling like a ether." Giving either. We have become a bottle, either bottle. We smell like that. If we stop there, if I am expert in ether giving anesthesia, I would have been forgotten, just like ether. And as to develop interest in upcoming updates, now it is very fast moving. Today's progress, tomorrow's passé. This much of pace is not expected anywhere. And this CME is not just a routine affair. a proper thinking and how to make it useful for the PGs are taken into account. And we had a great lecture by Subhalakshmi Madam and Sriza. Madam represented the routine and everyday problems of us, and Sriza told us about the genomics and everything. After the inauguration, we will have some inputs on artificial intelligence also. So I think it will be very good feast of academic activity. I think you will enjoy it, and not only to create hours, you will get knowledge, and it must be an interactive session. And I think with these words I can conclude. Thank you.
Thank you, sir, for the energetic speech. Now, kindly request Dr. B. Muralikrishna, sir, Professor in HOD of Emergency Medicine, to kindly address the gathering.
Dignitaries on the dais, Professor in HOD of Anesthesia, Dr. D.V.G. Shankar Rao Garu, and Dr. Professor of Medicine, and the main chief anchor of this hospital, James Medical College, and other dignitaries on the dais and off the dais, and my dear postgraduate students. And we all know the importance of regular continuous medical education. So more than any other department in our medical department, and this type of regular interactive sessions, be it a one-day CME or conference, they are very essential to brush up our knowledge. And in our hospital, we regularly conducting all such one-day CMEs, whether as a protocol of university or not, have been regular, and everybody is getting the 2 credits and as well as lot of imparting medical knowledge. And under the guidance of Dr. D.V.G. Shankar Rao Garu, and he is so humble person, in spite of his achieving accolades, he is so simple, yet he is very effective. And I expect a lot of students will learn more knowledge and academic activities, as well as more skill-oriented knowledge. People, postgraduates will going to learn. This is what I believe and what I expect, and I really very happy to see my students like Shankar Rao and Dr. Subhalakshmi. They are in limelight in the present day CME. Thank you very much. Thank you all.
Thank you, sir, for also coming as the chief observer for today's CME. Now, I would like to request Dr. K. Sudhir, sir, Academic Director, CHIMS, to kindly address our gathering.
Respected Head of the Department of Anesthesiology, Dr. D.V. Shankar Rao, and my good friend Dr. Muralikrishna, and my colleague Dr. Sridhar Reddy, and Dr. Ramarao, and all the speakers and all the delegates who are attending this evening. I bring all my best wishes and pleasantries from our management and administration for conducting a great and successful CME today. And first of all, I want to congratulate the team of the anesthesia department, led by a very soft-spoken, Dr. Shankar. I think he doesn't need an anesthetizing agent. Only his mesmerizing smile is enough to anesthetize people, isn't it? Such a very wonderful HOD you have. And you have selected, the team has selected a very relevant and important topic today. That is critical insights into perioperative anesthetic complications. Really, there is a challenge to the anesthesiologists. So, why should we have this topic? See, after passing MD, everybody becomes a good anesthesiologist, everybody a good professional. But how to differentiate from one to the other? How is one is superior to the other among all the good anesthesiologists? There comes this topic. Who can handle the complications well? Who is confident in dealing with any sort of situation, any problematic case? He will definitely be branded as a superior anesthesiologist, isn't it? So how can we become like that? Everyone should aspire to become an anesthesiologist of that cadre. How do you become? First of all, we need to know what are the complications. We need to acquire the knowledge. When you acquire knowledge, and how do you acquire? Every day your faculty says, go and read, but you will never read. There must be a triggering point, and those triggering points are the CMEs. At least you will be forced to learn something about those particular aspects. And you will be acquiring, whether you like it or not, you will automatically acquire some knowledge about it. That should trigger your intention, your zeal to become a better anesthesiologist by acquiring the knowledge. Once you acquire knowledge, is not enough. Once you have knowledge, you will start finding problems in your field. When you are in action, you will find the problems and you will understand them with your knowledge. Once you have knowledge, then you start seeing them, you start learning to handle them. Once you handle them, you will become skillful. That makes you a better anesthesiologist among a big lot of good anesthesiologists. So these CMEs are necessary, especially in the present days. It is very, very necessary. That's why the university has brought back all the CMEs again after a gap of some years when we just stopped. So I hope all the young and dynamic anesthetic students of anesthesia will get benefited from this CME and use them purposefully. Please don't waste your time here. At least on this day, if you focus your attention on this topic, definitely it will enhance your knowledge level and it will make you it will make yourself a better anesthesiologist. So please get benefited from this delightful and very useful CME. Wish you all the best. Thank you.
Thank you, sir. Now I request Dr. V. Ramana, sir, PG Academic Coordinator, to kindly address the gathering.
Respected HOD Sangarrao garu, Academic Director Veer garu, COY Reddy garu, and others, dear friends. Basically, I am a bottom surgeon and a gynecologist. We are in the middle era. I have seen bad anesthesia, fast surgery, or little anesthesia, fast surgery. From them, and if you go back to the ancient things, the tribals used to impregnate the anesthetic agents to the arrow and used to anesthetize the animals when they are hunting. That is the reason why it is called deep tube corale. Deep tube. They used to keep the arrows in the tubes. From there onwards, there is so much evolution in the anesthesia. We have seen with our own eyes. So now the anesthesia is developed leaps and bounds. And the patients also, the awareness also increased greatly. I worked in muscle areas and I used to give spinal anesthesia. If I could not get spinal anesthesia, I used to give local and used to do severe and hysterectomy. So those are the days. Now everybody wants comfort. Even tuberculosis we used to do under local. Hundreds of thousands of tuberculosis were doing. But now the patient wants painless things. Even deliveries, they want painless deliveries. So the role of anesthesia increased dramatically. But the thing is, we want a safe anesthesia. We don't want complications in the hands of anesthesia. They may agree some complications during surgery, but they may not agree anesthesia. So that is a word of warning. So I advise you, another thing is a lot of comfort is there for you. When we are operating, there was no AC rooms. We used to have a spec pad and we used to do surgeries. Sometimes, if the power is not there, there were days where we have operated on candle lights. I'm not exaggerating the things. So there's so much safety and comfort is there for the surgeon as well as anesthetist. So there was very rarely we used to get mobile operators, the government hospitals. So now everything is now furnished and investigative procedures also there. So this is the important thing. So the anesthetic people will have to understand. And another thing is, I want to give a piece of advice regarding counseling of the patient. The counseling must be given by a senior doctor, not by a junior PG. I have seen here the junior PG, first year PG will tell, he will be dictating all the complications of the textbook. You will die finally. So that he will run away. So these things, you must know the knack of giving a counseling, pre-anesthetic counseling and other things. So I hope you will understand the problem. Another thing is, country needs more anesthetists. We have lack of anesthetists. Sometimes, we were waiting for anesthetist. Suppose every taluka, not even one anesthetist is there. So we have, suppose I want to do a cesarean section. I must know whether he is available or not, he or she. So such is the thing. We need more anesthetists and safe anesthetists. That's why I advise you to enrich your knowledge and update your knowledge and practice safe anesthesia. Thank you.
Thank you, sir. Now I would like to request Dr. S. Sridhar Reddy, sir, Chief Operating Officer, GEMS, to kindly address this gathering.
Respected dignitaries, faculty, postgraduate students. First of all, I want to congratulate the Department of Anesthesia of GEMS Medical College who has organized this zonal CMA. I have 2 points to talk about here. The point number 1 is continuous medical education. We don't see continuous engineering education, continuous law education, or any other things in the society. Why only continuous medical education? Why only doctors are penalized with continuous medical education? There's a reason for it. If the engineer doesn't know his or he doesn't upgrade, he is out from the business field. The lawyer is out from the business field. But if he doesn't know, the patient is out from the earth. So there is a difference there. The service provider is out, here the client is out. That's why the government has enforced, or the society has enforced, or university has enforced this continuous medical education on us. And the other reason is the drastic change what is taking place in the medical field. To cope up with these drastic changes, a continuous medical education is always necessary. These changes were there even in the past when I was a postgraduate. So that's why always I envy the PGs at present because they are getting this opportunity and we never had this opportunity. You should be a lucky people. The other thing it is, most of the time whenever we say continuous medical education of a particular department, per se, let us say the anesthesia department or the other departments thinks, okay, it's anesthesia department, we doesn't require it. So this what we are doing, it is we are studying human being by speciality, not as a human. Why this continuous medical education, especially of today's such a perioperative topic, is so important? It's important for general medicine people, emergency medicine, critical care, even any other clinical people can come and participate. But most of the time they sign and go off, which is not right. And at the end of the day, most of the time I say that the continuous medical education is not just for the medical faculty, even person like me who's an administrator. Of course, even I come from a medical faculty, it might not be your specialty. My specialty is different from forensic. But when I was listening to Madam on pharmacogenetics, immediately thought came to my mind, implementation in India. She was talking about only, sir, it is very highly costly. But I was thinking into the legal aspects of it. అది ఇంప్లిమెంట్ అయితే మొత్తం ఇన్సూరెన్స్ కంపెనీస్ చేంజ్ అయిపోతాయి. వాడు ఒక క్లాస్ పెడతాడు దాంట్లో ప్రీ ఎగ్జిస్టింగ్ జెనెటికల్ కండిషన్స్ ఆర్ నాట్ కవర్డ్ అని. మేడం ఈ స్క్రీనింగ్ చేసి ఇది ప్రీ ఎగ్జిస్టింగ్ జెనెటికల్ కోడ్ అని చూపించేస్తారు, మనకు రూపాయి రాదు. So I was thinking into some other aspects, so that immediately triggered me also. So always when we attend CMEs and all that thing and we try to listen to the people, we get a thought. Everyone get a thought in their own aspects. I got the thought in my own aspects because I was into the administration. The other people get into their own aspects. So my request is, utilize the opportunities of these CMEs. Don't miss any CMEs. And one day CM is equal to at least your 3 months of academic activities what you have in your own colleges. Because they have the faculty coming from other colleges and teaching. And almost, and I was also saying with Ashok sir, the advances in medical field of a question cover up అయిపోయింది కదా మేడం చెప్పింది exam కి అని. So even one exam question is covered. So I request all the postgraduates to actively utilize these programs, and even in future please don't miss zonal CMS wherever they are going on. Thank you very much.
Thank you, sir. Now I request Dr. TDP Subbulakshmi ma'am, Professor GMC Shitokulam to connect address the hearing. Respected TDPs on the dais, respected faculty and postgraduates, good morning to everyone. Medicine is a field where we need to learn all through our life. And more so when we talk about anesthesia, this is an evergreen learning subject. Because every case we face every day is unique in its own way. Because the patient differs, the individual differs from, everything differs. The response of the patient differs from individual to individual, even though they undergo the same procedure. So it's an evergreen learning subject. I'm talking only about anesthesia because my subject is that, but it holds good for any other subject too. So when we go to the theaters, we learn the clinical aspects and from the scenarios, and we will learn how to deal with different scenarios associated with the patients. But when it comes to the CMEs, we will learn the theoretical basis of each and every condition we encounter in the clinical scenarios. So I wish all of us a happy learning in these zonal series. Thank you.
Thank you, ma'am. Now, we would like to felicitate Dr. V. Muralikrishna sir, our APMC observer for the day. I would like to request Dr. Subbulakshmi ma'am to felicitate sir with a memento. And also, I'd like to request our HOD sir, DVG Sankarao sir, to felicitate with the shawl.
Now we'll have a short break for tea and refreshments. Please kindly proceed to the refreshment area. We request you.
అయినా కోసం కింద టమాటో తీసుకున్నాను. కింద ఉందా? ఇస్తున్నాను. నేను అనుకుంటే వాటితో
లేదా ఇందులో చేసుకుంటాను. you take it faster. So again, within the we have WPS officer. That's why it's is there. Again now. అయిందా bro? నెక్స్ట్ ఎలిస్టేషన్ దానికి మ్యూజిక్ రెడీ చేస్తున్నాం. నెక్స్ట్ అశ్విని మ్యామ్ ఏమైంది బ్రో? అంటే ఇలా ప్రెజెంట్ చేస్తే పాయింట్స్ వస్తాయి. నాదేంటంటే ఇది ఇచ్చాను నాకండి మీరు పైన ఎలా ఉంటుంది?
Everybody, please gather inside. The session is going to get started.
We request everyone to kindly gather so that we can resume our academic session as scheduled.
I don't want. ఎక్కడ తెలుసు వచ్చింది
Welcome back, everyone. Now, I would like to request Dr. TDP Subalakshmi ma'am to kindly come on the dais, and I would like to request HOD sir, Dr. DBG Sankarao sir, Dr. Pradeep sir, Dr. Venkatramana sir, and Dr. Hemasundram sir to kindly come on the dais to felicitate ma'am. So please. Ranganath sir, please come on the dais. I request him also.
I heartily thank the GEMS Srikakulam team for this kind gesture. Thank you so much. Thank you, ma'am. Now we'll move into the next academic session. Now we'll have a presentation by Dr. G. Ashwini, ma'am. Now I request her to come on to the dais for her presentation on the topic perioperative organ dysfunction, anesthetic rolling disc reduction. Dr. G. Goli Ashwini, ma'am, currently working as a senior resident in MIMS Vizianagaram. She has completed her undergraduation from NRA Institute of Medical Sciences, Tagrapolsa, and her post-graduation from Deen Dayal Upadhyay Hospital, New Delhi. Her areas of interest are critical care medicine. Good morning, everyone. I'm Dr. Ashwini, faculty from MIMS. So today I'm going to speak about the perioperative organ dysfunction and anesthetic role in risk reduction. So in this I'll be going to discuss about the definition, epidemiology and clinical importance, complications and role of anesthetic in risk reduction. In this I'll be going to discuss about the cardiovascular system, respiratory system, neurological, renal and hepatic system, and their complications and role of anesthetist in risk reduction. Perioperative organ dysfunction. It is defined as the inability of a given organ to perform its functions in a reversible or irreversible manner, leading to altered homeostasis. This requires clinical interventions or life support to maintain its normal physiology. Perioperative organ dysfunction will lead to prolonged hospitalization, increased perioperative morbidity and mortality, and direct impact on health disease process of surgical patients. So in this whole, I'll be going to discuss about the how organ dysfunction will be going to happen. Organ dysfunction will be going to happen due to demand and supply mismatch, susceptibility to the infections, biochemical injury, biophysical injury, and coagulation abnormalities. Demand and supply mismatch will be occurs due to hemodynamic changes like increasing in the heart rate, increase or decreasing in the respiratory rate, decreasing in the cardiac output, hypovolemia and blood loss will lead to demand and supply mismatch, and this will lead to decreased organ perfusion, and this will lead to organ dysfunction. Coagulation abnormalities like platelet dysfunction, coagulation, increase or decreasing in the coagulation factors, increase or decreasing in the fibrinolysis, increasing or decreasing in the blood viscosity will lead to coagulation abnormalities, and this will lead to the organ dysfunction. Biophysical injuries like mechanical ventilation, cardiopulmonary bypass pump, laparoscopy, increased shear forces, increased tissue overdistension, increased intracavitary pressure will lead to biophysical injury, and this will lead to organ dysfunction. Immune activation due to surgical injury, ischemic reperfusion injury, increased cytokine levels, increased complement activation, increased immune cell recruitment will lead to biochemical injury, and that will lead to inflammation and edema, and that will cause organ dysfunction. Neuroendocrine activation due to pain, anxiety, metabolic changes, hypothermia, increased cortisol, and increased catecholamines will lead to organ dysfunction. So in this diagram, I will be going to show what common complications will occur system-wise. Neurologically, we will see postoperative delirium, postoperative cognitive dysfunction, major adverse cardiac events will occur due to prolonged vasopressor usage, heart failure, postoperative atrial fibrillation, myocardial injury after non-cardiac surgery, hepatic we will see acute liver failure, endocrine we will see hyperglycemia. Pulmonary complications commonly we will see are severe acute respiratory syndrome, non-ARDS lung injury, postoperative pulmonary complications, renal we will see acute kidney injury, gastrointestinal we will see ileus, mesenteric ischemia, and gastrointestinal bleeding. Coming to epidemiology and clinical importance, the four most common causes of death are cardiovascular disease, cancer, cerebrovascular disease, and organ dysfunction. Organ dysfunction is the major cause of perioperative death. Early identification of high-risk patient is essential for tailored anesthesia management, organ protection strategies, and improved clinical outcomes. Epidemiology of intraoperative complications. Anesthesia is considered a highly safe specialty. Reported complication rates: minor 1 in 5 cases, major 1 in 100 cases, death 1 in 1 lakh people. Perioperative complications may arise from surgery, anesthesia, or their interaction. Global surgery volume is around 300 million procedures per year. Key risk factors are ASA status, comorbidities, age, emergency surgery, and extent of surgery. Elective inpatient surgery mortality within 1 month will be 0.5 to 4%. Daycare surgery mortality is less than 0.1%. Epidemiology of post-operative complications. Complications after elective inpatient surgery occurring 20% of the patients. Unscheduled emergency surgery mortality is higher. After emergency laparotomy, it will increase to 10 to 20%, especially in patients of more than 8 years of age group. Elderly, trial, and comorbid patients have greater susceptibility to the complications and physiological stress. Complications increase hospital stay, resource use, and overall morbidity. Coming to cardiovascular complications, The most common complications we will see intraoperatively and postoperatively are myocardial ischemia and infarction, myocardial injury, hypertension and hypertension, arrhythmias, stroke and vascular complications, venous thromboembolism and air embolism. Myocardial ischemia and infarction. Imbalance of myocardial oxygen supply and demand. Factors which decrease the oxygen supply are coronary perfusion pressure, arterial oxygen content, coronary vascular resistance, and tachycardia. Factors increasing the oxygen demand are heart rate, ventricular pressure, afterload and preload, contractility, and LV hypertrophy. This is the diagram showing the determinants of myocardial supply and demand. Myocardial oxygen demand will depend on the heart rate, wall stress, and contractility. Wall stress will increase due to the pressure and chamber size. Myocardial oxygen supply will depend on the coronary blood flow and coronary arteriovenous oxygen difference. Role of risk reduction in preventing myocardial infarction and acute coronary syndrome. Delay elective surgery for unstable angina, acute coronary syndrome, or recent MI. In emergency cases, balance urgency versus cardiac risk. Avoid surgery in high-risk stent periods. If bare metal stent is there, avoid within 30 days. If drug-eluting stent is there, avoid within 6 months. May consider more than or equal to 3 months. Do not stop dual antiplatelet therapy unless essential. Restart P2Y12 as soon as possible. Bridging with IV antiplatelet anticoagulant not routinely recommended. Continue statins. Maintain beta blockers. Do not start on the day of surgery. Avoid tachycardia. Avoid and manage hypotension in recent CABG and percutaneous interventions due to risk of graft or stent thrombosis. Venous thromboembolism. Risk factors will be age more than 40 years and previous DVT, immobilization, high BMI, oral contraceptives, hormone replacement therapy, cancer, varicose veins and prolonged surgery and anesthesia, pelvic, hip and varicose vein surgery. Presentation of DVT, calf pain, tenderness, redness, swelling, pain increases with dorsiflexion called as Homan sign. Classic presentation of pulmonary embolism will be chest pain, dyspnea, faintness, hypoxia, tachycardia, hypotension, pleuritic pain and hemoptysis. ECG shows sinus tachycardia, non-specific STD changes. Chest X-ray usually normal. ABG shows hypoxemia with low PCO2 due to hyperventilation. Pulmonary embolism diagnosis is intraoperative pulmonary embolism is rare. It will present as hypoxia plus decrease or absent EtCO2 despite normal ventilation due to increasing in the death space. Investigations are non-specific. CT pulmonary angiogram is gold standard. Echo shows RV dilatation and decreased systolic function and pulmonary hypertension. Transesophageal echo may show embolus. VQ scan is less used. Coming to the treatment, airway breathing and circulation, ICU admission, anticoagulation is the mainstay. Prevent recurrence and allow clot resolution. Heparin will give bolus, then we will give infusion. Low molecular weight heparin, full treatment dose. Warfarin, slowest onset. Thrombolysis with altiplase, only for life-threatening and risk for major pain. Pulmonary embolectomy, rarely used. Role of risk reduction in preventing pulmonary embolism. Early ablation, adequate volume status, intermittent pneumatic compression, elastic stockings, heel cushion on table, stop estrogen-containing contraceptives, and hormone replacement therapy 4 to 6 weeks prior to the operation. Pharmacological prophylaxis in high-risk patients. Careful timing of regional anesthesia if patient is on anticoagulant therapy. Coming to air embolism, pathophysiology is air entry into the venous system will lead to right ventricular obstruction that will cause cardiovascular collapse. Air volume of 0.5 to 1 ml per page can be fatal. If patient is having right to left shed, for example, if patient is having patent foramen mauvais, there might be chances of paradoxical embolism and that will cause coronary and cerebral obstruction. Causes are surgical causes will be wounds above the heart level, open venous structures, procedures like neck, thorax, breast, pelvis, shoulder, brain and spine surgeries, especially if patient is in sitting position during the surgery. Laparoscopy due to CO2 embolism, there might be chances of air embolism. Anesthetic causes are IV lines open to the air or syringe disconnections. Diagnosis is sudden drop in EtCO2, that is the early sign, and sucking sound from the wound due to large entry of air, continuous precordial Milwin murmur, cyanosis, hypertension, tachycardia, raised neck veins, cardiac arrest, Doppler probe for high-risk neurosurgery. Risk reduction and treatment for air embolism are immediate airway breathing and circulation, flood the surgical field with saline, position is Durant position, that is left lateral position with head down to trap the air in right ventricle, and 100% oxygen. Aspiration of air via the central venous catheter if central venous catheter is present, and hemodynamic support. Respiratory complications, procedural complications, pulmonary aspiration of gastric contents, failure of protein airway techniques, upper airway obstruction, lower airway obstruction, postoperative pulmonary complications, obstructive sleep apnea, airway trauma, pulmonary paratrauma and pneumothorax, and airway fire and oxygen cylinder fire. Coming to the procedural complications, major contributing factors are poor airway assessment, that is difficult airway and aspiration risk often missed, poor planning and inadequate backup plans, multiple attempts at the time of intubation leads to cannot intubation and cannot oxygenation situations. One-fourth event occur at emergency and recovery, usually upper airway obstruction. ICU and EMD airway events more likely to lead to death. No capnography in ventilated ICU patients will lead to more than 70% airway deaths. Pulmonary aspiration of gastric contents. Solid food will lead to fatal large airway obstruction. Acid injury, if the pH is less than 2.5 and volume of 25 ml will lead to Mendelssohn's pneumonitis. Can progress to bronchospasm, hypoxia, ARDS, clots and death. Management is 100% oxygen, head down and lateral position, oropharyngeal and tracheal suction. Do not remove the supraglottic airway device unless necessary. Nasogastric decompression, bronchoscopy if needed. Supportive therapies with bronchodilators and physiotherapy. Antibiotics only if infection is there. Risk reduction and prevention of pulmonary aspiration. Proper risk assessment. Fasting for 6 hours for solids, 2 hours for clear fluids. Gastric ultrasound if available. Prokinetics with metoclopramide 10 mg. Acid suppression. HD blockers or proton pump inhibitors. Neutralization with sodium citrate. Avoid heavy sedation. Avoid fiber optic intubation for high risk airway. Rapid sequence induction when indicated. Second generation supraglottic airway devices if SAD is required. Extubate fully awake or lateral position. Rapid sequence induction, full pre-oxygenation, induction agent plus fast-acting relaxant, required force of 10 newtons while awake, 30 newtons once patient is unconscious. Avoid excessive pressure, this will lead to distortion of airway. Video laryngoscope improves the view and allows observing required application. Not a strategy to wake up quickly if airway difficulty occurs. Failure of protein airway techniques. Composite airway failure. If one airway technique fails, others more likely to fail. So principles are aim first attempt success, avoid multiple attempts, success is less than 20% after repeated attempts, use advanced equipment, video laryngoscopes and second generation supraglottic airway devices. Management of failed intubation, cannot intubate and can oxygenate situations. Rule of first, follow algorithm, DAS and vertex algorithms, avoid multiple attempts, use video laryngoscope early, use supraglottic airway devices as a rescue. Cannot intubate and cannot oxygen situations will be very rare, that is less than 1:5,000. High mortality due to delayed action. Immediate transition to the front of neck axis. Front of neck axis, scalpel cryptothyrotomy, which is the recommended technique. Cannula technique, 60% failure chances will be there, and there might be a chance of barotrauma with jet ventilation. Coming to upper airway obstruction, causes are loss of tone of tongue, palate, and epiglottis, foreign body like blood and vomitus, laryngospasm, misplaced or displaced supraglottic airway device, tumors, infection and swelling. Signs will be inspiratory stridor, paradoxical breathing, increased work of breathing, absent capnography, high airway pressure during the intermittent positive pressure ventilation. Management is sniffing position, chin lift and jaw thrust, oropharyngeal and nasopharyngeal airway, mask ventilation with positive P, supraglottic airway device insertion, awake fiber optic intubation for known obstruction, sitting position in awake patient, post-obstructive pulmonary edema. After relief of upper airway obstruction, patient requires ICU and supportive care. Coming to glottic obstruction, that is laryngospasm, risk factors will be children, recent upper respiratory tract infection, smokers, asthma, ENT surgery, secretions and blood in airway. Management is 100% oxygen, CPAP, deepen anesthesia planes, suction, Lassen's manual, propofol bolus of 0.5 mg per kg and scoline dose of 0.1 to 0.25 mg per kg. If spasm is not relieved, then watch for post-obstructive pulmonary edema. Lower airway obstruction causes will be bronchospasm, asthma and COPD, aspiration, pulmonary edema, pneumothorax, especially tension pneumothorax, infection, endobronchial intubation and anaphylaxis. Management will be deepen the lines of anesthesia, suction properly, IV salbutamol, magnesium sulfate, aminophylix and adrenaline. Treat the underlying cause. If pneumothorax is there, go for chest drain. Postoperative pulmonary complications. Common types are atelectasis, infection, and respiratory failure in 5 to 20% of the cases. Major risk factors are age more than 70 years and ASA grading of more than or equal to 2,
major abdominal, thoracic and vascular surgery, emergency surgery, trauma surgery, and general anesthesia. Prevention, minimally invasive surgery, avoid GI if possible, opioid sparing analgesia, epidural analgesia, early mobilization plus physiotherapy, lung protective ventilation, tidal volume of 6 to 8 ml per kg according to the ideal body weight, and peak pressures should be less than 30 centimeters of water. Obstructive sleep apnea, perioperative issues are difficult mask ventilation, difficult supraglottic airway insertion, difficult intubation. Desaturation will occur rapidly due to decreasing in the FRC, post-op obstruction, post-obstructive pulmonary edema, screening with stop time questionnaire. Score is more than or equal to 3, high risk. If score is more than or equal to 5, we'll consider it as a very high risk. Management, prefer regional and minimal sedation. Avoid opioids, use short-acting agents if general anesthesia is required. Post-op CPAP and BiPAP, enhanced monitoring with oximetry and capnography may require HDU admission. Airway trauma causes will be intubation, especially difficult airway, bougie and stylet trauma, VL blind spot injuries. Prevention, use appropriate tube size, avoid blind advancement, cuff pressure monitoring, avoid unnecessary intubation, use supraglottic airway device where appropriate. Pulmonary barotrauma and pneumothorax causes will be overdistension due to volutrauma and barotrauma. Trauma, regional blocks like interscalene block, supraclavicular block, paravertebral block, and intercostal block. CVC insertion and laparoscopy. Management, chest drain for closed pneumothorax. Inflate the lung and close pleura for open pneumothorax. Airway file and oxygen cylinder file. Airway file will contain triangle of ignition source, fuel and oxidizer. Ignition sources will be electrocautery, laser, fiber optic light source, and high-speed burst and drills and defibrillator. Fuel will be alcohol skin preparations, brakes, gowns, gauze, sponges, patient's hair and skin, and endotracheal tube. Oxidizers will be oxygen and nitrous oxide. Prevention by awareness and debriefing, wet swabs, laser safe tubes, inflate cuff with saline, minimize FiO2, and avoid nitrous oxide. Coming to neurological complications of anesthesia, inadequate anesthesia, awareness during general anesthesia, delayed recovery from anesthesia, complications of central neuroaxial blockade, complications of peripheral nerve blocks, and postoperative delirium and cognitive dysfunction. Causes of neurological complications will be surgical causes are such as hemorrhage, fat and air embolism, operative trauma, especially during the neurosurgery. Anesthetic causes will be hypercapnia, hypoxia, electrolyte and acid-base imbalance, induced hypotension, and hypothermia. Disease-related causes will be stroke, myxedema, hypopituitarism, and hyperglycemia. Postoperative cognitive dysfunction, definition and incidence, prolonged declining cognitive ability after surgery. Incidence is 10 to 40% after discharge, 5 to 12% at 3 months. Not limited to surgery, can occur after major illness. No consensus definition, underreported and misdiagnosed. Risk factors will be old age, pre-existing cognitive impairment, acute illness, major and long duration surgery. Etiology, possible mechanisms will be direct anesthetic neurotoxicity, inflammation and cytokines, and microembolism. Role of anesthetic technique, type and extent of surgery inconsistently linked to postoperative cognitive dysfunction. Avoid general anesthesia is not reliably protective. Regional anesthesia without GA sedation may decrease the delirium. Depth of anesthesia monitoring may reduce the risk. Management principles, these are supportive only, no proven treatment, focus on eliminating other causes of confusion, check for sepsis, anemia, dehydration, hypoxia, electrolyte and hyperglycemia, hypothyroidism, drugs withdrawal. Perioperative strategies, maintain physiology, oxygenation, blood pressure, glucose and temperature, maintain sleep-wake cycles, avoid deep sedation or GA where possible, use minimally invasive techniques, minimize centrally acting drugs, early mobilization and cognitive support, and early discharge home if safe. Renal and hepatic complications. General true anesthesia-induced organ failure is very rare, but patients with pre-existing disease are at high risk of worsening post-operatively. Idiosyncratic drug reactions. Renal failure will occur due to antibiotic usage. Immune hepatitis may occur due to halothane usage, and cholestasis will occur due to antibiotics. Renal and hepatic disease and anesthetic considerations. Avoid organ toxic drugs. Maintain blood flow and oxygenation. Pre-existing disease alters pharmacokinetics, that is drug metabolism and clearance, and pharmacodynamics, that is drug sensitivity. Hepatic blood flow in anesthesia effects of GA.
General anesthesia will usually decrease the hepatic blood flow, worse in case of abdominal surgeries. In chronic liver disease, portal vein flow and oxygen delivery will decrease. Normally, portal vein will supply 75% of the blood flow and 50% of the oxygen supply. Liver becomes dependent on hepatic artery, that will supply only 25% of the blood flow. This makes them vulnerable to post-operative liver dysfunction and higher mortality in severe liver disease. In chronic liver disease and anesthesia, regional anesthesia may be contraindicated due to coagulopathy. Avoid deep anesthesia, hypovolemia, hypotension, and hypoxia, raised abdominal pressure, surgical traction on the liver. Aim is to maintain stable hemodynamics and oxygenation to protect the liver function. Acute kidney injury, surgical and anesthetic concerns are incidence in non-cardiac surgeries is 5%. In cardiac surgery, it is up to 25%. Rarely caused directly by the anesthesia. High risk group will be CKD grade of more than or equal to 3 with GFR of less than 60 ml per minute. And acute kidney injury risk will increase with nephrotoxic drugs, hypovolemia, hypotension, and hypoxemia. Effects of anesthesia. General anesthesia will decrease the GFR via the decreasing in the cardiac output. MAP of less than 55 mmHg for only 5 minutes can worsen the kidney function. High risk surgeries like cardiac surgery and major vascular surgery, chances of AKA will be more. How do we diagnose and stage the acute kidney injury? By Rifle and Aiken criteria and KDIGO. In Rifle, we will consider creatinine and GFR criteria and urine output criteria. In risk, there is an increasing in the creatinine of 1.5 times of the baseline, and GFR will be decreases more than 25%, and urine output of less than 0.5 ml per kg per hour for 6 hours. In injury, creatinine will increase 2 times from the baseline, and with decrease of GFR more than 50%, urine output will be less than 0.5 ml per kg per hour for 12 hours. In failure, increased creatinine 3 times from the baseline and GFR will be decreased by more than 75%, or creatinine of more than or equal to 4 mg per dl with acute rise of more than or equal to 0.5 mg per dl. Urine output of less than 0.3 ml per kg per hour for 24 hours or anuria of 12 hours. In loss, persistent acute renal failure, complete loss of renal function for more than 4 weeks. Final stage is end-stage renal disease. In Aiken criteria, we have stage 1, stage 2 and stage 3. In stage 1, creatinine will be increased 1.5 times of the baseline or more than or equal to 0.3 mg per dl. Urine output of less than 0.5 ml per kg per hour for 6 hours. In stage 2, increased creatinine 2 times of the baseline and urine output of less than 0.5 ml per kg per hour for 12 hours. In stage 3, increased creatinine 3 times of the baseline or creatinine of more than or equal to 4 mg per dl with acute rise of more than or equal to 0.5 mg per dl. Urine output of less than 0.3 ml per kg per hour for 24 hours or anuria for 12 hours. Renal protection principles: avoid nephrotoxic drugs like aminoglycoside, that is gentamicin, NSAIDs, furosemide, AC inhibitors, starch colloids, and radiocontrast. Maintain perfusion by avoid and rapidly treat the hypotension. Maintain normovolemia and cardiac output. Ensure unobstructed urine outflow by checking the blocked catheter, urinary retention. Avoid raised intra-abdominal pressure. In laparoscopy, we have to keep the intra-abdominal pressure of less than 12 mm of Hg. Post-operative abdominal hypertension is there. Treat if it is more than 20 mm of Hg. Epidural analgesia may be protective in major vascular surgery. Dopamine and furosemide no benefit in preventing acute kidney injury. Dialysis helps fluid balance but does not protect the kidney. Thank you. Thank you, ma'am. Thank you for the informative session. Now the session is open for any queries and discussions.
Good morning. So for a heart failure, we know the pro-BNP or drop can tell the organ dysfunction.
Yes.
For liver and kidney, any markers are there for organ dysfunction in the post-operative marker. Serum creatinine more tell the kidney dysfunction directly. So any marker is there for liver and kidney or lung markers are there. Post-operatively, that organ dysfunction was done.
So kidney will go for this criteria, sir. 18 and KDIGO is not there using. That will also contain stage 3. That will also contain creatinine and urine output. Basis only KDIGO.
GFR you prefer creatinine?
Creatinine.
Creatinine. Okay. Liver lung, any markers are there? Like heart, troponin, peak, like that.
For liver markers are there, sir. For lung. Thank you, ma'am. Please kindly stay there for a moment. Now I request Dr. A. Ashok Vardhan, sir, Associate Professor, to kindly come on to the dais. Let's get ma'am with the momentum.
Thank you, ma'am. Now, I would like to request Dr. V. Ramya ma'am to kindly come on the dais for a presentation on the topic AI in perioperative care, monitoring, predicting, and prevention of anesthetic complications. Dr. Ramya Bharta, currently working as an assistant professor in Jimson Medical Hospital, Visakhapatnam, completed her PG from IMS and Sun Hospital, Bhubaneswar, and also has a fellowship in regional anesthesia and trauma critical care from Ganga Hospital, Coimbatore. She has an areas of interest in regional anesthesia and pain management. Please, ma'am.
A very good morning. I'm Dr. Ramya. I'm working as an assistant professor in Jimsar, Visakhapatnam. So, my topic today, I'll be walking you through artificial intelligence in perioperative care. Okay, so kind of new topic and kind of new terms. So, kindly bear with me. I'll try to help you out. So, anything that we wanted to talk about is the first primary goal always, if you want to implement anything, is never compromise on the patient's safety, first of all, right? So anything right now, our primary objective is to keep in mind about do not disturb what is going on. You can add it. That's it. It's an additive. So first, they have to enhance patient safety, improve clinical outcomes, and augment. I really stress on it, not replace the anesthesiologist's decision making. So the core goals of it is that it's predicting adverse events before they can occur, personalizing anesthesia delivery, whether it is drugs, fluids, ventilation. Now automating the routine monitoring tasks to reduce the cognitive load and the writing tasks also. Okay? Next is integrating and interpreting vast multimodal data streams in real time. Now, the life cycle of an AI model, how does it actually work? So, first is that the basic thing is that I have to feed all the data. So, data needs to be collected in a very genuine way, unbiased model, okay, and cleaned, processed, and validated prior to any model construction. Now, the model is constructed, then undergo validation prior to implementation. Now, with after implementation also, they would be under constant surveillance, okay, and generation of new data to update and improve the existing models. So it's like you implement, you make mistakes, you try to learn from your mistakes, and then again implement another model. So this is always a educational process, a constant work in progress. Okay. So now, how it can help us? The main part right now, starting from, is the pre-anesthetic care and risk stratification. So it would be maybe impossible for us to remember all the protocols or everything when you see a patient. But AI can help you in. So it's like a visual aid to you, right? So it can assist you taking out the risk scores for anesthetic and surgical planning, then tools to help patients navigate the preoperative experience, And one very important and interesting is that the augmented reality and the virtual reality. None of us, if we are not into the medical field, will know what surgery are we going to or what are they going to do on us, right? So if you walk them through, try to explain in a visual way. When we try to tell them, they may not be able to understand, but take help of VR, virtual reality. So it can show the work progress of a surgery and how they're going to go through and how they're going to recover. So videos can help them out and ease their anxiety out also, right? So next is perioperative event prediction models. So now outcome and adverse event prediction and real-time intraoperative monitoring. Now then there's real-time clinical decision support and aiding decision making and prompting tasks and leveraging the large language models to rapidly synthesize data. Now resource allocation and drug and device development. So there's the same thing, the data collection, data processing and validation, and then the model updating and construction and validation, and then the model implementation. Again, this is going to be in a circular process. Now, applications, a few applications that we could actually think about right now is the perioperative risk assessment, correct? So risk prediction, there's an app called My Surgery Risk Platform actually. It can predict problems like sepsis, kidney injury, or death, or better than any other traditional scores actually, because it's going to integrate among a number of protocols that currently we do have right now, and they are going to take the data from the meta-analysis. So I wouldn't say that this is an ideal or absolutely 100% coming to the near virtuality, but it is somewhat. So A-B prediction, it can analyze the facial structure and ultrasound scans. It can predict difficult intervention. So it can help us to get prepared, be equipped with the necessary backup. Now, personalized plans is that it can combine genetics, like already I missed the topic, but it's a very interesting pharmacogenetics and polypharmacy. It's a very nice one. So AI can combine that genetic polymorphism data and labs imaging, and also it can create a tailored customized anesthesia strategy for any patient that can go. Now, so first is that how do you identify the high risk patients before surgery? So can AI, what solution it gives is that there's something called machine learning models, okay? So it analyzes the preoperatively whatever data about the EHR data, that is, we don't have it here, but we can, a few hospitals have already implemented the electronic health record data. So first time the patient comes, you are gonna take a very vast history about his previous surgeries, whatever drugs he's taking on, or any other kinds of family history, genetic history, all of it, whatever you can, and they're going to feed into this EHR, right? So basing on these EHR, the machine learns about it, and they take a note of it, and they predict whether he's going to have a difficulty rate, whether they're going to have a longer PACU stay, or they are going to have POND, or any other major complications they can have. So in the US, it is called as the NSQIP database. Like the EHR is inculcated into the database of National Surgical Quality Improvement Program databases. So India is still not there, but we might end up soon, right? So this allows for optimized preoperative planning and resource allocation, right? Not every surgery requires all the manfold over there, right? So you can allocate, you can plan better. Next is depth of anesthesia monitoring. Now, the most common problems that we have is that most of the setups have ETCO2, but we don't have depth monitorings or depth of anesthesia monitorings, correct? So you need to understand or strike a balance between under anesthesia, where it can cause intraoperative awareness, or over anesthesia, then we can have delayed recovery or hemodynamic instability. Now, AI can give you a good solution for this. So you can connect your bus monitoring, and with the help of EEG signal processing, with the machine learning models, it can analyze the raw EEG waveforms, and it provides a much more robust and artifact resistant estimate of anesthetic depth actually. So the mind that we are reading it manually, we may not be able to understand whether it is an artifact generated EEG or the accurate EEG. But machine learning, since it has a lot of data with it, so it can analyze it. Okay. And then, so for example, it can tell the individual's patient's brainwave patterns, and it will titrate the drug infusion rates automatically, like we do it in CLADS. We're going to talk about it soon. Now, the hemodynamic monitoring and prediction. So hypotension and hypertension are one of the most common associated complications. Myocardial injury, AKI, many of them line down with these complications, right? So the AI can give you a good solution. It can give you a predictive analysis. How? So it can analyze the continuous arterial line waveforms like ECG and the patient's history, and it can predict like 5 to 15 minutes prior to what can happen. It can tell you whether its patient's going to land in hypotension or hypertension. So it's going to give you a chance to correct it way before if your patient gets into that state, right? So goal-directed therapies like it can integrate the stroke volume variations, the cardiac output, and other parameters to provide personalized closed-loop fluid and vasopressor recommendations. Now, the hypertension prediction index from Edward licenses is a prominent commercial algorithm which is already in use right now. Now, the automated drug delivery systems, it's called CLADS actually. So, closed loop anesthesia delivery systems are one of the best innovations of AI. I won't say this is going to be like the 100% proof kind of system, but it is actually one of unburdening the anesthetist, I would say. So propofol and remifentanil have been long tried and tested since many. The AI-based systems can titrate these drugs automatically, keeping the best levels stable and reducing the variability. Now, neuromuscular blockade also can be monitored, and it could optimize the muscle relaxing dosing and reversal, lowering the chances of residual paralysis and recuralization. Now, ventilation and pulmonary management is that. So you need to understand and optimizing the mechanical ventilation to prevent ventilator-induced lung injury, atelectasis, while at the same time, adequate gas exchange should be there, and you should be able to get the optimal PEEP for the patient. Right? So how AI can offer you a solution is that it can have a closed loop systems, again, that automatically adjust the tidal volumes, PEEP, and respiratory rate based on continuous capnography, spirometry, saturation, and the lung compliance. So it can detect patterns indicative of bronchospasm and pneumothorax too. Now in the ICU, it can predict different sepsis, respiratory failure, and helps in ventilator weaning also. So it can give you good sedation, optimal sedation, and pain control techniques. Now, there is something called robotic airway management. So, in conditions like where natural disaster conditions or bomb threats or anything, so they have tested it for the AI to secure the robotic robot to secure the airway actually. It is still work in progress, not this is just an existing patent. The patent is still pending. So, what we have talked about right now, so closed and loop anesthesia delivery systems. So, then clinical decision support systems and teleanesthesia and mechanical robots. Now there's a new invention, innovative thing, which is interesting. So there's something called AI tube. So now it's supported ventilation through multimodal closed loop ventilation. So if you see at the structure of the endotracheal tube, it looks like just like any other normal tube itself, but they have something called as MEMS sensors, which can actually sense it's a 3D sensor. It can actually sense for the light, pressure, and temperature. Right? So we're going to talk about it. So what is this MEMS? It's microelectromechanical systems, microphone induced and inculcated, and suction channel containing integrated ET tube. Now it enables a precise recording and analysis of breathing and ventilation parameters in real time. Now abnormal events during ventilation are automatically detected. It can be used for oral and nasal ventilation. So what is it doing with that? It is having a built-in microphone inside the cuff itself, okay? And can be used to listen to the breathing patterns in the immediate vicinity, like wherever you are putting it in the division of the two main bronchi or wherever it is. So the sensors are typically fabricated onto a flexible polyimide film match using an MEMS technology and integrated into the tube or an adapter. Now these sensors use principles like thermal flow sensing, where temperature changes caused by the airflow are measured to determine flow rate, direction, often with inbuilt temperature compensation also for accuracy. Now, data from the sensor can be transmitted in real time to a monitoring system or a ventilator. Now, confirming the correct placement can be done with this. Now, real-time monitoring of the patient's airflow, pressure, it could be a better assessment actually. Now, preventing lung injury also. So, by monitoring the pressures in the tube, system can provide feedback actually to the ventilator to regulate ventilatory modes automatically and tidal volumes and prevent ventilator-induced lung injuries or over or under inflation of the lungs. Now, optimizing extubation timings also. Now it can measure the spontaneous breathing efforts just before planned extubation, and it can suggest you the exact time or appropriate time to extubate. Now compatibility is something that now they are trying onto the prototype where this NEMS sensor can be inculcated into your regular existing endotracheal tubes also, right? Now the A4 patterns that can be heard because of the sensor can differentiate between the respiratory status and also contain mucus, pendulum volumes, and cuffing also. So it is to enable close suctioning also, with the suction channel also instilled in the ventilation tube. Now there's a control unit, it's a mini computer which interprets and senses signals and algorithms also. Now implements the information in control system of modern ventilators. Now, there's where do we can apply these tools? You can apply everywhere, like anesthesia, emergency medicine, ICU, wherever precise monitoring and control of ventilation is required. Now, next is analgesia and nociception monitoring. Now, the assessing of the balance between analgesia and nociception is very subjective. Now, how AI can give you a solution is that it can analyze multiple signals, heart rate variability, galvanic skin response, plethysmography waveforms, to quantify the nociception and the antinociception balance, and it can guide you for opioid or analgesic infusion rates in real time. Now, regional anesthesia is that AI enhances the ultrasound imaging by identifying the nerves, tracking the needles, improving success, and reducing the dependency on operator skill. Now, for post-op pain, AI-driven pumps adjust opioid doses according to the patient's responses. So this is one of this very commonly we can see in the GE ultrasound machines right now. It can even highlight the anatomy. If you have this option called gene nerve, so it's like a nerve tracker. So it can show you a probe position, and it can also give you options like which part of the plexus that you want to block, and how, for example, if it's in a supraclavicular approach, how the bundles will be arranged. In the infraclavicular approach, how the bundles will be arranged, and it can also help you in if you're using systemic needles. It can tell you the needle direction, how you have to change also, right? So it can give you a real-time, more confident to the people, especially the postgraduates who are learning. So it will be very intuitive and yeah, something very encouraging basically. So. Now, integration in smart alarms. So, alarm fatigue is something a very major safety issue. One of the other problems exist in the machine, and always they give up some of the other alarms. So, that fatigue we call it, right? Like you trying to ignore them, correct? So, this is going to help you out in some way. Like it's going to screen for something which is like false positive rates will be decreased, and proper alarms can be integrated. Now, there is something called context-aware alarm systems. It can be AI fuses the data from the ECG, BP, saturation, and capnography with the surgical stage right now going through, and to distinguish true critical events from artifacts actually. So, nuisance alarms can be screened off. Now, the OR management. Now, it's a very important thing because if you want to have the OR turnaround ratio, right? It will improve it. It's very important for the corporates. Like more and more cases that you operate more in little less time. So operating OT management is very important for them, right? Less time. So OR can act and AI can help you in planning that. Now the machine learning is used to perform three vital tasks actually. First is surgical cases cancellation identification, then occupation of the PSU, and estimation of clinical surgical case duration. These are the three things that can actually help you in planning. Now, it developed a prototype for automated OR management called Block OP, and it associates an indoor tracking system with ML analysis. These are smart automatic surgical times are automatically detected for smart OR scheduling. It includes a Bluetooth low energy tags indoor localization via Raspberry Pi 4 model. It's a patented model. It's already been used in China also, it seems, with relative antennas that communicate each other through a local area network actually. The ML algorithms analyzes on the other hand, and the purpose of making accurate predictions of the operative times, and it will be a basis for an intelligent scheduling model. So a rough data, I just put a picture, says that like it can tell you which OT is going to be occupied the next, and where does the patient has to be from the like from the pre-op room, where the patient has to be mobilized to the to the observatory room, or from the patient who is extubated, they come to the PACU. So it's going to help you in a smooth workflow actually. And it's going to give you timings also. Within 10 minutes, you need to ship the patient to there, okay? And it seems that I have read a few articles. In China, they already have robots and also for delivery of drugs, equipment, and for surgical drapes and all of that also, like decreasing, unburdening the manforce actually. Right? Now, clinical decision supporting systems. So that, as I told you, these are like decision supporting itself, not something that can take the decision on behalf of us actually. So there are tools that provide real-time advice. So it suggests the right drug, dose, using the patient's comorbidities, and whether I can give this drug safely or not, or it can trigger an allergic reaction or not, or the doses currently basing on his heart rate or basing on his the right choice of drug basically. So it's going to help you. Ultimately, the decision lies on you itself. Now, when it's a predictive alerts, then workflow improves operating room efficiency and ICU integrations also. Now, so this is a short infographics of how AI core functions actually. So as I told you, we have talked about predictive algorithms, then there is CLAD system, then there is patient's input data, the EHR, labs, vitals and history. Then they will actually categorize into low risk profile and high risk. If it's a low risk, they're going to get the time like conventional anesthesia and standard monitoring. If it is a high risk profile, then they will use AI augmented care actually. And then the risk stratifications, then preoperatively, intraoperatively, like autonomous monitoring and closed loop controls, and post-operative is outcome evaluation and recovery analytics. Now, then later is the ethical considerations and clinical oversight. Like what kind of challenges that can you face? Because since AI is a new entity, you need training, you need to integrate into your current existing operating systems, correct? And clinical autonomy, shared decisions to be there, and authority to override AI. Something it is suggesting, and I don't want to do that. So I should give me the freedom to override the decision made by the AI system, right? Then regulation, like how ethical are they implementing it, and how ethical is our data being protected. So all of these have to be taken considered. Now the perks of AI. So of course, enhanced safety, we talked about it, improved precision, we have talked about it, then reduced cognitive load on the anesthetist, right? So it's going to help us in some way. It automates the routine monitoring, unburdening the anesthesiologist for higher order tasks and patient care. Better outcomes, operation efficiency. Now, what are the challenges and considerations that we have to do? Now, black box problem. So many complex AI models, they have deep neural networks actually, and they're not easily interpretable, not to a common man like us, like a doctor like us. And clinicians need to understand why the AI made the recommendation to trust it. So what do they want to say is that exercise caution. Use your own clinical knowledge too. When an AI is suggesting that, it could be a glitch also, or it could be something which is coming out from the data it had analyzed. Now, I said previously also, the quality of data which is being supplied to the AI plays a major role. If the data is not fed properly, so it's going to suggest you something which is out of the blue. So you need to be cautious that what is, like, I should know first, basically, that's what I want to say, right? So this is what data quality and bias, then clinical validation and regulation. A few regulatory pathways are there, like for FDA and CNC, but they still don't have their boundaries being limited. Like, does a AI come under them or not? They're still not so sure. Next. So integration and workflow, the current seamless integration to existing OR monitors and EHR systems is technically challenging. So the user interface must be intuitive and liability and responsibility. And one of the major tasks is cost. So development, validation, research analysis, it would be very expensive and it could limit the access to us. Now training of doctors to use AI efficiently is also important. So the future directions is that it will be personalized anesthesia, no doubt about it, then multimodal fusion, like combining traditional vital signs with the advanced data streams like video, like for blood loss estimations, tissue oxygenations, right, and point of care ultrasound. Then the expanded perioperative scope is that seamless AI monitoring through the OR, PSU, wherever you are, you can monitor the patient. Now, digital twins. Now, this is an interesting entity they're working on it, that if the patient is coming for a surgery, let's say lap cholecystectomy. So you can actually create a visual twin of the the patient's physiology, like how this fellow is going to react under pneumoperitoneum, how his blood pressure is going to shoot up, or whatever. So you're trying to clone out his physiology, and you can plan your anesthesia plan for that. That's a lot of effort, I know.
So AR and VR integration, the AI guided overlays could highlight anatomy in real time during the blocks of intubations. It could also, VR is very good for training residents actually. Now, fully autonomous systems, it's a fully autonomous, it's a prototype still developing, it's a Max Sleepy. It showed fully automated anesthesia tendering, which is still an ethical and legal concern. Next is reinforcement learning, continuous learning, it is a continuous process, and medical education is required to train up the current residents. So now conclusion is that now AI in perioperative anesthesia is rapidly transitioning. So now it was what was a research 10 years ago, it's right now into clinical reality already, right? And whether we want it or not, it's gonna come into force because there's a lot of business is being involved, a lot of money being invested. So it is going to come. So what can we do is that train ourselves and we can use a lot of modules of AI for our convenience, right? So I would always say that it's not in replacing the anesthesiologist. It can function as a powerful data-driven co-pilot. Right now, it can predict insights, personalized recommendations, and reducing the alarm noise. And it can empower the clinicians to deliver safe, more precise, more efficient care. So these are my references. And
Thank you, ma'am, for your new and informative presentation. Now the session is open for any questions and discussions.
Regarding fluid management, any AI role? Because cardiac output and fluid management interoperatively, we are very concerned about ERAS protocol.
Correct, sir.
So, how AI helps in fluid management? And
So, as I said that in my previous slides, it's going to take the data from stroke volume variations with the help of impedance technology, and it's going to take you a goal-directed fluid therapy. So, basing on the output that you have given and also the pre-existing forms of the cardiac condition. So, it's going to collaborate on the data of the patient that you have given. And yes, the fluid management AI has a very good role in fluid management. In fact, better assistant than a human, I think.
That was a very insightful lecture, madam. But I want to know two things. One is what about the legal implications of AI? One thing. Second thing, are there any hybrid models in both the human intelligence as well as AI put together, especially a period of transition? Then once anyway it will come into your life. You cannot avoid it at some stage of your life.
Yes.
Till then, you should not fall into the pitfalls of the AI and all the complications. So the two things I want.
Correct, sir. So there are many legal battles going on right now. So I already had delivered a talk with ma'am's moderation already. So that time it was my cons of artificial intelligence, and I have actually given a very elaborated. I can forward the slides also because I've done a lot of research about the legal entities that's going on in different European countries. So as I said also, so no regulatory network is right now. So the FDA doesn't know where does it actually have to draw a boundary. So whether it has to stick on to the drugs part or it has to stick on to the medical devices manufacturing part, and it's the kind of mostly it's like this is right now in the trend. If I don't pick up the trend, I might be somewhere in the back, or I would be like outwritten from the trend. So in order to catch the trend, many of the data or many of the research work has been done. They're just publishing, but they don't have even a AI integrated monitor also in their setups. So not every paper that gets published you should not be trusting unless it comes to it. First thing, legally, sir, obviously, sir, because how do you defend yourself? Whether the anesthetist who delivered the anesthesia would be liable, or the hospital who hired the system would be liable, or the surgeon who is operating would be liable. Nobody knows it. So you need to be, that's what I was trying to tell you. So when AI will give you an intuitive aid or something and suggesting you that try to bring up the doors or lower the doors,
You need to be equipped clinically also, first of all. That's the way I said that it's never going to replace me. It's just going to help me. That's it. It's going to be a co-pilot. So first thing. Second thing is that, yes, sir, eventually, even if I want it or not, it's going to get enforced, right? Because a lot of businesses have been invested very high. Many countries have been invested. So what I would say that make peace with it, train yourself, and know your stance. Where do I draw a line and override the decisions of AI? How do I? So every decision that I let the AI take, I need to know how to defend myself. So yeah. But for teaching and educational, it's going to be a wonderful tool, I feel, sir. And telemedicine is going to be a game changer, I feel.
Many layers of protection should be there
Correct.
before anybody accesses patient data.
So that's why they said, I said the black box problem. So the machine learning problems, it has deep neural connections. So so that's what. So anyways, it's a virtual thing. So anyone who is very equipped with hacking, they can hack into your data.
But
So
there should be many layers of protection.
correct, they
Nobody can
have them. No matter how much you have, it is still online, so they can still hack into it. That's what they say. That, yeah. It's ultimately zeroing down to the hospital which hires the AI. So if you say that if you are firewall, you need to invest higher amounts to protect your data. So ultimately, that cost is going to get converted onto the patient therapy, or cost would be expensive. It will be very expensive. Yeah.
Madam, good morning, madam. Hey. Okay. From corporate side, it is okay because they will invest and they will keep all equipment ready. But what about the consent from patient and relatives? How can we explain regarding this?
Yes. So it's going to be a tough walk. So it's not. Trust me, it's not going to be very easy. So back in US or Europe, they have a very basic medical education before, like even in their schooling or also. So if I say this to ఇప్పుడు వచ్చి ఎవరిలో ఇది ప్రాబ్లం ఉంది నాకు అది మెషిన్ చెప్పింది అంటే మనం కొడతాం సార్ ఖచ్చితంగా. So I that is what I was trying to tell you. So to tell them, so it's very ethically problematic, like double-edged sword, that if I say that I'm using an AI based anesthesia model, so will I save the patient or not? So hiding it was also I'm ethically legally answerable. Doing it and then in the AI makes some problem, and if I don't know how to correct it, then that is also putting me into troubles. So it is going to be a problematic. So maybe we'll, through the years, down the R&D or something, government if gives any legal guidelines, could be helpful for us. Yeah.
Using AI, so you're taking consent or something, like AI knowledge from AI. So it might be received from some patients in a good way. Some patients may not take it in a good way. Yeah. So we never know whether we have to reveal that we have to get information from AI or not.
Yes.
In order to take the consent, because of the prediction from the AI cannot. This is not. We are not on par with AI in predicting the post-operative status or intraoperative complications.
True.
We are not on par with AI. So.
And not only to the patient, ma'am, it's not going to be an easy takeoff to explain to the surgeon also. Because something which I don't know, something which I don't have a control, it's very extremely scary for them too. So it's not going to be an easy way. And even if there are so many scary people or scary, unsure faces, even I will not be sure, like, okay, if anything's going to come, how will I override it?
And the respect that we get as doctors from the patients. It is doubtful whether it will be the same when we say that we are using AI as a co-pilot.
Yeah, they'll just undermine us very quickly.
We might be undermined.
Yeah, yes, ma'am.
Thank you, ma'am. I'm requested to stay on the desk for the token of appreciation. I would like to request Dr. Jaychandra sir, Associate Professor James, to kindly felicitate ma'am with the memento.
We will now move to the next seminar presentation by Dr. K. Harikaman, postgraduate, on the topic intraoperative anaphylaxis under the guidance of Dr. D.V.G. Shankaran sir. Sir has completed his undergraduation and post-graduation from AMC Visakhapatnam, currently working as professor in HOD GEMS Srikakulam. Sir has a teaching experience of over 19 years, worked as a professor in Department of Anesthesiology, NIMS Vizag.
Very important topic. How many of you PGs have witnessed anaphylaxis? No. That's the good thing with the anaphylaxis. Very rare. I witnessed one thing long back, two decades back. It was moderate severity. It was rescued well. That is the good thing with the anaphylaxis. But bad thing, what is the bad thing? First bad thing is any drug can cause anaphylaxis. Not even drugs, food also can cause. Sometimes we hear exercise-induced anaphylaxis. Such things are there, so any drug can cause at any time. That's the bad thing. Another bad thing is it is life-threatening. So please focus on the lecture, focus on this topic, and anybody can give your inputs for this. Thank you.
Good afternoon, everyone. I'm Dr. K. Harika, a postgraduate from GEMS College. Today, I'm going to present the case report, intraoperative anaphylaxis following protamine administration. My moderator is Dr. D.V.G. Shankaran sir, Professor in HOD, Department of Anesthesiology. A 48-year-old female resident of Srikakulam came with complaint of breathlessness, palpitations, chest pain since 4 months. History of presenting illness is breathlessness, which is progressive and precipitated on exertion, comes under NIHA grade 2 classification. Associated more on lying down, patient requiring 2 to 3 pillows while sleeping. Palpitations are sudden, rapid in onset, which are relieved on rest. Chest pain, dull aching, central chest pain, which is non-radiating, precipitated by exertion, relieved on rest. No history of cough, fever, edema, or hemoptysis. Past history, she is a known case of diabetes since 10 years and hypothyroid since 3 years. She is on regular medication. No history of seizures, CKD, COPD, hypertension, tuberculosis, asthma. No history of any allergies for food and medications. She should have penicillin injections every 21 days for 8 years till age of 20 years, and then she discontinued. Present medications, she is using the tab glimepiride 1 mg, metformin 500 mg, and voclivos 0.2 mg per oral once a day, and tyronol 25 mg per oral once in a day. Surgical history not significant. Personal history, appetite is normal, mixed diet. Bowel and bladder habits are normal and regular. She had disturbed sleep. She was not a known alcoholic or smoker. She attained menopause by 50 years, 40 years. Family history non-significant. General examination. Patient is conscious, coherent, and cooperative. Moderately built, nourished. Height is 155 centimeters. Weight 55 kgs. BMI 22.9 kg per meter square. So vitals, BP right upper limb 140 by 90 mm Hg. Left upper limb 130 by 90 mmHg in sitting position. Heart rate 76 beats per minute. Saturations are 98% room air. Temperature patient is febrile. Grade 1 pallor is present. No icterus, cyanosis, clubbing, edema, or lymphadenopathy. Headway examination, mouth opening 3 FB, no loose tooth or myelopathic grade is grade 2. Thyromental distance is 7 centimeters. Stenomental distance is 12.5 centimeters. Adequate neck movements, no restriction but not there. Systemic examination, cardiovascular examination, inspection, patient is orthopney, no peripheral edema, no cyanosis or clubbing. JVP is not elevated, no external deformity or no surgical scars. Palpation, apex beat is localized in the left fifth intercostal space, mid-clavicular line. Precordium is normal. Peripheral pulses are normal. Parasternal heave is absent. Trills are absent. Oscillation loud H1 is there. Opening snap is was there. Low pitched mid-diastolic rumbling murmur was heard in mitral area with pre-systolic accentuation, no radiation. Respiratory system, bilateral air entry was present, no added sounds. Abdomen soft bowel sounds were present. CNS no focal deficits. Provisional diagnosis: a 48-year-old female with complaint of breathlessness, NIHA grade 2, associated with lying down, palpitations, chest pain since 4 months, non-diabetic and hypothyroid. On examination, failure and on auscultation, loud S1, low-pitched mid-diastolic murmur in mitral area. Probably a case of mitral stenosis. Investigations, HB is a 10.8 gram per dl, platelets is 2 lakhs, RFT, LFTs are within normal limits, T3 is a 0.7, T4 12.8, TSH 3.48, chest X-ray was normal, 2D echo, EF 55%, CRHT is there, AM, VL thickened and doming, PMVL restricted and thickened AB. Severe mitral stenosis, mitral PPG by MPG ratio is 24 by 12. Dilated left atrium, mitral valve area is less than 1 centimeter square. Blood group is O positive, viral markers are non-reactive, INR 1.03. Diagnosis, severe mitral stenosis. The plan of surgery is mitral valve replacement. Plan of anesthesia, general anesthesia. Preoperative preparation informed the written consent was obtained. Blood products were arranged and cross-matched. Stopped the oral hypoglycemic drugs night prior to surgery and started injection regular insulin subcutaneously according to sliding scale. Anti-emetic and aspiration prophylaxis were given. Injection ondansetron 4 mg IV and injection pantoprazole 40 mg IV was given. Antibiotic prophylaxis with injection piperacillin 2 grams plus tazobactam 0.5 grams were given. Patient kept fasting 8 hours for solids, so 6 hours for liquids, 2 hours for clear fluids. Anesthetic management and induction after shifting to OT, all the standard all ASS standard monitors were connected. After arterial cannulation done to the left radial artery and venous cannulation done to the right internal jugular vein with the 7 French triple lumen catheter. Patient is used with injection fentanyl 200 micrograms IV. Thiopentin is given as graded doses 300 mg. Muscle relaxant given with injection rocuronium 8 mg IV, injection loxicab 42.6 mg IV given to reduce the intubation response. Intubated with 7.5 mm cuffed endotracheal tube with within 90 seconds. Ventilator settings FiO2 40%, peak 5 centimeters H2O, tidal volume 6 ml per kg, respiratory rate 18 per minute. Under deep anesthetic plane, surgical incision was given and the procedure was started. Initially, we have started injection NORAD 0.1 ml per hour and injection adrenaline 0.1 ml per infusion was started. Before going to the cardiopulmonary bypass, injection heparin 400 international units per kg IV was given. ACT was checked and it was 480 seconds.
Bicable cannulation was done and patient was placed on cardiopulmonary bypass. Mitral valve replacement was done and patient started to wean off from cardiopulmonary bypass. With surgeon's confirmation, we have started injection protamine infusion 150 mg in 100 ml NS. Intraoperative event after 1 minute of starting protamine infusion, there was fall of saturation from 99% to 88%. Peaks raised from 22 to 28 centimeters H2O. Fall of BP was from 110 by 70 mmHg to 60 by 40 mmHg. And heart rate was from 80 beats per minute to 58 beats per minute. Informed to the surgeon and immediately protamine infusion was stopped. Management we did with injection hydrocortisone, 100 mg IV was given. Injection Ebil 22.75 grams IV was given. Injection ranitidine 50 mg IV was given. NORAD infusion increased to 4 ml per hour. Adrenaline from 4 to 8 ml, increased to 8 ml. Ventilator settings we changed FiO to 100%. We made PEEP 10 centimeters H2O. I is to E ratio 1:2.5. Simultaneously, two FFPs and one PRBC was transfused as ongoing bleeding was there. One ABG sample we have sent, it was values for pH 7.22 mmHg, PCO2 52 mmHg, PO2 83, HCO3 21.3. Management after resuscitation, saturation improved to 99% with FiO2 100%. PPX improved to 18 centimeters H2O. BP 110, blood pressure 110 by 70 mmHg, heart rate 88 beats per minute. After patient was stabilized, again protamine was started slowly. The remaining 100 mg was given as slow IV. While starting the second time protamine, there were fluctuations of hemodynamic parameters, but managed with inodrops till the closure. Again, ACT was repeated. It was 170, and closure was done with minimal bleed. Patient was planned for elective extubation and shifted to intensive care unit with stable vitals. After shifting to ICU, another PRBC was transfused and ABG was repeated. The repeat ABG values of pH 7.33 mmHg, PCO2 42 mmHg, PO2 is 232 mmHg, and HCO3 is 22.1 moles. ABG was corrected. Post-op management, patient was again repeated for ACT, and ACT value was 175. Patient was extubated after 12 hours of surgery. As patient was hemodynamically stable and chest X-ray didn't show any collections, and repeat 2D echo also didn't show any changes. Patient injection NORAD was still 4 ml per hour and adrenaline was 4 ml per hour. Patient was followed up for 7 days and uneventful and hemodynamics was stable and slowly inodrops were weaned off gradually. Discussion, intraoperative anaphylaxis, a severe acute life-threatening systemic hypersensitivity reaction that occurs during anesthesia. It is characterized by airway compromise, bronchospasm, cardiovascular collapse due to massive inflammatory mediator release. Incidences one in 10,000 to 1 in 20,000 anesthetics. Risk is higher with previous drug or any previous exposure of drugs or latex exposure. Exposure to multiple drugs in a short time, or any history of asthma or a history of any perioperative reactions. Common triggers are in drugs, neuromuscular blockades like succinylcholine or rocuronium or etraquilium. Antibiotics, injection agents like propofol and thiopentone. Opioids, morphine, meperidine. Colloids, which are gelatin-based. Protamine, when given for unfractioned heparin reversal. Others are latex, chlorhexidine, dyes, methylene blue, isosulfan blue. Protamine-induced anaphylaxis. Protamine is a low molecular weight polycationic peptide which is used to neutralize heparin. Administered in cardiac surgeries or vascular or hemodialysis procedures. It is derived from Salmon's sperm and recombinant process. Incidence is 0.06 to 10%. Severe anaphylaxis incidence is 0.5 to 2%. Early recognition and preparedness are essential. Protamine-induced anaphylaxis reactions are of two types, type 1, type 2, type 3. Type 1 hypotension which is caused due to direct histamine release. Type 2 anaphylaxis is IgE mediated. Type 3 pulmonary hypertension due to IgG mediated and it is non-immunological. Pathophysiology, any allergen which when is exposed, primarily antigen presenting cells are activated, which leads to T cell and B cell proliferation. From the B cell, IgE antibodies are generated. IgE antibodies cause the mast cells proliferation and causes the release of the inflammatory mediators like histamine, leukotrienes, and cytokines. IgG antibodies cause the complement activation, which leads to neutrophil and platelet interaction, and which causes acute pulmonary vasoconstriction. Due to that, there will be right ventricular failure and impaired left ventricular filling due to the dilatation of the right ventricle, which leads to the cardiogenic shock. Triggers cause the either direct mast cell activation or IgE mediated or IgG. IgE mediated it causes the mast cell degranulation and causes the release of histamine, tryptase, thymus, and amines. Ecosin, leukotrienes, prostaglandins were released. Cytokines, chemokines, and growth factors are released. Clinical features, systemic wise, cardiovascular, there will be sudden profound hypotension because first there will be decreased systemic vascular resistance. Due to that, there will be vasodilatation. Due to this, there will be sudden profound hypotension. And the capillary leakage, fluid shifts from intravascular to interstitial space. So there will be capillary leakage and up to 35% of the circulating volume may shift out of the circulation. Decreased venous return leads to the decreased preload and the cardiac output will be decreased. Tachycardia, histamine acts on the H2 receptors in heart, increases the heart rate and contractility, and heart rate also increases as there will be hypotension, sudden dyspnea, flushing, airway edema due to vasoactive mediators from mast cells. Hypotension due to the when there is decrease in cardiac output, there is less CO2 delivered to the lungs. So there will be decrease in end-tidal carbon dioxide. Myocardial depression will be there due to reduced contractility, coronary vasoconstriction leading to the ischemia. Respiratory, as leukotrienes are the most potent vasoconstrictors, they increase the mucus secretion and cause the edema of the upper airway. It causes bronchospasm, wheeze, raised peak pressures, difficult ventilation, and hypoxemia will be seen. Cutaneous symptoms of flushing, urticaria, angioedema due to vasodilatation of the arterioles, that is more blood flows to the skin. Cyanosis is presented in severe hypoxemia. Gastrointestinal symptoms, abdominal cramps, nausea, vomiting, diarrhea will be seen, as there will be increased gastric acid secretions and there will be increased peristalsis due to the activation of H1 receptors. Neurological symptoms, confusion, lightheadedness, and loss of consciousness will be there, as there will be decreased cerebral perfusion. Complement system activation will be there. Due to that, there will be opsonization and more release of the inflammatory mediators. Severe pulmonary vasoconstriction will be seen as complement activation causes activation of pulmonary intravascular macrophages, which release thromboxane A2, which is a potent bronchoconstrictor. Increase in pulmonary artery pressure, right ventricular failure will be there. Due to this right ventricular dilatation, there will be less preload in the left ventricle. Due to that, there will be a decrease in cardiac output and there will be hypotension. Investigations are serum tryptase levels released from mast cells. Serum tryptase is a marker of the anaphylaxis. First sample is collected within 15 to 60 minutes after onset, ideally 1 to 2 hours. Second sample can be collected after 2 to 4 hours after onset. Third sample 24 hours later or in outpatient follow-up. Elevated tryptase supports IgE mediated anaphylaxis. Normal tryptase does not rule out because in food or anesthetic non-IgE reactions can be occur. Investigations of arterial blood tests, any metabolic acidosis in case of, as there will be hypotension, there will be less perfusion. It can give rise to metabolic acidosis. Respiratory acidosis in case of bronchospasm, there will be elevated, there can be elevated levels of carbon dioxide. Lactate elevation in case of poor perfusion, hypoxemia. Complete blood count eosinophilia rarely acute but useful later helps to rule out the other causes of the shock. Protamine specific IgE and IgG can be performed for the patients who were given protamine. Serum histamine levels which rises rapidly but returns to normal within 15 to 30 minutes, often difficult intraoperatively to assess. ECG, cardiac enzymes and chest X-ray for any collections. Urinary output monitoring, as in case of low perfusion, there will be low urinary output. Renal and liver function test to assess any end organ injury or a drug toxicity and hypoperfusion effects. Transesophageal echocardiography. Latex allergy workup for 6 weeks. This is mandatory for identifying the offending agent. It includes the skin prick testing, intradermal testing, specific IgE testing, tryptase baseline drug challenge test. Treatment, we should stop trigger immediately and stop further infusions of any triggering agent. Do not give additional trigger. Notify perfusionist or anesthetist. Give 100% oxygen, switch FiO2 to 100%. Ensure airway patency. Prepare for ventilatory support. Anticipate difficult airway if edema or a bronchospasm develops. Adrenaline is the key drug, first line drug for hypotension or anaphylaxis. IM 0.01 mg per kg of 1:1000. For adults, 0.5 mg IM is given. For children, ideally 0.3 mg can be given IM. Sinus mid anterolateral thigh, repeat every 5 minutes if there is no improvement. Start adrenaline infusion for adults or pediatrics 0.05 to 0.1 micrograms per kg per minute with impending signs of any cardiovascular collapse is there. Give 10 to 20 micrograms of 0.1 to 0.2 ml of 1:10,000 solution bolus can be if BP still remain low. For cardiac arrest, adrenaline 1 mg IV every 3 to 5 minutes according to the ACLS protocol. Adrenaline improves the blood pressure, treats bronchospasm, stabilizes mast cells and improves cardiac output. Fluid resuscitation, severe vasodilatation, third spacing fluid accumulation will be there. So rapid crystalloids 20 to 30 ml per kg may require. 2 to 3 liters during the cardiac surgery. Nebulizations can be given through nebulizer with chamber with the salbutamol. Injection phenylamine 45.5 mg IV, ranitidine 50 mg IV, hydrocortisone 200 to 400 mg IV can be given. Vasopressors with adrenaline is insufficient, noradrenaline 0.05 to 0.2 micrograms per kg can be per minute can be started. Vasopressin 1 unit bolus or 0.01 to 0.04 units per minute can be given. Phenylephrine 50 to 100 mics intravenous can be given. For pulmonary hypertension, G mediated, it causes sudden pulmonary arterial pressure and right ventricular failure. Management with inhaled nitric oxide, which decreases the pulmonary vascular resistance. Inhaled prostacyclin can be given. IV nitroglycerin infusion can be given for any coronary vasospasm. For 0.5 to 1 microgram per kg per minute can be given. Milrinone to maintain the hemodynamical parameters can be given. Injection sildenafil 0.25 to 0.5 mg per kg IV over 3 to 5 minutes can be given. Support the right ventricle by reducing the afterload and maintain the right ventricular preload and avoid excessive fluids. For protamine sensitivity, stop protamine immediately, call for help and give 100% oxygen, secure airway and support ventilation. Rapid IV fluids to counter the vasodilation as there will be loss of fluid. Adrenaline first line, 10 to 20 micrograms of bolus can be given initially. Support the right ventricular with iron drops and to reduce the pulmonary vascular resistance, we can nitric oxide inhalation, sildenafil can be given. Treat the bronchospasm with nebulizer by giving salbutamol, antihistamines plus steroids. Alternatives to protamine.
Focus reflexes. Patient comes for surgery for the first time. Do you expect any anaphylaxis in the patient or any drug? Previously, I have not taken any antibiotics, any for neuromuscular blood disease.
For succinylcholine or docetaxel or etrasimod, can apply.
No, he is going to get those drugs for the first time. Then how can you expect anaphylaxis? For anaphylaxis, there must be pre-exposure for the drug, antigen formation and antibodies formation. That's the way anaphylaxis develops. So here you are telling me that succinylcholine, first time he may get the anaphylaxis. How it is possible? Or any etracurium or anything? No. It's due to cross-sensitivity. Same benzodiazepines or quaternary products will be there in cosmetics and other drugs and over-the-counter drugs. So you may get the previous exposure unknowingly. So you may get the anaphylaxis there in his first time also. Okay. What is the take-home message from this?
We only assessing in any instant preoperatively assessing the incidence of anaphylaxis which can occur intraoperatively. If we have to thoroughly ask about the history. Any previously before the patient had any surgeries, previously he had any reactions to any drugs, we have to ask.
For anaphylaxis management, rapid recognition and proper treatment. This is the method for anaphylaxis treatment. Rapid recognition and proper treatment. Epinephrine should be given immediately after recognizing the event. If it is given 20 minutes late, the outcome may be different. So rapid recognition is important and proper management with epinephrine is the first thing you have to focus upon. Okay, what are the advantages and the disadvantages for being in intraoperative anaphylaxis? How you are safe there and how you are not?
Advantages of we can immediately administer the drugs to the patient, sir. Basically, in intubated cases, patient cannot say about rashes or that. It is difficult to identify in intubated cases.
All are available. Life saving is very easy. You have airway in your control and vein in your control, so you can act immediately. The problem is patient is under drapes, so cutaneous manifestations may not be identified. You may take it as a normal bronchospasm, a normal tachycardia, a normal hypotension. You may miss the diagnosis. That is the problem. Okay. Additions. Here, one thing is very important. Follow-up is very much important. Once resolution is there, you need not to lay down. Patient must be under proper monitoring. Why?
Because sometimes there will be delayed reactions. Few reactions will be seen delayed.
Again, the patient may get the problem anaphylaxis. Uniphasic, biphasic, there are many phasic things are there. So, most of the times it is uniphasic, but sometimes it may be biphasic. After few hours, the patient may get the anaphylactic shock. So, you must be careful for that. Again, after follow-up, everything must be documented. Patient should be educated that he is having some allergy for that for certain drugs. It must be there. I think everybody went through the news last November 20th in Kakinada General Hospital. A patient was died due to Pantap injection. Already documented Pantap. He is allergic to Pantap. Still, some doctor has surgeon has given that one. Last November 20th on Pantap, he was given. Lost the patient. Any additions? Only addition, no questions.
So patients on chemotherapy are immunocompromised patients. So anaphylaxis is a protective or it will deteriorate the patient. Patients who are immunocompromised are chemotherapy patients. So anaphylaxis will protect the patients or will harm more.
Will harm
More. Because more symptoms are masked. So anaphylaxis will be symptoms will be delayed. So you know, ranitidine intraoperatively, it was any.
It was H1 locus.
No, it was H2. So you have to give diphenhydramine or levocetirizine, but we have not intra-IV available, not available. So that is the ranitidine.
Thank you.
Thank you, ma'am, for the presentation. Now I'd like to request our introducer to kindly stay back on the dais for the registration ceremony. I'd like to request Dr. B. Muralikrishna sir, Dr. Shirisha ma'am to kindly come on the dais to give a token of appreciation to our introducer. I would like to request Dr. Shravanti ma'am, as Assistant Professor James, to kindly facilitate Harika ma'am for this session. Now moving on to the next presentation by Dr. S. Shweta ma'am. I would like to request ma'am to come on the dais for a presentation on the topic Complications in Pediatric Regional Anesthesia, Enhancing Safety and Preventing Harm. Dr. Shanti Shweta, currently working as an assistant professor in AMC Visakhapatnam, completed her UG from AMC Visakhapatnam and PG from Sri Venkateswara Institute of Medical Science, Tirupati. She has a working experience from July 2018 and has an area of interest in regional anesthesia, pediatric anesthesia, and pain management. She also has one publication. Welcome, ma'am.
Thank you for the kind introduction, and I thank GEMS Anesthesia Department for giving me this opportunity. Very good afternoon to you all. My topic today is complications in pediatric regional anesthesia, enhancing safety and preventing harm. These are the topics I am going to cover under these headings. Coming to the introduction, previously when we were students, regional anesthesia in children used to be like looked down upon. They used to not prefer. Always general anesthesia used to be the anesthesia of choice. And but now pediatric regional anesthesia has emerged as a cornerstone in the multimodal approach to perioperative pain management in children. This needs a comprehensive understanding of the features unique to pediatric patients, and it is necessary to utilize these techniques of safely and effectively, especially if the anesthetist is usually doing adult cases. We all know that children are not small adults. Children smaller body size and unique body composition, they necessitate meticulous dosage adjustments to prevent under or overdose. So coming to why pediatric anesthesia has seen a resurgence, pediatric regional anesthesia has seen a resurgence. So previously, general anesthesia, the research into general anesthesia effects in pediatric patients like children, they have found that the NMDA receptor antagonists and the GABA receptor agonists, which are used, most of our anesthetic agents are influencing these receptors. They have found that these receptors, they activate the apoptosis pathway in the pediatric brain. the developing brain, during which rapid synaptogenesis is taking place. There is usually physiological apoptosis, but using these drugs or repeated exposure to drugs which affect these receptors, they induce rapid apoptosis and they cause some neurodevelopmental problems in these children. There are few studies like the PANDA study or the GAS study which show these results. Mostly these are all retrospective studies, but some uh, and mostly animal studies are proving these things, but in humans these are mostly retrospective studies. And we all know there is a higher incidence of hypoxia, bradycardia, and postoperative apnea. These are seen most commonly in neonates and infants less than 1 year who are given general anesthesia. And prolonged effects of general anesthesia might occur due to immature renal and hepatic systems, which delay the drug metabolism. And the most common thing we use is to prevent persistent post-operative pain. So coming to the benefits of regional anesthesia in children, I hope you can see this. The first one is a profound pain relief. It results in happy patients and happy parents, and also the happy hospital staff. It decreases the costs in attending to these patients. And there will be, if a regional anesthesia is combined with deep sedation or general anesthesia, we can reduce the MAC of the inhalational agents. All this reducing the MAC will lead to all beneficial effects in the children. It reduces the cardiorespiratory depressant effects. They avoid the possible airway instrumentation, reduce need for muscle relaxant, smoother and faster wake-up times, and patients will have a return of appetite sooner and quicker discharge from the post-surgery unit, post-surgical care unit. And physiological benefits are respiratory wise, they provide excellent analgesia. They decrease the post-op ventilatory support in major surgeries like thoracotomies or major surgeries the children undergo. Again, shorter ICU stays. There is a benefit to the hospital also. And cardiovascular, they decrease the hemodynamic instability, they decrease the blood loss. Coming to gastrointestinal system, if anesthesia is not given and opioids are given to manage post-operative pain, it leads to the opioids. What they cause is they decrease the gut motility and they decrease the splanchnic perfusion. If you use regional anesthesia instead, they improve the splanchnic perfusion and increase the peristalsis. And with the decrease in pain post-operatively, the host defense mechanisms are not activated. The surgical stress response is decreased and all. And in patients, in children who are very sick, and who are in whom general anesthesia is contraindicated, like patients prone to malignant hyperthermia and patients with severe respiratory disorders also, the regional anesthesia can make a difference. And in outside the operating room, some children might present in emergency, and they may be waiting for the operating room to be empty. In such patients, even in emergency, some blocks can be given and the waiting time can be reduced for the patient to undergo treatment. So coming to the key anatomical and physiological characters in children, which are different from adults. So this table is given in Miller, we all know. This is the classic table. This is a very important question to the postgraduates. And since our time, this table is increasing in size. The rows are being added but not diminished. So as research is being known, many differences are being known. So the first, I will discuss about the anatomical differences. In children, there is a lower termination of spinal cord. that is a conus medullaris and ends at L3 in neonates and in L1 in adults. So this level is not reached after till the child is not more than 1 year of age. So there is an increased risk of direct trauma to the spinal cord. So subarachnoid block or the epidural caudal block, whichever whenever it is performed, should be performed below the level of L3. The dural sac is also projected until the S3 or S4 level in the neonates. There is increased risk of CSF dural puncture during the caudal block. The bones and all the vertebrae are cartilaginous. The ossification nuclei are still active. By using sharp needles, we may damage this ossification nuclei, and the growth might be affected. So the implication is we shouldn't use excessive force, and if resistance is obtained, we should change the direction, but we should not go into the bone. And there is a lack of fusion of sacral vertebrae. This is due to persistence of the sacral intervertebral space. This makes the sacral epidural or caudal block, as we all know, possible in children. But this sacral spaces close as the child grows, and this sacral spaces fuse, and this sacral epidural caudal block, it is not possible in older children, or it may fail. So up to 6 to 7 years of age, we can use this sacral caudal block. After that, it may result in failure. Meninges are highly vascular. It leads to faster absorption of local anesthetic. Cerebrospinal fluid volumes are higher in children, like it is in 10 ml per kg in infants, while it is 4 ml per kg in adults. It is 2 ml per kg in adults. And this ratio of CSF in the cranium and the spinal cord, it is 50-50 in infants, while it is more in the cranium in the adults. So the duration of local anesthetic is shorter in the children, and need for higher doses of local anesthetic occurs in subarachnoid block in children. So nerves also are myelinated lately. So they may take up to 12 years of age to myelinate completely. So there is easier intraneural penetration of local anesthetic, and the local anesthetic can achieve a faster and prolonged sensory motor block, and low concentration of local anesthetic than needed in adults can achieve a quality prolonged motor block. The nerves supplying the vessels supplying the nerves are also highly vascular. There is faster absorption of local anesthetic and shorter duration of action. The diameters of all the structures are very small. They are superficially located and are compactly packed with minimal adipose tissues between them, so they are prone to injury. The epidural fat in the caudal space is highly fluid. So we get up to 6 to 7 years of age, we can give caudal block, and up to the thoracic level, we can even thread the epidural catheter into the caudal space up to the thoracic level, and we can achieve an excellent block. So there is a delayed development of curvatures of the spine. Only when the child holds her neck up or starts eating, the curvatures develop. So before that age, any epidural block, there is no needle orientation. Like in adults, you have to orient it in a certain way at the thoracic level, at the lumbar level. That need is not there in children. The Duffier's line, that is the intercrystal line, it crosses the L4 or L5 space in the adults, while it crosses the L5S1 space in the children. And loose attachment of sheaths and aponeurosis to underlying structure. This leads to diffusion, increased spread of local anesthetic along nerve paths, and there is danger of penetrating the remote anatomic spaces and blocking distant nerves. There is sympathetic immaturity, parasympathetic dominance, and decreased cardiac autonomic flexibility. All these lead to hemodynamic stability during the neuraxial blocks in children. While adults, bradycardia and hypotension are most common. So this avoids the need for fluid preloading and vasoactive agent use in children. And enzymes are immature in the liver. The cytochrome P450 enzymes are very immature. This leads to slower metabolism of local anesthetics. But this can result in local anesthetic systemic toxicity. There is increased mean body residency time and half-life with accumulation due to this, especially after repeat injection and continuous infusion of local anesthetics. There is increased cardiac output and heart rate, increased regional blood flow to the areas where we give the block, and increased systemic absorption of local anesthetic. And epinephrine is highly effective in this in children. There is low plasma protein contents of albumin and alpha-1 acid glycoprotein. This leads to increased unbound free fraction of the drug, leading to local anesthetic toxicity. Because the heart rate is high in the pediatric patients, the sodium gated channels are in the open state for longer time in the children. So this leads to local anesthetic cardiotoxicity. There is high propensity for cardiotoxicity. Because of increased extracellular fluids, increased distribution of volume, and mean body residency time of local anesthetics is present. And ill-developed descending inhibitory pathway is there in the children, which modulates the pain perception. So they poorly localized pain. And because of greater receptive field of neuron. And so good pain control is necessary to prevent development of chronic pain. Usually the children, there is delayed acquisition of body scheme and conceptualization. They are unable to recognize paresthesias or concept of paresthesia. They are unable to cooperate properly. So this needs heavy sedation or general anesthesia before giving the blocks to the children. Next, coming to the doses of commonly used local anesthetics in the pediatric patients. So this slide is very important. Usually what we use is bupropion and ropivacaine and levobutyrate. So the maximum dose per kg calculation is for bupropion and levobutyrate, it is 2.5 mg per kg, while for ropivacaine it is 3 mg per kg. Lignocaine it is 5 mg per kg. With adrenaline it is 7 mg per kg. In the spinal, for the central neuraxial blocks for spinal, we give depending upon the weight of the patient. Bupropion. It is less than 5 kg, 1 mg per kg dose of bupropion is given of 0.5%. 5 to 15 mg, 15 kgs, 0.4 mg per kg is given, and more than 15 kgs, then 0.3 mg per kg is given. In the epidural blocks, caudal usually in the epidural and caudal blocks, we decrease the percentage of the concentration of bupropion to either 1.25 or 0.125 or 0.25% bupropion. For thoracic, as we have to cover more dermatomes, we give more dose, more volume. While caudal, we give less volume. And for peripheral nerves, upper limb peripheral nerves, single shot, the dose is 0.5 to 1.5 mg per kg. And lower limbs, it is 0.5. It is the same. And facial plates, the dose is still more reduced, around 0.25 to 0.75 mg per kg. For continuous blocks, we give 0.1 to 0.125% solution. Again, the dose is calculated according to the weight. So given below is the ropivacaine dose. I will not go into the details. These are the adjuvants used. Morphine, fentanyl, and clonidine are most commonly used. Intrathecal dose is 5 microgram per kg. Fentanyl is 0.5 to 1 microgram per kg. And clonidine is 0.5 to 1 microgram per kg. Coming to the contraindications, the absolute contraindications are allergy to local anesthetics and the parent or patient user. Relative contraindications are infection at the needle insertion site, hemodynamic instability, vertebral abnormalities, pre-existing neurological deficits, and patients on anticoagulation. Coming to indications, the complications and their management. Uh, The general risks for all blocks are bleeding, infection, block failure, local anesthetic systemic toxicity, nerve injury, or intravascular injection. Coming to the central neuraxial blocks, these are the highlighted ones are not mentioned before. These, like for caudal epidural block, there can be total spinal leading to apnea. There can be osteomyelitis of sacrum, hematoma can occur. Epidural abscess, meningitis, radiculopathy, cystitis, all these can occur. And lumbar and thoracic continuous epidural spinal cord injury might occur. This may lead to paraplegia, total spinal anesthesia, and loss. So, spinal anesthesia is of short duration, but can present with complications include high spinal and shorter duration of block or failure of block. So this is a caudal anesthesia demonstration. We can see here the posterior superior iliac spines and the sacral cornua. The sacral cornua has the sacrococcygeal ligament that needs to be pierced. And this is the ultrasound picture. Here you can see the frog's eye appearance. Frog's eye appearance of the both sacral cornua. I am highlighting this because this is the most common pediatric regional block event. And this is a longitudinal view. We can see the sacral vertebrae and the sacral coccygeal ligament in the first picture. That space is that after ligament is pierced, there is a loss of resistance, and then we change the angle of the needle to become parallel with the skin, and then we enter the caudal space. Coming to common adverse events during neuraxial anesthesia, the common events are hypotension, pruritus, urinary retention, or pain on injection. The uncommon events are post-dural puncture headache. Rare events are permanent nerve damage, and very rare events are epidural abscess, meningitis, and epidural hematoma. If we thread a catheter to the caudal space, or if we place a lumbar or thoracic epidural, the epidural catheter, complications include misplacement, kinking, knotting, rupture, secondary migrations, and leakage around the puncture point, inadvertent catheter removal, or catheter infection. So, how to troubleshoot these complications? If there is a subcutaneous bulge when we are giving a central neuraxial blockade, it means needle is in subcutaneous tissue, we withdraw, reinsert, and seek the deburrate healing. If there is positive aspiration of blood or CSF, then we remove the needle, reinsert it, and make sure of negative aspiration and inject the drug in electrodes. There is arrhythmia or change in heart rate. It means that there is a undetected intravascular or intraosseous injection. Stop the injection, call for help. Basic life support should be instituted, and last protocol should be activated. If there is a leakage of local anesthetic around the caudal epidural catheter, we should accept that they do leak, but we have to ensure that they deliver analgesia and apply a pressure dressing. Soiling of the caudal epidural catheters are most common. The solution to this problem is tunneling of the catheter into the skin. So this applies a skin cover on the catheter and prevents the infection in the anal area spreading to the catheter. And if there are occlusions, we should make sure that all connections are appropriate. Rule out kinking of the catheter. And if there is drug accumulation, we should make sure that infusion does not extend for more than 48 hours. So if following neuraxial anesthesia, if there is any evidence of spinal cord dysfunction, the patient should undergo neuroimaging, preferably MRI. If MRI is not available, emergent CT should be done to rule out any compressive lesions. So most epidural hematomas and epidural abscesses will require emergent decompression. Neurosurgery and neurology consultation should be applied, and peripheral nerve studies and early electromyographic studies should be done to rule out any peripheral nerve injury. So coming to the peripheral nerve blocks, I have highlighted here what all blocks are given. Each and every block that can be given in the adult can be given in the children also. And these are some of the complications associated with the block. Most common blocks given are supraclavicular, the brachial plexus block. The complications are phrenic hoarseness, hoarse voice, Horner syndrome, intrathecal infection. All these can occur. Pneumothorax can occur. And for the abdominal wall blocks are also most commonly given. I'll just discuss this. This is the surface landmark techniques for all the blocks. I am not able to represent because of lack of time. No problem, I'll just tell you. This is the first diagram is showing the superficial nerves of the maxillary nerve. These the supraorbital nerve, here supraorbital nerve, infraorbital nerve, and the mental nerve. These blocks are very useful for the cleft palate and cleft lip repair. And the dose is 1 ml per kg. Like how you have to calculate the dose is, you take the body weight of the patient, of the child, you calculate the maximum dose of the local anesthetic allowable. Like you take bupropion, it is 2.5 mg. If the child is 10 kgs, you have to take maximum of 25 mg of bupropion only. And you dilute it because it is a peripheral block, a peripheral superficial block. You can just give 0.125 or 0.25%. So you dilute the maximum allowable dose so that you will get a 0.125 or 0.25% solution, and then according to the required amount for the block, like here it is a 1 ml per kg only for block of these superficial nerves. So you can take that amount and use it in giving the block. Okay, that is how it is done. And complications include penetration of the eye cord, damage to the ossification nuclei of the face. This is a superficial cervical plexus block. The dose is 1 to 3 ml per kg. Here complications may include hematomas. These are the brachial plexus and the axillary plexus block. We all know the indications for this. The dose is 0.3 to 0.5 ml per kg. And complications include pneumothorax. The dreaded complications include pneumothorax. Because I'll tell the reason for this. These are the abdominal wall blocks, the rectus sheath block, and tab block, and ilioinguinal and iliohypogastric nerve blocks. Doses for rectus sheath, it is 0.2 to 0.3 ml per kg. For the tab block, it is 0.3 to 0.5 ml per kg. And ilioinguinal block, it is 0.2 to 0.3 ml per kg. So intraperitoneal injections, intraperitoneal structure damage is the most common complication. So here is a paravertebral block and intercostal block. Paravertebral block, the complications are many. It can lead to hypotension, vascular puncture, pleural puncture and all. While intercostal block, the most significant, it is highly prone for development of local anesthesia systemic toxicity because the dose used is very high. We have to cover so many spaces, intervertebral spaces. And penile block, we all know it's an end artery, so adrenaline should be strictly avoided. And complications may include hematoma, arterial puncture, etc. These are the lower limb blocks. So coming to the local anesthetic systemic toxicity, this is discussed in detail. I'm not going to go into details. The early signs are, first we should be able to recognize the early signs. It's lightheadedness, tinnitus, blurred vision, and perioral numbness. Late signs include muscle twitching, drowsiness, generalized tonic-clonic seizures. Usually, all children will be under sedation, so they may not be able to say these early signs. Usually, we should look for muscle twitchings or any generalized tonic-clonic seizures. And as the serum concentrations in the local anesthetic in the blood increases, the cardiac toxicity also starts appearing. So coming to the management, first is the recognition of problem, call for help, stop injection of local anesthetic, and then take care of airway breathing circulation. Then definitive management is start intralipid infusion 20% immediately. Bolus is 1.5 ml per kg over 1 minute, followed by infusion at the rate of 15 ml per kg per hour. After 5 minutes, if serious stability is not achieved or if serious deteriorates, then 2 more boluses can be repeated 5 minutes apart. Then we can double the infusion rate to 30 ml per kg. This is the intravenous lipid emulsion. This is available actually in our hospital. This is the picture which I took. You can see this is it has the same composition as like propofol, but the propofol it is 10%, but this is 20%. So just don't dare to give propofol instead of this because it is not effective in these doses. Whatever propofol is there, the intralipid which is there in the propofol is not effective for correcting the toxicity. And next, coming to evidence for safety, there are two major research networks which have provided valuable insights. One is the French Language Society of Pediatric Anesthesiologists, and this studied 47 hospitals in France for a 10-year period of time, almost 10 to 15 years. And they have published 2 or 3 studies. And for pediatric regional anesthesia network, they have included data for more than 100,000 blocks in USA. So what they found, the most common adverse events are catheter related. They are benign catheter related, 4%. There was no permanent neurological deficits reported. The risk of transient neurological deficit is very low, 2.4 in 10,000 patients. And risk of severe local anesthetic systemic toxicity was 0.76 in 10,000 blocks. The majority of cases occurred in infants less than 1 year. The incidence of cutaneous infection rate was 0.5%. There were no hematomas or associated with neuraxial catheters, but one epidural hematoma occurred with a paravertebral catheter. And placing blocks under general anesthesia showed no additional risk. Then the French Language Society of Pediatric Anesthesiologists, they found that there is no increased risk to children having blocks performed under general anesthesia. But however, complications were 4 times greater in children aged less than 6 months compared to older than 6 months children. And usually they were minor. Overall complication rate was 0.12%, but it is significantly 6 times higher for the central neuraxial blocks than for peripheral blocks. So Cochrane review suggested that use of ultrasound guidance, it decreased the volume of anesthetic used dramatically. Coming to the safety measures, the infant safety is the top priority. Constant vigilance is needed. Appropriate monitoring, everything like pulse oximetry, ECG, and capnography should be instituted. We should first secure an IV cannula. If the patient is under GA and block is given, we should be mindful of the face mask, laryngeal mask, airway, and endotracheal tube by giving the blocks. Disconnections might occur. Selecting a block that aligns with the surgery specific nature and anesthesiologist expertise is necessary. Meticulous dose and volume calculations are crucial. Appropriate sized equipment of the needles, catheters, etc. should be selected. Local anesthetic should be injected with repeated aspiration in electrodes, and each electrode should be treated like a test dose. Vigilance and awareness is needed while injecting the local anesthetic. We should take care of, we should monitor the respirations, pulse oximetry, heart rate, etc. The American and European societies of regional anesthesia, they have proposed a practice advisory to prevent and treat infection, hematoma, and local anesthetic toxicity. Aseptic technique should be used always. Chlorhexidine was found to be superior than the betadine, and tunnel catheter is preferred when using a caudal route for inserting an epidural catheter. Daily inspection of the epidural catheter insertion site should be done. Uraxial and deep peripheral blocks are contraindicated if coagulation tests are abnormal. And to use of ultrasound to reduce the vascular puncture to prevent the blast. Then some more things to take care of are optimal location for performing regional block. It should be a fully equipped operating room with appropriate infrastructure and team to handle emergency. We should never shy from giving sedation or general anesthesia if the child is not cooperative. This prevents damage to important structures. If the child is struggling, always better to give sedation. Vital parameters, everything should be monitored. The doses of the technique and doses of local anesthetics should be reported detailedly in the anesthesia chart. Then after giving the block, assessment of the block should be performed meticulously. Post-operative monitoring in recovery room should be done without fail. Discharge criteria should be formulated in the institute for the child to discharge after single shot procedures, and continuous regional techniques when the patient is on infusion, epidural infusion. Some proper monitoring should be there. 5 minutes. You should avoid the high pressure nerve injections, more than 15 PSI. Then older techniques like paresthesias or transarterial techniques for axillary blocks and swoosh test for the caudal block should no longer be used. Epidural catheters should not be inserted more than 2 to 4 centimeters into epidural space, and continuous infusion should be limited to 48 hours. So last and but not the least, our checklist should be included. Perio to perform the pre-block timeout, and the perioperative team not speaking up when the block was incorrectly performed are contributing factors to harm to children. So this is an example of one such checklist where the last there is a column for if a last rescue kit is available or not ready. So coming to controversies, test dose. This is always controversial in children. Usually we give epinephrine 0.5 microgram per kg, but the children already the resting heart rate is very high. We give atropine as a pre-medication. So using a test dose with epinephrine is usually does not reveal additional information, or it does not change from baseline much. So what the others are mentioning is that instead of looking for increase in heart rate, we have to monitor the ECG changes. If there is a more than 25% change in T wave or ST segment, irrespective of the ECG need, it is considered by some to be more specific and more reliable for intravascular injection of local anesthetic. Here we can see the upper figure, that's the baseline, and the lower figure after injection of local anesthetic with adrenaline. There is an increase in the T wave height, T wave and ST segment height. So these changes also should be looked for. So again, awake versus asleep box. A calm patient is always preferred in the pediatric regional anesthesia, so better to sedate or intubate. And compartment syndrome. Usually, regional anesthesia and compartment syndrome, there is no convincing evidence that acute compartment syndrome diagnosis is delayed because the pain is not felt by the child. But it is said that regional anesthesia will actually allow for earlier detection of acute compartment syndrome because the pain in the acute compartment syndrome will be out of proportion to the block place. So it can be detected early. And usually, if acute compartment syndrome is suspected, the guidelines suggest using a lower concentration of local anesthetic. And coming to loss of resistance, both to saline and air have been used, but it is prudent to not use air more than 1 ml in the pediatric patients. And if repeated attempts are made, then the air injection should not be repeated. Take home message is choose a less toxic drug, do not exceed the maximum dose, inject small electrodes and aspirate repeatedly. Ultrasound, use ultrasound if available. Beware of repeated doses and limit infusions in units to 48 hours. The epinephrine test dose containing test dose may be used, but always ECG should be monitored. And last but not the least, the child should be monitored continuously. So these are my references.
Thank you, ma'am, for the informative presentation. Now the session is open for any questions or discussions. Now, I would like to request Dr. Shrija, ma'am, Assistant Professor James, to kindly comment the Elizabeth ma'am as a token of gratitude. Now it's time to take a short lunch break. Before that, I'd like to request all the respective speakers and dignitaries to kindly come on the dais for a small photo session. Others can kindly proceed to the lunch area for the lunch.
Also, there is an exciting quiz at the end of today's session. So, interested postgraduates can submit your names and also exciting prizes. So, please kindly come forward and submit your names.
Lunch coupons are there in your files. I'd like to request Dr. PDP Shubhalakshmi ma'am, Dr. Murli Krishna sir, Dr. V. Ramaya ma'am, Dr. Shweta ma'am, Dr. Vashokta ma'am, Dr. Anisha ma'am, HOD Dr. Shankarao sir, Pradeep sir, and Ashok sir to kindly come on the dais for the presentation. Instead postgraduates, instead for the quiz at the end of the session, kindly submit your names.
అనుష అనుష చూడు అది కనపడదు అంటే అది వర్క్ పవర్ పాయింట్ లో ఇచ్చుంటే అయిపోయేది వాళ్ళకి ఓకేనా అలా నా బ్యాగ్ నా రూమ్ లో ఉంది కావాలా కాదు తను అడిగింది ఉందా అని అడిగింది ఇక్కడ లేదు
అంటే నేను చెప్పేస్తాను సపోజ్ ఉంటాను అది నా టైం చెప్పేస్తాను చాలా బాగుంది. పడవద్దనే అలా పెట్టింది సార్. పడదు పెట్టదు. నువ్వు కొన్ని చేయలేదు. ఏం తీస్తావు? అక్కడ ఇంటికి తెచ్చిన రోజు అన్ని ఏదో సర్టిఫికెట్
We'll now move to the next seminar presentation by Dr. B. Anisha ma'am. Now I request Dr. Anisha ma'am to come on to the dais for a presentation on the topic enhancing patient safety in NORA, challenges and strategies. Dr. Vangapur Anisha ma'am is currently working as assistant professor in NRA Vizag. She completed her undergraduation from Katuri Medical College, Guntur, and post-graduation from NRA Medical College, Mangalore. She has a working experience of over 6 years and has made quite a few publications. Good afternoon, everybody. Shall I start? So I'll not take much of your time. Please be patient. For 20-25 minutes, I'll finish it. So today my topic is enhancing patient safety in NORA, challenges and strategies. So I'm from NRA Institute of Medical Science, Nagarapalsa. I'm working as assistant professor there. So coming to the definition. So non-operating room anesthesia refers to all procedures performed in outside operating rooms, okay, which are called as offsite locations. So historically, cases managed outside operating room are generally stable and minor, but now they evolved into complex cases which are needing ramified interventional strategies. So, however, in the current era, they're involving and demanding anesthesia services. So this is one of the example for NORA interventional suits. And coming to the today discussion, so we are not discussing about how we are delivering NORA to each and every case. Just I'm giving an outlook. on what are the challenges and tasks we are facing these days, and what are the types of procedures generally coming under NORA to which most of the anesthesiologists are not exposed. So, coming to novel characteristics of NORA cases. NORA cases are characterized by a triad of features, that is location, operator, and relative novelty. Location means these are situated far away from the not regularly operating rooms. Operator means interventional proceduralist, who is a not generally he is an interventional physicist rather than a regularly favorable operating surgeon, who we are very much familiar with. Okay, so relative novelty is the evolving comprehensive strategies which are getting familiar to interventional physicists but not to the anesthesiologist. So, what are the unique obstacles we are facing? So, lack of visibility of procedural screens. So, the technical experts who are situating outside the interventional suite are generally aware of what's going on and what is the next step. Okay, but the anesthetist who is placed readily, very much bedside of the patient, is not getting aware of what is happening or what about the hemodynamics which are fluctuating because of the fluoroscopy screens or the perpendicularly operating CM machine. Okay, which will be very much intervening between monitors and the anesthetist. So, no proper gas scavenging and no oxygen and proper suctioning. Not the ventilator also sometimes. So, generally we are lacking pre-procedural evaluation. Why? Because of improper anesthesia scheduling time for non-operating room procedures. Generally, a central office will schedule the cases which has totally nil medical knowledge about which case needs anesthesia backup, which case may not. So, because of this, resources are deploying, but anesthesia services they can't be able to utilize properly under utilization of anesthesia services. So, what are the operational constraints? Variability means less flexibility in the staff which are allotted to the non-operating rooms. So, today one staff member will come, and after 2-3 days, the same staff member will not be appearing in the same operating room. So, which is leading to unfamiliar NORA situations. So, likelihood of underutilized but deployed services, a lack of storage space for anesthesia equipment. So, we can't even store a regular basic emergency anesthesia equipment also in the non-operating rooms, as already you people have exposed to MRI suits, CT suits. Whenever we need to go for any procedure, we will carry everything from the operating room. So as I have already told, no proper pre-procedural evaluation, so we don't know about the NPM status, nor about the patient's past medical history, nor about his allergic history, okay, nor about his health complications. Now, basic guidelines for NORA locations. So, reliable oxygen source with backup e-cylinders and reliable suction source should be there, and proper scavenging system should be there, well-equipped anesthesia machine, sufficient safe electrical outlets. So, if any problem is occurring in the outlets, again we have to run for technical expertise, which is not readily available at the NORA rooms. So, adequate information, sufficient space for easy access, emergency card, a reliable two-way communication, which is very much important between the interventional proceduralist and the anesthesiologist, which is lacking nowadays. Interventionalist will have a separate time in his brain, and he will change it according to the procedure, but he will not discuss with the anesthesiologist. So, how can we ramify our anesthesia plan? It is in vain. So, a reliable two-way communication to request assistance, a compliance with the facility without applicable safety and building codes. So, transitional priorities for anesthesiologists outside of the operating room. Transitional means, see, for many years, NORA has been evolving. So, it is not same each and every year. So, present anesthesiologists should take the responsibility of standardizing and prioritizing their anesthesia plans according to the present evolving technical needs. So defining interdisciplinary safety in non-operating room locations, that is standardization, reliability, and communication. So generally, anesthesia will depend upon his routine working environment in the routinely operating rooms. So, and surgeons also, he will be working with a separate sector of surgeons who will be working regularly in the operating rooms. But now he has to work in a new environment where there is lack of space, with no sufficient, with no familiar anesthesia team and no familiar surgical team. It is a totally physicist team. Okay? So, environments that facilitate safety and reliability or encouragement of continuous learning and accountability, responsibility, teamwork support, database, and effective communication, which will be explained in the next slides. So, continuous learning means, so anesthetist should also know, he should have a basic knowledge. Whoever anesthetist is allotted for a particular procedure, he should have a basic knowledge on whatever the step is going on and what is the next step planned by the intensivist. So data acquisition means he should, the data in the particular intervention suit must be very much readily available for the anesthetist regarding what are the previous procedures done in this suit and what are the general anesthesia or anesthesia backup services used for those particular procedures, so that he will have a prioritized and standardized manner to plan the present case. And culture of accountability and responsibility means everything will be good if the case is good, but if any event happens, it should not be a blame game. We should not blame the system, nor we should blame each and it should not be converted into a dispute between the surgeon and the anesthetist. So in a culture of accountability, individuals are held accountable for their actions, but not for system failures. So teamwork structure means jobs must be clearly defined and a constructive debriefing with a reasonable time frame. Okay, so leadership take the required steps to ensure this plan. So effective communication and flow of information. As I already said, it should be close and loop communication between the anesthetist and the proceduralist. Now, new non-operating room anesthesia sites. So, the evolution of cases and the broadening of target patient profiles can render even well-conceived units inadequate. No matter what type or level of anesthetic care is provided, an anesthesia ventilator should be present or readily available in all rural locations, because conversion to general anesthesia is always a possibility. So, but whatever the intervention source we are facing today, they are not having any ventilator setup. So adequate pre-procedure, post-procedure care space should be available. So generally we don't have a post-procedure care space in an interventional suite. We must ensure that we should have a recovery unit for the follow-up of the particular patient receiving NORA care. So it is certainly standard of care that an anesthesiologist be available during this recovery period. And ASA standard for basic anesthesia monitoring may serve as a fundamental guide. So monitoring in non-operating room anesthesia locations. So how will we monitor and what will we monitor? Normally, whatever we monitor is only pulse oximetry. So adverse events occurring outside of the operating room may in fact be associated with more deleterious outcomes and serious injury when compared to operating room, because emergency equipment and drugs are not very much readily available, nor the mechanical ventilator, nor the hemodynamic monitors also. So, the last 20 years, capnography has become the standard of care for monitoring not only for ventilation but also for circulation and metabolism by directly measuring expired carbon dioxide levels and indirectly measuring production of carbon dioxide at the tissue level and delivery of carbon dioxide to the lungs. So, despite broad utility and clear clinical superiority, capnography is not always available in non-operating room locations. Even in very much needed IC units also, sometimes we'll miss the capnography monitoring for even ventilator cases. So anesthesiologists providing services outside operating room, however, may find themselves explaining the shortcomings of pulse oximetry relative to capnography, particularly when discussions arise regarding purchase of new equipment for new neural locations. So these are financial constraints also. When anesthesiologists are called to step in during failed sedation cases, the absence of capnography equipment can be life-threatening and make case management very difficult. So pre-procedural evaluation for non-operating room anesthesia cases, and what are the additional considerations. So ASA guidelines for pre-anesthesia evaluation is patient interview should include a physical examination and a review of his past medical history as routine PAC, okay, and diagnostic laboratory tests and other relevant diagnostic information as all you know. So ASA status will be assessed as such. And then formulation of potential anesthetic plan and ramification of the plan if needed. So additional concerns in the non-operating room locations make some comorbidities more problematic outside of the operating room. Okay, what are those? Generally beds with lower weight limits. So they won't have a specific plan for morbidly obese patients. Procedure suits for colonoscopy have beds that cannot be placed in Trendelenburg or reverse Trendelenburg position. So anticoagulation status also, we can't assess properly. Definitely it's an issue. Like in some examples for thrombolizations and embolectomies, we will follow anticoagulation prior to the case till until the prior day also. So, but we have no prior assessment of PTINR or anything else, and the patient will be posted as such on the emergency basis. So, renal status also, maximum in renal failure cases or whatever, they will plan the case, but renal status will not be assessed priorly to the case. So, during percutaneous procedures, bleeding may be occurred and the potential need for transfusion should be addressed pre-procedurally. So, we don't have a proper time for counseling them also. Regarding explanation about bleeding and cross-matching or arrangement of blood reserve and everything. So, patients with extreme anxiety like claustrophobia, chronic pain, mental disability, movement disorders, obesity, and obstructive sleep apnea or those who are at the extremes of ACE and may not tolerate some extreme stimulatory procedures. So coming to gastrointestinal procedures in this NORA suits. Esophagogastroduodenoscopy, as already you have already must have seen. So the most difficult parts of this procedure are passing the scope into the esophagus and through the pylorus. So important and potentially stimulating therapeutic undertakings during endoscopy include just like hemostasis, biopsies, stenting, like in onco cases. Okay. So what happens? These are so many complications occur during this procedural things. So most patients tolerate this procedure well with opioid or benzodiazepine sedation or topicalization. But for those at risk for obstruction or aspiration, hemodynamically unstable children or very anxious patients, general anesthesia is a good option. Or you can go for Procil laryngeal mask airway. But what is the problem is this gastric endoscopic suits, endoscopic equipment also should pass through the same ports. So driving the inhalational gases and everything will be again a problem. So next, specific interventions during sigmoidoscopy and colonoscopy constitute additional stimulation, including introduction of the endoscope, colonic insufflation, advancement of the scope, and additional interventions such as biopsy, polypectomy, like colorectal carcinomas, like those, stenting, dilatation, mucosal resection. So in these cases, the potential complication is again bleeding, perforation, and if the surgeon is dealing with carcinoid tumors, what happens? Again, hormonal adverse events, landing the patient into shock. So new studies looking at patient-controlled sedation pumps, which are still under study. So ERCP, coming to endoscopic retrograde cholangiopancreatography. So it includes procedures like sphincterotomy, hemostasis, stent placement, stone extraction, pancreaticobiliary visualization, laser lithotripsy. So here what happens is patient will be placed in prone position. That is what our main concern is. So we have to decide initially only whether the interventionist have a deep evaluating the tumor plans like taking the biopsy in a normal way, or he has any specific plans on further visualization of the tumor, like that we have to discuss with him, and we have to tell him priorly only that GA may be needed for this case as a patient will be prone Again, if you need deep sedation, the patient may land into hypoxia, like that. And regarding hemodynamic monitors, the risk-benefit analysis, everything have to be discussed priorly only. So natural orifice transluminal endoscopic surgery, the next frontier. So here it represents an approach to abdominal peritoneal procedures that integrates the perspectives of endoscopic medicine and minimally invasive surgery. So these are the minimally invasive surgeries, which approaches the decided organ through natural orifices, like vagina or through oral cavity, like that. So, example, through oral gastric approach, they're removing the gallbladder. Transvaginal approach, they're reaching the gallbladder. Like cholecystectomy means they are also performing through other natural orifices also. So, the use of nodes in humans is in the very early phases. So, transvaginal and transgastric cholecystectomy. So, these cases have required a pneumoperitoneum and general anesthesia. So why we are discussing it here? Because these are also considered as a NORA cases nowadays. Okay. So other common bronchoscopy procedures. So endobronchial stenting, placement of self-expanding metallic stents to treat stenosis, and endobronchial biopsy, laser treatment and cauterization, balloon dilatation, cryotherapy. These are all coming under NORA cases. Some of the examples which cannot be explained in brief with this limited span of time. So what are the novel anesthetic concerns? So instrumentation of the airway and insertion of the biopsy or therapeutic equipment, as I already said before, it will compromise delivery of inhaled anesthetics to the patient and potentially pollute the procedure room. So you can go for TIVA like propofol, remifentanil, dexmedetomidine. So, but they need some monitoring because it may cause some deep sedation to the patient. So use of muscle laxants may be needed to prevent gagging or cough reflex sometimes, which may need again TIVA. Okay. So nowadays we are relying on jet ventilation and high frequency jet ventilation have been increasingly used as a strategy to provide a static field during therapeutic and pulmonary interventions. Diagnostic and therapeutic interventions, new challenges. Interventional procedure suits impose constraints not normally encountered in the operating room. Additional considerations that emerge in these environments include, first of all, equipment layout. So, use of several infusion pumps, then monitoring the PM lines, and the use of extensions on the ventilatory circuits. These all are a potential for mishap. So, blood warmers, imaging screens, and other monitors. So anticipating events is therefore difficult unless good communication occurring between the anesthesia and the procedural team. So what about the radiation exposure as low as reasonably achievable principle? Means it's not a numerical limit. It's an ethical limit. So you yourself has to limit your radiation exposure through limiting your distance, duration, and shielding from the source. So the radiation beam attenuates based on the inverse proportionality to the square of the distance from the source. So coming to the contrast material, generally high ionic contrast materials lead to most of the adverse events occurring in the NORA. So better shift to low ionic contrast materials. So oxygen, epinephrine, bronchodilators should be very much readily available in these suits. And pre-treatment of patients who had already previous history of this event with steroids and diphenhydramine. But the steroids, studies are showing that these steroids are not bringing much change in the edema events pre-procedurally and post-procedural comparison when we do. Okay, so the use of low osmolality contrast further reduces the risk for adverse reaction. Prophylactic protection strategies including a combination of peri-procedural hydration, using administration of soda bicarbonate and MSTN systems. What about the bleeding? As we already discussed, it's a serious concern, especially in patients receiving anticoagulation patients. So the recommended INR, it should be less than 1.5, platelet count greater than 50,000, and warfarin should be held 5 to 7 days, clopidogrel or aspirin for 5 days, fractionated heparin for 12 to 24 hours. So what about the vascular interventional procedures? Angiography, the general term for imaging of blood vessels, includes arteriography and venography. It involves activation of images during injection of contrast material. This definition, I know you people know it already. So, complications to anticipate include bleeding during thrombolysis, undesired embolization of nearby structures during embolization, and vessel disruption. So, generally, in these angiographies, thrombolectomy and embolization procedures will be add on. So, we should be very much ready for the adverse events occurring when by mistake embolization of the nearby structures may happen, and thrombolysis may lead to unanticipated bleeding issues. So, what about the histograms, graftograms, and tunneled hemodialysis lines grouped collectively as hemodialysis vascular access procedure? As you people already know, you must have given some regional anesthesia for these procedures, and sometimes TIVA. So patient evaluations, like any procedure requiring anesthesia care with special consideration, should be placed on volume status. Because hemodialysis lines means already the patient is on the verge of renal failure. So you should see the plasma potassium and visible ECG changes. So care must be taken to weigh the risks and benefits. So whether we have to proceed with this case now or not, whether to cancel it for now or postpone it. Okay. So moderate sedation, visual anesthesia, normally. So percutaneous interventions for oncology. So anesthesia services are frequently used as these patients are truly high risk of surgical intervention. So general anesthesia works best as the interventions may be intermittently painful, control of breathing may be optimal, and the patient cooperation may not be compatible with the level of sedation required. So sometimes control of breathing may be needed to prevent the shifts in the equipment focus, so that the proceduralist can take the biopsy or whatever very precisely. Example: transarterial chemoembolization and percutaneous ablations, okay, which are directed at the tumors. And if cryotherapy it's of less pain, but with radio frequency ablation, it involves a coagulative necrosis of temperature around 5 and greater than 50 degrees centigrade, which causes a greater stimulation to the patient in the form of pain. Okay, gastrointestinal and genitourinary interventions. The most common of which is the percutaneous gastrostomy tube. Other variants include cecostomy and jejunostomy tubes. So, as already you know, the common complication is bleeding. Along with it, violation of adjacent structures and peritonitis is also an issue. So, in many cases, these procedures can be tolerated with normal TIVA sedation. So, except in situations where patients are at high risk for gastric aspiration, where you have to think about the airway protection again. So, most common genitourinary intervention procedure we perform is nephrostomy tube placement. In formulating the anesthesia plan, one must carefully weigh the risks and benefits of prone sedation versus general anesthesia again here. So factors to take into consideration include patient habitus and hemodynamic condition, and what about the skill of the procedure list and the duration of the procedure. So procedures guided by computer tomography, positron emission tomography, and magnetic resonance imaging. So CT guided biopsies. So generally, you must have seen liver biopsies like that. These are usually performed with the patient supine or slightly oblique. Sometimes retroperitoneal masses may require lateral decubitous or prone position. So task is, in case of carcinoma tumors, hormonal surge. Okay? And it needs a consistent level of sedation. So therapeutic interventions means catheter drainage of abscess. Okay? Which may induce septic shock also. So computer tomography guided ablation means, so with the help of the coils and catheters, generally alcohol or phenol will be introduced. So inadvertent injection into the vascular structures may land the patient into shock again. And post-ablation syndrome like flu-like syndrome due to inflammation induced by the dying tissue. So CT guided injections for pain management, like steroid injections in the joints like that. So MRI guided interventions ensure MRI compatible devices everywhere, because otherwise It may lead to error in the readings of the hemodynamic monitors. Not only that, they may become a missile in the MRI suite. So diagnostic cerebral angiography, this also coming under the NORA. So here, what is the need? There's a need for still patient, long procedure durations, and hemodynamic perturbations that require management by the anesthesiologist. On the other hand, carotid stenting can be done with the patient awake to facilitate neurological assessment. So we have to counsel the patient on this basis. So stent implantation for binded cerebral aneurysms, so which may need anticoagulation, pre and post procedure. Complications include aneurysm rupture or thromboembolism. So embolization of post-atrium vessels precipitating rupture, passes of embolic material into pulmonary circulation is also again become task of the time. So what's the take-home message? It's clear that we must extend the recognized realm of our specialty beyond the limits. So inclusion of the procedural areas within our practice requires a new model of service delivery. Okay, thank you. Thank you, ma'am, for the wonderful presentation. Now the session is open for any discussions and queries. Thank you. Now I request Dr. Sahiti, ma'am, Assistant Professor, please come on to the level and felicitate with a moment.
Thank you, ma'am. Now we would like to request Dr. P. Vasundhara ma'am to come on the desk for her presentation on the topic managing the unexpected, difficult airway challenges and innovative solutions. Sorry, ma'am, for the inconvenience and delay. Dr. P. Vasundhara, currently working as an assistant professor in Visakhapatnam, has completed her undergraduate from Sri Siddhartha Medical College, Karnataka, teaching from Kamini Hospital, Nalgonda, and a fellowship in IDCCM. Has a working experience of 8 years and an area for interest and academic research. She is a gold medalist and the best medical officer from CFA.
Thank you for the wonderful introduction. Welcome back to the post-prandial drowsy session for the day. So I hope I'm not echoing, right? Everybody is clear. Okay. So our topic is going to be unanticipated difficult airway challenges and solutions. What are the difficulties are we anticipating in any scenario where there is unanticipated bag and mask or difficult intubation? These are the two scenarios we are going to discuss, and what are the other methods you have to inculcate if you are facing any difficulty. So coming to the bag and mask ventilation, the steps will be like pre-oxygenation. First you will pre-oxygenate the patient and then you will hold the bag. So we'll be discussing how to hold a bag and positioning maneuvers and primary airway manager position. All the side headings which we are going to discuss are very important and very helpful to increase everybody's skills. So why do we have to pre-oxygenate the patient? Anybody? I think already in postprandial in a setting. So to understand this concept, I like to tell you some of the basics that is happening in the lung. So in the lung, in what is FRC? Functional residual capacity, that is the amount of volume of air that is present in the lung after expiration. So in that FRC, what is the amount of oxygen? It comes to 273 ml of oxygen. It comes to 273 ml of oxygen. And what is the oxygen consumption rate? It is 250 ml per minute. So if you see the difference is 23 ml. So you will be normally having 23 ml of oxygen as reserve. So which will take 60 to 70 seconds to desaturate. And if we pre-oxygenate, this 60 seconds of margin is going to be extended to 3 to 4 minutes. I'll be discussing about the shunt after the next slide so that you will understand it better. So why do we have to pre-oxygenate only for 3 minutes? So our main funda is what? We have only a reserve of 23. We want to increase that reserve so that we can have a maximum safety margin time to do your intervention, whatever it is, bag or mask, intubation or whatever. So our motto is to increase the amount of oxygen or the reserve that we are having in the lung. That is the FRC. So first thing is, if you consider the alveolar gas equation, the alveolar oxygenation will increase. See? So this alveolar oxygenation will increase if you increase the inspired oxygen concentration. So that is our funda. So we are keeping it as 100% oxygen while we are pre-oxygenating. And the second mode is you're denitrogenating the lung. So in FRC, when you are inspiring, you will inspire a room air which has 21% of oxygen and 78% of nitrogen. So you are denitrogenating or taking out all the nitrogen and replacing it with 100% oxygen. So how do you know that it is 3 minutes? So it is always governed by nitrogen washout time. What is this nitrogen washout time? That means it is taken as a time constant. What is time constant? The amount of time required for the concentration of nitrogen to come down to 37% is taken as one time constant. So how much you want to remove the nitrogen? Almost 100%. So 98% of the nitrogen, if it washes out, we will take it as 4 time constants. So time constant is nothing but FRC divided by effective alveolar ventilation. So that is what I've written. 37% of washout is one time constant. So always remember FRC is taken as 30 ml per kg, anatomical dead space as 2 ml per kg, and tidal volume as 7 ml per kg. So to understand it in a better way, let's have a look for 70 kg patient. So it is 30 ml per kg. So it comes to 2100 ml. Tidal volume is 490. Respiratory rate in this case I've taken as 12. So anatomical dead space is 2 ml per kg, which comes to 140 ml per kg. So then one time constant is FRC by effective alveolar ventilation. So we are minusing the anatomical dead space from tidal volume, that is 490 minus 110, which comes to 350 ml. So 2100, if you calculate, it comes to 0.5 minutes. So like that, that is one time constant. How many time constants we need? 4. Thank God, you people are not yet drowsy. So we need 4 time constants. 4.5 into 4 is 2. But still we have kept 1 minute as our safety margin. So do you think the safety margin would be enough? Even if we have kept 1 minute as a safety margin, so the studies revealed that it was not enough. So next comes your pre-procedure preparation. Now you got to know why do we have to pre-oxygenate the patient for 3 minutes. So I told you, I'll just go back to this point. Nobody has reminded me about it. So why I have kept this shunt? I want to tell why there is no benefit with oxygen. What is shunt? Shunt is the alveoli that are getting perfused but not getting ventilated. That means in the cases where FRC is low, that is, it is not 2100. Say for example, if it is 1800 ml. So to pre-oxygenate 1800 ml, you need lesser time or more time? Obviously lesser time than 2100. And what it tells? It tells the time to desaturate is decreasing or not. Your time constant is directly proportional to FRC. FRC is coming down, your pre-oxygenation or the safety window is also coming down. So whenever you are pre-oxygenating the patient, whenever the patient is attaining your pre-oxygenation fast, that doesn't mean that you will get the same safety margin as that of 3 minutes. So how are you going to know whether this pre-oxygenation is what is required is 3 minutes or not? So in such cases, in such patients, what are you trying to, what is your rescue other plan? So you have increased FiO2 to 100%, but still your pre-oxygenation FRC is low. So what is the other method where you can improve FRC? So whenever your FRC is coming down, that means your closing capacity will go up. So you try to ventilate the patient or you try to inculcate PEEP in your pre-oxygenation. So how do you know that this 3 minutes is not enough? That is why we got a tool. What is it? It is called pre-oxygenation. We will just switch to pre-oxygenation tool. Before that, always remember every institution will and should have this emergency airway rescue team. What is it? Every day for about 2 to 3 months, we will fix the team. In that team, we will assign the roles like primary airway manager, who is most likely the anesthetist, and the assistant, it should be a junior JR or SR, and then timekeeper. Why time is more important? Everywhere time is very important because you want to prevent hypoxia leading to cardiac arrest, brain damage, so many things, right? So the time you are having is very important. And an observer. Observer is always important to again debrief the event, what has happened, how you have to improve. And irrespective of the case, you should always conduct a comprehensive airway assessment, which includes same fatafat we will be doing in PAC, history, Malam scoring, thyromental distance, mouth opening, neck mobility, focus if needed. So coming to the pre-oxygenation tools. In the pre-oxygenation tools, because see, if you are keeping it as a time constraint, you are not able to tell whether the patient is adequately pre-oxygenated or not. That is why there is something called as ETO2 monitoring, that is end tidal oxygen monitoring. So you should always make sure that the end tidal oxygen concentration is always above 85% to maximize the safety window. What is the apneic time? It is a time taken following cessation of the breathing to drop in your saturation of 88%. That is your apneic time. So you will put a ETO2 monitor to the mask. You will see if the monitor shows above 85%, that means you have adequately pre-oxygenated the case. The case is not showing 85 despite your attempts. You try to apply some PEEP, attain above 85 somehow, and then this is how an ETO2 monitor looks like. I have not seen. Some of my senior who works in Dubai has shared me this picture. He has it. And also, what do we have now? We have ETCO2 monitoring instead, which is a marker of ventilation. So we will try to use ETCO2 monitoring and see whether the bag and mask we are doing is proper or not. I think everybody knows how an ETCO2 monitor looks like. And now coming to pre-oxygenation and para-oxygenation. So pre-oxygenation, you have decided the time of 3 minutes. And what is para-oxygenation? Anybody? I'll give you a hint. Para-oxygenation is also called as apneic oxygenation. So anyone? The name itself suggests it's apneic oxygenation. So if the patient is having apnea, During that apnea, you try to keep oxygen delivery. Like how? Via nasal cannula you can keep, via HFNC you can keep. So why is it so necessary? So what is the mode of delivery of oxygen or carbon dioxide across the body from lungs to the tissues? It is by, yes, very good. It is by diffusion. So that is the same mechanism we are applying. We are trying to put HFNC in the apneic period so that your upper airways will act like a nidus for your rich oxygen. So by this, the raise of carbon, see, in this process, we are maintaining the pre-oxygenation or the oxygen reserve, but we are not improving the reserve. We are maintaining whatever reserve we have obtained through pre-oxygenation. We are maintaining it through HFNC. And the second point is we are not removing carbon dioxide. So obviously there will be accumulation of carbon dioxide. So there was a study between the raise of oxygen or carbon dioxide with HFNC, with nasal cannula, with oropharyngeal airways, so many studies. So why we have come, what conclusion have we come is the raise of carbon dioxide per minute when you are using HFNC, it is much more lower. Why are we more concerned about this carbon dioxide? Because whenever oxygen, what is had an effect? No, okay. So whenever oxygen is high, this oxygen will have a higher affinity for your Hb, displacing the carbon dioxide to the plasma. So the carbon dioxide will be, instead of escaping back through the airways, it is not possible for carbon dioxide to come out. So it will go into the plasma. So if carbon dioxide goes into plasma, it causes acidosis. So, and this raise of carbon dioxide, it is 8 to 10 in first 10 seconds or 1 minute, and from then it is 3 to 4 mmHg. So this raise was observed much lower with HFNC. That is the reason why. And if you use HFNC in apneic oxygenation, they said we are able to maintain the oxygen reserve that is present in FRC for about 22.5 minutes, which was, I didn't believe it. I don't know. So that is why whenever you are anticipating or whenever you faced any difficulty pre-oxygenating the case, so definitely go for HFNC. If you are not equipped with HFNC, even bag and mask ventilation is also not as efficient, but still. And then you can use, if you are very sure about the NBM status, you can also use the non-invasive methods like CPAP and BiPAP, depending upon the patients. Again, if it is obese or obese and then on NBM, not on full stomach, seeing all those pros and cons, you can either go for either of the modalities. So now you have decided 3 minutes, depending upon 3 minutes or more or less, depending upon your ETO2 and CO2 monitoring. Done. Then you have used, whether you have decided whether you want to go for apneic oxygenation or pre-oxygenation techniques. Done. Next, you want to hold the mask. Does small hands matter? Anybody know that? During my PG days, I used to think that, I faced a lot of difficulty doing bag and mask. Always my seniors used to grab. I used to think, okay, maybe even my husband didn't know. He just he has seen my hands and said, "Your hands are very small. Probably that would be the cause you are not able to ventilate." I was like, I took it light because okay, whatever it is, I'll practice and I'll put it, make it perfect. So later on, when I came through the study, I was very much astonished because it is true that your small hands are going to make your ventilation definitely difficult. So what are the modifications you are trying to do if you are having small hands? What are small hands? Immediately after this, I'll project an article. You can go through in that. He has taken a hand span, hand length, something to tell your hands are small. Okay. So your answer is yes or no? Does small hands make ventilation difficult? Yes. So how are you going to modify your ventilation? So then there came a study which is CE versus VE technique. See, now I'm going to discuss only two-handed technique because this is anticipated difficult ventilation. So with single hand, until unless you are the sole rescuer, we are not going to do it. So I will talk first about two-handed technique. So when you compare what is C, what is V? CE technique is you are going to make a seal on the mask and your third, fourth, fifth on the mandible. Okay. VE technique is you are using your thumb and the thenar eminence as your seal and you are lifting the jaw. Okay. So in this, one more maneuver is also involved in a better way than CE. So what we have observed is the tidal volumes which are delivered were better with VE technique than CE technique. But the amount of peak airway pressures generated were always less than 15 centimeters of water, which tells you that there is very less insufflation, gastric insufflation. So if you are having small hands, what are we going to do? Directly go for VE technique. This is in that hand span and all it is written, so please go through. So in unconscious obese apneic adults. See, this is not a unanticipated because if the patient is obese, obviously you're going to anticipate it. Okay, this is just a one more support in terms of evidence. So in unconscious obese apneic adults also, VE technique is far better than CE technique. What will CE is better or VE is better in pediatrics less than 2 years? Guess cheyach kada, simple ga. Konman CE, konman VE. So what do you say? CE is better or VE? So none of the technique is superior. You can use either CE technique or VE technique. Tidal volumes delivered both in both the study groups are same, and the peak airway pressures delivered are always less than whatever is there in pediatrics, leading to the less gastric insufflation. So in pediatrics less than 2 years, you can adapt any of the method which you are comfortable with. But if you are having small hands and facing difficulty, instead of CE, VE is always better than CE. This is just an idea where in case if you, and this is also one of the case of anticipated because the patient is edentulous patient. So in this what they have done is what we will do, the edentulous patients will have a sunken cheeks. So we'll try to pat the cheeks and have a better feel from the mask. That is what we usually do. But in this case what they have done is they have pulled the cheek. The cheek is pulled up with an index finger to complete the seal. So it is just an idea where in case you get to land up in ER with a difficult bag and mask, so you try to lift the cheek with your index finger to complete the seal. So what has happened here? In figure A, you can see the patient is having sunken cheeks. In B, you are holding the mask in classical CE technique where there is no EtCO2 tracing. EtCO2 is a marker of ventilation. So the patient is not getting ventilated. When the cheek is being lifted up, there is again EtCO2 tracing. So so if you are only sole rescuer, which technique are you going to use? What is this technique, by the way? I am ready to increase your postprandial sugars more high by giving chocolates to the one person who stands up and shouts, what is this technique? Should stand and I should listen. If nobody tells this, all the chocolates are mine. So 1, 2, 3, 4, 5. Thank God, my chocolates now. So this is the classical CE technique. What is this technique? The person has used thumb with thenar eminence and but the tip of the thumb is like this, not like this. VE ever chepparu? Who told VE? I'll appreciate them also because I think they are listening to my class nicely. They deserve a chocolate. So it is, I think something is coming from this side. Yeah, very good. It is called TE technique. So Dr. Ashok will please give a round of applause. Now, this is TE technique. And what is the other technique? Nice try actually. Claw hand technique and chapter. It's a nice try. Yeah, it is hook technique. Nick already of chopper touching kabatti. So this is called as hook technique. So when you are the sole rescuer, what are you going to, which method are you going to adopt? It is they observed this hook method is very much superior in getting the face mask sealed. So if you are the only rescuer, try to hold the mask in a claw hand or whatever the technique. This is called as a hook technique. So they have evaluated the newly proposed technique as hook technique, and when you are the only one. And one more point, doing the ventilation with hand is better or putting on ventilator is better? There is a common sense involved in this question. I feel all of us have a nice. So if you want to keep it on a ventilator, only your hand will be occupied. The other hand is free. You can involve the other hand in so many things. And this is an unanticipated emergency condition. So always you keep the patient on the ventilator and try to hold a mask. Okay? So coming to this positioning maneuvers. So what is the position that you follow while intubation? This is basic. People have to answer. What is the position? Sniffing, thank God somebody told. So it is a sniffing position. In sniffing position, what is going to happen? That is what even I have studied. Alignment of oropharyngeal laryngeal axis. But that is not the thing now. So in sniffing position, what is there? This is the primary curve. This is, what is it called? Pharyngeal-laryngeal curve. And this is called the secondary curve, that is laryngotracheal curve. In what shape it is? It is in the reverse S shape. Okay, so starting from here, this is the incisors where your eye will be there. And you want to see something near glottis. And what is this line? It is called as vestibule axis. That means vestibule, glottis, and a proximal part of subglottic area will be there. So this is your point of interest that you want to see from this incisors. So technically, if you want to see something in a hollow tube, you can see it directly from here till there. If it is bent at various levels, say for example, if it is bent like on the 90 degrees, like how it is bent here. So are you able to see something which is here? No. So what are you trying to do? You want to obliterate this space and make it in line of your sight. That is what we are going to do now. So if you can observe, see, this is your inflection point. What is inflection point? The point where your primary curvature and the secondary curvature meets. So this is your line of sight. This is the area below this line. See, on the inflection point, we have drawn a tangent to calculate the area. This is when the head is in neutral position. So what they have done by keeping the head lift, the area has come down because you are lifting the head. So you are trying to lift the head and try to decrease the area. And while extension, you are trying to get this line of sight closer, again to decrease the area. So in this sniffing position, you are doing both. So this is the place where you will get the least area so that you can see your glottis. So in sniffing position, what are we going to do? We are going to align what? We are going to align only pharyngeal laryngeal axis, not oral axis with the line of sight. So this thing is based on this. Now coming to the position maneuvers, as we have already discussed in sniffing position, what are you going to do? Lower cervical flexion and upper cervical extension. In chin lift, it is going to open your pharyngeal soft tissues. Why pharyngeal soft tissues are very important? Because like in obese people, the pharyngeal tissues are very lax. You want to maintain the longitudinal tension in the upper airways. So for that, jaw lift, head tilt, chin lift, these maneuvers are very important. Jaw thrust, head tilt and chin lift. So these all jaw thrust, it displaces the mandible, which will increase the retrolingual and retroparietal space. This is what we have already discussed. When you are keeping the sniffing position, we are aligning laryngopharyngeal axis and we are making sure that your this external auditory meatus and your sternal notch lie in the same line. Okay, this is chin lift, jaw thrust, this is reverse Trendelenburg. What is the advantage? The diaphragm is pulled down, it prevents the basic atelectasis and it delays the gastric emptying. And your pre-oxygenation also will be better if the head adapted is reverse Trendelenburg. Then the position of the primary airway manager. This is what we usually do. How are we going to intubate the case? Obviously, we are going to hold like this. So, is this the correct position? No. Because in difficult airway, what are we anticipating? We are anticipating the fatigue in your muscles. So, what is the best position? You should always try to. I think, am I clear? No? So, what you have to do is, you have to flex your elbow 15 to 30 degrees and your elbow should be in front of the body and you have to hold the mask like this with your legs slightly forward. Okay, you have to hold like this and the pressure, the forward pressure you have to apply is through this and you have to lean little back so that to maintain the center of axis there will be a centripetal acceleration developed in the body so that the pressure is distributed along the body. Like in CPR, you just transfer the chest compressions that from the pressure that is coming from the hip, right? So in the same way, you are using your body to generate force and counteract the fatigue in your muscles. All of you understood, right? I'm running short of time. So if anything, just let me know. This vortex approach is nothing but it is an approach to maintain your airway, how you have to go. From bag and mask, you have to, it primarily, the main motto is to avoid or to not to place the patient in cannot intubate, cannot oxygenate condition. So how we are following, we tend to forget. Even the most experienced person, he will fail to forget that I have to use burp or keep airway or suction. So that is why this vortex approach has been developed. So it is nothing but see, from the face mask. From the face mask, you can either go this way or this way depending upon the patient, either LMA or ET tube. If you are able to place it, the patient will go into the green zone. So our main motto is the patient should go to the green zone. If we are not able to do, the patient will also go to the green zone, that is inside this blue zone. This is cannot intubate, cannot oxygenate zone. Okay. So what you have to, in each 3 attempts, see 1, 2, 3. So in these 3 attempts, you are modifying your way of doing bag and mask, like using edge joints, see head manipulation, edge joints, size, suction, and muzzle down by giving paralysis. So this is you are doing this because you want to prevent it to fall in your central green zone. So now coming to the cannot intubate, cannot oxygenate. I think as the name suggests, I'll explain you the important things so that it will be useful as PGs. So now the policy we are discussing is based on ASA guidelines 2022 and DAS guidelines 2025. So when it has come to Plan A, the Plan A tells that attempt should be 3+1 senior clinician. Always use optimal technique using a video laryngoscope as a first line equipment and position. This all we have done it in the vortex approach only. But previously it used to be 3, now they made it 3+1. Why one is being added? Because they have added or emphasized more on video laryngoscope, where trauma is less likely to happen. That is why an extra attempt of one by senior clinician is being added. And deliver apneic oxygenation. This we have already discussed why. And confirm always success with a capnography. If you fail, always verbalize failed intubation and prepare phonak kit, not opening. Opening will come in plan B. So prepare phonak kit, always verbalize failed intubation. So now what we are going to discuss is one of my seniors' experience where he got a call for that the patient is desaturating. So he has done a normal laryngoscopy. He couldn't visualize anything, so he used a video laryngoscope and he visualized it and he started putting the tube from 8 and he came down to 3.5. He couldn't pass the tube and the tube size has come down to 3.5. So what was practically what he faced was the 3.5 tube will be very small, will be only this much. So it was ending in the oral cavity itself. So he didn't know what to do. So on the spot, what he has done was he has taken a 4-number tube and he has joined both of them. And then he ventilated the case. So now what he has done is immediately he shifted the case to the CT and he has seen what was happening in this, why he was not able to pass the tube. And then he in the CT he observed that there was a stenosis from C2 to T4 where he couldn't do anything. So since he is out of country, he just airlifted the case and he has shifted to higher center. And what they would have done? Any guesses? After knowing, I was very curious to know what has happened. How they would have maintained the oxygenation? Any inputs? Whoever tells, they really deserve chocolate from my bottom of my heart. Yeah, it is venous ECMO. Very nice. Again, GVP students are. Thank you so much for responding on time. You deserve it, and I am giving it. So they have done venous ECMO. They airlifted the case. So always have a backup plan to just manage the situation. Okay. I'm not telling you have to do like this. I'm just telling you the idea. That's all. Because it is not having any evidence. So coming to the plan B, again 3 attempts and always insert a second generation, either IGEL or Procel LMA. And if it is successful, please confirm the ventilation and pause for senior consultation. Even the senior consultant has arrived in the plan A itself. So he'll continue. So you put an LMA, you tell him like okay or like what should we go about it. So if you fail, you please verbalize failed SID ventilation and activate code blue if not ready, and still not able to intubate, proceed to plan C. So what is your plan C? Plan C is now optimizing your ventilation. How you will optimize? Optimize in all means. Position, relaxation, adjuvants, suction, oxygen, increasing the oxygen, apneic oxygenation. So in this plan C, you are increasing your nasal oxygenation, which was 15 liter per minute to 30 liter. You are doubling it, 30 liter per minute. And in HFNC, always remember the flow is high, but not oxygen. It is not the high oxygen concentration of oxygen. It is the high flow. Okay. So what you will do? Please employ your 2% technique with oropharyngeal airway and with full paralysis, and if stabilize and wake the patient with Sugamadex if the patient is stable hemodynamically, or verbalize CICO declared, cannot intubate, cannot oxygenate, and then proceed to plan B. And always remember the time from declaration to fauna until your access should always be less than 3 minutes. I think everybody knows what is the importance of 3 minutes. So, and then how do you prepare? You always extend the neck. If you are so well versed with the focus, use your ultrasound to identify the cricothyroid membrane and your scalpel number 10, chordate bougie and 6 mm ET tube. Why only 6 mm ET tube? I am going to tell you. So 1 minute, one video done. So how are you going to do it manually? There is something called as laryngeal handshake. Why it is called laryngeal handshake? You are using your hand to shake the larynx. So you are using your middle finger and thumb to locate your larynx and fix the larynx. You are moving it side by side. That means you are shaking it. And you are palpating with your index finger to see the depression. That is your cricothyroid. You have two prominences. The one is thyroid prominence and another one is cricoid prominence. So if you can palpate properly, you will get two prominences. Just in between, you will have this cricothyroid membrane. So you give a transverse incision and rotate the scalpel 90 degrees, insert a bougie, railroad it with 6 mm like a central line. Instead of guide wire, you are putting a bougie. Instead of your catheter, you are putting a TT tube. So what are the other alternatives? Tracheostomy. Why only cricothyrotomy was considered as superior than tracheostomy? Because it takes less time, less skill, no complications. So this is how we are going to do cricothyrotomy, and almost I'm done. Will this be played? అట్లీస్ట్ నిద్రపోయే వాళ్ళంతా ఇప్పుడు కళ్ళు తెరిచి ఈ సినిమాని ఒకసారి చూస్తే. And always remember 10 mm blade and 6 mm tube only for adults.
Before attempting a cricothyroidotomy, announce that this is a can't intubate, can't oxygenate situation and call for help. Continue attempts to oxygenate from above and ensure that the patient is paralyzed to exclude laryngospasm. Position the patient to extend their neck. Stand on the patient's left. Using your left hand, perform a laryngeal handshake to identify the larynx and place your index finger on the cricothyroid membrane. Stabilize the larynx using your left hand and stretch the skin taut between your fingers and thumb. Holding the scalpel in your right hand, make a transverse stab incision through the skin and cricothyroid membrane with the cutting edge of the blade facing towards you. You'll feel a pop as the scalpel enters the trachea. Keep the scalpel perpendicular to the skin and turn it through 90 degrees so the sharp edge points to the feet. Swap your hands so you are holding the scalpel with your left hand. Maintain gentle traction, pulling the scalpel towards you to maintain a triangular incision, but keep the scalpel handle upright at 90 degrees to the skin. Taking the bougie in your right hand so it is parallel to the floor and at right angles to the plane of the trachea, push the angled tip down the scalpel blade, keeping contact with the blade until the bougie is in the trachea. Rotate the bougie to align with the trachea and advance gently up to 10 to 15 centimeters. Remove the scalpel. Advance a size 6 tracheal tube into the trachea, continuously rotating the tube as you advance it. Try to avoid excessive advancement of the tube. Remove the bougie. Attach the circuit and give oxygen. Inflate the cuff. Confirm ventilation with capnography. Finally, recheck the depth of the tube and secure.
So after that, you should always have a debriefing session. A mandatory team to debrief within 48 hours and a psychological support and employee assistance program if needed, and always appreciate your colleagues. Please, if you are able to secure airway or manage it dynamically, always have a heart to appreciate your colleagues, to encourage each other. So, thank you so much for your patience.
Thank you, ma'am, for the effective and session. The session is open for any questions or discussion. I'd like to request Dr. Jayachandra sir, Associate Professor, to kindly come on the dais for the questions.
I thank all my PGs for coming long way and supporting me. Thank you so much. Please give a round of applause for them.
we'll move to the next seminar presentation by Dr. Ravi and Dr. Kishore, postgraduates from Government Medical College, Vizianagaram, under the guidance of Dr. Sheikh Halal Ma'am, Assistant Professor, on the topic anesthetic errors from drug swaps to equipment failures.
Good afternoon. My topic is anesthetic errors, mainly focusing on drug swaps and equipment failure. Myself, Dr. Raveen from GMC Vijayanagaram. I will be speaking mostly about drug swaps. So, every anesthetics carries risk, but many outcomes are preventable. Anesthetic errors account for approximately 11% of preoperative complications worldwide. Our goal should be safety culture, that is, improve patient safety, teamwork, and vigilance. So, three high-risk industries where error kills people are commercial passenger aviation. Example, we have heard about Air India crash recently. We will blame either the pilot or the machine. Like nuclear power, we will blame human errors. So anesthesia is also one of that. It is most complex and dangerous. According to stats, 270 times more likely to die under anesthesia than when flying on a commercial airplane. So what are anesthetic errors? They are unintended actions of omissions or commissions during anesthesia care that may lead to patient harm or adverse outcomes. So where the error can occur? Mostly it can occur in preoperative assessment, induction of anesthesia, maintenance phase, emergence and recovery, postoperative pain management. So what are the different types of errors? First one are medication related, airway and ventilation failure, equipment malfunction, PAC failure, human factors, and system level failures. So medication errors. Medication errors can be omission errors, wrong time errors, compliance errors, deteriorated drug errors, unauthorized drug errors, prescribing errors, monitoring errors, improper drug errors, wrong preparation errors, and wrong dose forms. So we will speak about few examples of medication errors in our practice. First are drug calculation errors. An anesthetist miscalculates the dosage of muscle relaxant, resulting in either insufficient paralysis or an overdose during surgery. Next will be look-alike, sound-alike drug confusion. We can intend to administer fentanyl, but accidentally mix up and administer sufentanil with their similar packaging and names. Incorrect labeling and packaging. Two vials with a different concentration of drugs, such as epinephrine, have similar packaging, leading to a wrong concentration being drawn and administered. Accidental drug swap. An anesthetist is used to having certain drugs always in specific drawers. In a rush, they accidentally swap the location of propofol and lidocaine, leading to a mix-up drug induction. Pump programming errors. They are incorrect programming of an infusion pump leads to delivery of an incorrect rate of a continuous medication, such as analgesic or sedative. Syringe swap. A mistakenly grabs a syringe that looks similar but contains a different medication, resulting in inadvertent administration of wrong drug. Then drug-drug interactions. Administer a drug without considering its potential interactions with other medications the patient is already taking, leading to adverse effects. Intravenous administration errors. Administering a drug meant for epidural or intrathecal used intravenously, resulting in systemic effects instead of local actions. Failure to recheck patient identification. An anesthesia provider fails to double-check patient's identity before drug administration, leading to drug intent for one patient being given to another. Lack of dilutional awareness. And administering a concentrated drug without proper dilution, leading to an unintended rapid onset of action and potential toxicity. Drug allergy mismanagement. Failure to review a patient's allergy history result in administration of a medication to which patient has a non-allergy causing an allergic reaction. Equipment malfunction. A malfunction in the infusion pump fails to deliver the intended dose of a drug, leading to inadequate pain control or anesthesia depth. Then syringe color coding. We can swap the syringe. A red syringe, assuming it contains an analgesic, but inadvertently administer a neuromuscular blockade agent, as the drug was recently changed, but not the syringe color. Unintended dose increase. Anesthetist is accustomed to a specific concentration of drug. However, a new batch with a higher concentration is introduced. He administers the usual volume, unknowingly delivering a higher dose than intended. Label misinterpretation. Misinterpreting the label on a syringe or medication vial due to poor lighting or illegible handwriting resulting in wrong drug being administered. Inadequate communication. A breakdown in communication between team members resulting in wrong drug being administered during a handover between shifts. Routine flipping of syringe label. During a procedure, an anesthetist routinely flips syringe labels to make them more visible. In doing so, they mistakenly mislabel a syringe, resulting in administration of wrong medication. Unnoticed empty drug vial. A technician can routinely restock medication tray. Due to hectic schedule, they overlook checking for empty vials, resulting in providers attempt to administer medication vials with insufficient quantities. Prescription abbreviation misinterpretation. Anesthetician accustomed to seeing PCA, patient controlled analgesia, misinterpret it as PCEA, leading to an unintended use of an epidural infusion in a patient expecting PCA for postoperative pain management. Infusion pump programming errors. Incorrect programming of an infusion pump result in delivery of an unintended air weight or volume of drug during continuous infusion. Cross-contamination during drug preparation. An anesthetic drug inadvertently becomes contaminated with another substance during preparation, leading to unintended side effects or interactions. Automatic drug selection on pump. An anesthesiologist routinely uses the automatic drug selection feature on an infusion pump. One day, a drug with a similar name appears in the list and the nurse unknowingly selects it, leading to an unintended dose. Then expired medication use. An expired drug is inadvertently used during anesthesia, potentially compromise its effectiveness and safety. Inadequate documentation. Failure to document drug administration details accurately, including drug name, dose, and time, may lead to confusion or delayed recognition of errors. So, for us, we should always be vigilant and avoid any negligence. Some other case examples which are routinely in our practice are giving succinylcholine or atracurium given before induction agent due to non-labeling. In post-operative period, propofol given instead of antibiotic because of bipower antibiotics. Neostigmine and tranexamic acid mistakenly given intrathecally due to communication gap. Precipitated drug combination given IV due to negligence. Expired bulb of succinylcholine used unknowingly and the effect was not seen. Low dose of propofol given due to fear of complications. Half-hearted knowledge is also a crime. 2 mg butram given instead of 1 mg because of very small writings on butram ampules. Diclofenac sodium IM given in high doses instead of lignocaine because of same color bulbs, leucare color bulbs. Sevoflurane filled in isoflurane vaporizers and started in hurry of induction. Anesthesia given in COPD patient without taking proper pre-anesthetic history and lapse with post-op pneumothorax. In hurry without taking proper pre-anesthetic history and monotonous routine. So incidents of errors are mainly, most errors are caused in area of muscle relaxation. It's about 23%. It can cause substitution, repetition or insertion or omission errors of muscle relaxation. Then the rest is opioid antibiotic inhalation agents as follows. Anticoagulants, sympathomimetic will be the least in errors according to stats. So how to prevent the drug errors? We have to first check we are giving the drug to right patient, right time, right route, right documentation, right dose, and right drug. So 6 R's should be maintained to reduce medication errors. Another error reduction technique is do not store concentrated solution of hazardous drugs in OT, distinctive drug labels, standardized syringe size, standardization layout of drugs workspace, barcode on drug labels with audible reader, double check ampules before labeling syringes and always label syringe before administration. Color drug labels, standardization drug preparation procedures, and check label with second observer, and pre-filled syringes are no techniques. There is a standard, some label color codings are there, like benzodiazepines can be color coded as orange, opioids blue, local anesthetics as gray, induction agents yellow, neuromuscular blockers red, vasopressors purple, potent vasopressors like epinephrine purple and black, potent vasodilators in lavender and white stripes, reversal agents in red and white stripes, anticholinergics green. And we can also use color-coded syringe trays if it is available to avoid mismatch or drug swaps and minimizing the errors in anesthesia fraction. So remaining types of errors, my colleague Dr. Kishore will continue.
Colleague has discussed about medication related errors. I'm going to discuss about different types of other errors like airway and ventilation. It is mainly because of mismanaged different airway and failed intubation recognition, hyperventilation or aspiration, or accidental extubation. So equipment errors. Equipment errors can be because of machine malfunction or lack of checks. This can be prevented by doing thorough machine checklist and oxygen supply failure, monitor disconnections and alarm fatigue. So anesthesia machine failures. So gas supply issues like empty cylinders or pipeline crossovers. These are very rarely happening because of the disc and pin system, but maybe happen. It may cause fatal usually fatal. Flow meter malfunctions, vaporizer leaks or incorrect agent fillings. Though we have the color coding for vaporizers, sometimes it will be incorrectly filled and ventilator failures. Breathing circuit errors. Disconnection leading to hyperventilation, kinking or obstruction of the tubings, damaged reservoir bags, or incorrect assembly. Example, reverse components. Equipment, airway equipment errors. Endotracheal tube cuff leaks, faulty diagnostic blades or batteries, incorrect sizing of airway devices, supraglottic device malfunction. Malfunction. False SpO2 readings due to poor perfusion or sensor failure, EPSO2 trace dropout from loose sampling line, inaccurate NABP readings, and calibration errors. Infusion pump issues, incorrect programming leading to overdose or underdose, occlusion and unnoticed alarms, battery failure during transport, tubing disconnections. So consequences of equipment errors: hypoxia or hypercarbia, hemodynamic instability, awareness under anesthesia, and potential morbidity or mortality. The prevention strategies. So routine maintenance and calibration of the equipment, daily machine and circuit checks, standardized protocols and checklist, team training and simulation. So checklist essentials are verify gas supply and pressure, check breathing circuit integrity, confirm vaporizer settings, test ventilator function, ensure monitors and alarms are operational. So another type of error is pre-anesthetic checkup errors. It is because of incomplete preoperative assessment. So lack of comprehensive preoperative assessment results in incomplete information about the patient's medical history, allergies, or current medications, increasing the risk of medical errors. Human factors. So the errors might be happening because of fatigue and long shifts. So working for more than 30 consecutive hours and working for more than 40 hours per week can lead to human fatigue, and which can lead to cognitive overload and distraction and multitasking. Inadequate training or supervision, system level failures, inconsistent safety protocols, poor operating and communication culture, staffing shortages, and inadequate reporting mechanisms. Medical legal consideration. So it is a duty of every anesthetist to take care and accountable for the medication error or anesthetic errors. It is important to document, and there should be transparent communication with the patients, and they should be encouraging the incident reporting. Preventive strategies. There should be standardized drug labeling, WHO surgical safety checklist, pre-anesthesia machine checks, and improved handover and communication. Role of technology. There are Newly advanced smart infusion pumps, barcode medication scanning, electronic anesthesia records, and AI-based monitoring methods to prevent the anesthetic errors. So building a safety culture, there should be non-punitive reporting structures. They shouldn't blame any person who is undergoing the anesthetic error. The teamwork and close loop communication should be happening. Regular simulation training should be happening, and continuous quality improvement should be done. So future directions are global standardized safety indicators, universal drug labeling, advances in wearable monitoring, and AI and predictive analytics can help in preventing the drug errors. So conclusion, most anesthetic errors are preventable. They require system level and behavioral changes. To have to promote a vigilance, teamwork, and reporting of any anesthetic error. The goal is to maintain the zero preventable perioperative and post-operative harm to the patient. Thank you.
Thank you, sir, for the presentation. Now I invite Dr. Sahiti Ma'am, Assistant Professor, to guide the comment to the illustrate the possibilities.
I request all of you now to please participate. Thank you, sir. Now moving on to the last seminar presentation by Dr. Manmohan, postgraduate GEMS, on the topic perioperative myocardial infarction under the guidance of Dr. Pradeep Kumar Das. Dr. Pradeep Kumar Das, currently working as a professor in GEMS Srikakulam, completed his UG from Nagaraya Medical College, Kakinada, and PG from Andhra Medical College, Visakhapatnam. He has a teaching experience of more than 9 years. He has publications of 6 international and 4 national journals, and some areas of interest are academics and regional anesthesia.
Good afternoon, everyone. Myself, Dr. Manmohan, first year postgraduate, Department of Anesthesia, GEMS. Today I am here to present a case presentation on topic intraoperative MI, and my moderator is Dr. Pradeep Kumar Das, Professor, Department of Anesthesia, GEMS. So, I'm going to present. My case is a 52-year-old male by name Shivakumar, resident of Srikakulam, brought to GEMS casualty with history of RTA, bike versus car at Srikakulam, with complaints of pain and deformity to right thigh and inability to walk. Patient was posted for emergency surgery for open reduction and internal fixation under regional anesthesia. History of present illness. The patient presented with a history of RTA near Srikakulam on 3rd 2025, brought to GEMS casualty with complaints of pain and deformity to right thigh. Inability to bear weight and swelling of the right thigh. Multiple abrasions and lacerations over right forearm. No history of head trauma, no history of LOC, vomiting, seizures, and ENTP. No history of chest pain, dyspnea, palpitation, or admission. So the past history and surgical history, there is a history of hypertension since 7 years, which is controlled on medications, tablet telmisartan, and type 2 diabetes since 6 years, and is controlled under medication metformin. There is no prior CAD or cardiac history. There is no CKD, COPD, or seizure or thyroid history. There is no previous surgical history for the patient. So the personal and family history include both appetite is normal, mixed diet, normal sleep, bowel and bladder. And he has a history of chronic smoking history, 10 cigarettes per day for the past 10 years. and history of alcohol intake, occasional drinker, and there's no family history of any congenital cardiac disorder. So general examinations of the patient include patient is conscious, oriented and cooperative, moderate in written narrates, height is 174, weight 66, no pallor, icterus, cyanosis, clubbing, edema or lymphadenopathy. Spine is normal and there is no deformity further. And the vitals include pulse rate, preoperatively 88 beats per minute, regular normal volume and normal in character. There is no radio-rated delay or any vessel thickness. BP includes 130 by 80 mmHg taken in sitting position. Respiratory rate is 80 cycles per minute. Saturation is stable, 99% of room. So the airway examination, mouth opening is 3 fingers spread. Dentition is no loose teeth, no dentures. Malapathy grade 2. Thyrometer distance 7 centimeters. Sternometer distance 13 centimeters. Adequate neck movements and there is no restrictions on the neck movements. Systemic examination, cardiovascular examination, sounds S1, S2 heard, no murmurs, and respiratory system bilateral air entry present, no added sound. Abdomen soft vowel sound present. CNS no focal difference. So coming to the provisional diagnosis, a 52-year-old male, ASA class 2, diagnosed with traumatic mid-shaft femur fracture of right side, posted for emergency open reduction and internal fixation under regional anesthesia. So the investigations prior to the surgery, blood HP is 11.2, total count 12,350, platelets is 1.34 lakhs. Other RFT, LFT, electrolytes are within normal limits. Chest X-ray is normal. ECG is sinus tachy, normal rhythm. There is no STT changes seen. The 2-day echo shows left ventricular ejection factor of 55%. There is no regional wall myocardial defects. Blood group is O positive, viral markers non-reactive, X-ray, right femur, APL lateral turn. Surgical plan, there is emergency open reduction and internal fixation. Anesthesia plan is subarachnoid block plus combined with epidural anesthesia. Preoperative preparations includes informed written consent taken, 2 wide bore IV cannula secured, blood products arranged and cross matched, antibiotic and aspiration prophylaxis given preoperatively, including injection ondansetron 4 mg IV, injection pantoprazole 40 mg IV. Antibiotic prophylaxis given, injection ceftriaxone 1 gram IV, 30 minutes prior to the incision. Patient kept fasting for 6 hours. Anesthetic management and induction. After shifting to the OT, all ASC standard monitors applied, including ECG, non-invasive BP, SpO2, ETC2, and capnographin as a cannula. Subarachnoid block performed in sitting position at L3, L4 interfaces. Midline approach. Drug use is 0.5% heavy bupivacaine, 2.8 ml plus fentanyl 25 ml. Epidural catheter placed at the level of L1 and L2 level. Sensitivity level achieved up to the level of P8. Vitals are stable and surgery stable. Intraoperative events on the beginning of the surgery. During the first 10 to 60 minutes, surgery is ongoing. Blood loss is approximately 350 ml. Patient stable with stable heart rate and BP. The maximum allowed blood loss calculated 650. At around 60 to 75 minutes, mild rise in heart rate, 90 to 100 beats per minute, noted but patient asymptomatic. During active reduction, suddenly excessive loss of blood noted, approximately more than 1.5 liter blood loss noted. At 75 to 90 minutes of surgery, patient complaints of chest discomfort and excessive sweating, developed severe tachycardia, heart rate increased from 90 to 166 per minute, hypotension developed, BP fall from 120 by 80 to 90 by 50 mmHg, saturation dropped to 93, patient became restless, dyspnea and became anxious. At 90 to 95 minutes during the surgery, during muscle closure, ECG on monitor start showing ST elevation release V2 to V4. We are suspecting intraoperative MS. Intraoperative management, what we have done is timeline from 75-90 where the patient become unstable and restless. Oxygen support is given with 100% FiO2. Saturation improved to 100%. Patient initially managed bolus intravenous fluid 250 ml ventilation given. Blood pressure not improved with the fluid bolus. Still remain at 80 by 60. Injection phenylephrine 100 mics given to improve the BP initially. We started following the IV fluid infusion. Blood is arranged immediately and one type of PRPC transfusion started. Blood pressure improved slightly, but patients still have persistent tachy. Vasopressor support started along with the blood transfusion. Injection or adrenaline infusion started to improve the map above 65. Patient became restless and irritable. Injection fentanyl 1 by 1 mics per kg by dose given to combination. Timer after 90 minutes. ECG changes of ST elevation leads chest leads V2, V4 are seen. Surgeon informed and surgery expected. Immediate investigation advice includes ABG, top and serum electrolytes. ABG, mild acidosis and electrolytes remain normal. Immediate ECG taken and showed is changes of hemoglobin MI. On auscultation, chest shows bilateral crepitations. Cardiology opinion taken need for anticoagulation therapy discussed. Tab aspirin 150 mg given per orally. Injection heparin was withheld as there was still active risk of bleeding present. Surgical procedure completed and wound stitching done immediately. Limb stabilizer and dressing done. Patient shifted to ICU for further monitoring and management. Cardiac enzymes were sent and again a 12-lead ECG was done. Proper was 3200 above the normal level. CKMB is also done 8.94 nanogram per milliliter. ECG ST elevation V2 4 leads persistently. ICU management includes shifting to ICU and continuous monitoring done. Series of ECG taken which shows gradual progressive ST elevation. Repeat profile was advised and continuous monitoring done. Echo done shows newly developed RWMS and ejection fraction reduced to 40 to 45%. ABG shows metabolic acidosis corrected with fluids and oxygen. Cardiology reference done. Treatment started. Loading double antiplatelet therapy given. Tab aspirin 300 mg plus tab ticagrelor 180 mg given as a stat dose. High dose statin is given. Stab at dorostatin 18 mg. Injection heparin infusion started. Injection NTG was started to reduce the symptoms and increase the coronary perfusion once the map improved by the vasopressors. Immediate angiography was done after 6 hours of shifting to showed 80 to 90% occlusion of LAD and patient was taken for primary PCI and drug. Loading stent procedure was done. Addition ICU management. O2 supplementation for improving saturations. Noradine tapered over 12 hours. Analgesia, paracetamol, epidural infusions given. Insulin infusion for glycemic control done. Fluid monitoring. Beta blocker restored after stabilization. Atorvastatin 40 mg continued. DVT prophylaxis given. Post PCI event, patient hemodynamic is stable, stabilized by 48 hours. No arrhythmia seen after procedure. Patient mobilized by day 5. Patient discharged on day 7. Dual antiplatelet therapy started after day 7. Metoprolol and ARBs along with hydrostatin. Patient shifted to orthopedic for fracture rehabilitation. So today, today we have discussed this topic under the following headings, including acute coronary syndrome, which includes STEMI and unstable angina as a broad terms, and the main topic perioperative MI and intraoperative management post-op periods. Other causes for ECG changes in intraoperative procedures. So, what is an acute coronary syndrome? The term acute coronary syndrome refers to any group of clinical symptoms compatible with acute myocardial ischemia and include unstable angina, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. So, we discussed the acute coronary syndrome in normal hospital management. Most commonly, the patient comes with complaints of chest pain. So, provisionally, we diagnose with the acute coronary syndrome. So we have to keep in mind that it can either be due to incomplete occlusion or complete occlusion of the vessels to the cardiac muscles. So firstly, we will take an ECG to confirm our provisional diagnosis. So it can be non-ST segment elevation or ST segment elevation. So in non-ST segment elevations, it can be there can be elevations or there can be no changes in the ECG, and there is a confirmed ST elevation can be seen. So the next test we prefer to perform is the myocardial injury markers, which due to the necrotic changes in the tissues. So there are two outcomes will be there. Either it will be not elevated or elevated. So depending on not elevated with the ST segment depressions or either not changes in the ECG, it can be an unstable angina. So when there is a confirmed ST segment elevation with elevated myocardial injury markers, it can be confirmed ST segment elevation myocardial infarction. Then the other one is ST depression followed by elevated myocardial injury markers, that is NSTEMI, which will come on ST segment elevation myocardial infarction. So we'll discuss the risk factors for it. The common risk factors for commonly we have seen is elderly, cigarette smoking, hypertension, obesity, sedentary lifestyle, high cholesterol, diabetes mellitus, family history of premature coronary artery disease, chronic kidney disease, peripheral arterial disease. So coming to the predisposing factors for MI during an anesthesia and surgery. So which during what are the risk factors which causes an intraoperative MI? That is main causes hypoxia, hypotension or hypertension, hypothermia, pain, blood loss causing anemia, arrhythmogenic electronic disturbances, inflammation, blood sugar instability, diabetes, acute stress response, avoidance of anticoagulation. So perioperative MI can be broadly classified into non-ischemic and ischemic. Non-ischemic is mostly caused by non-cardiac causes like the sepsis, pulmonary embolism, or acute stroke. The ischemic, which is direct injury to the myocardium due to the disruption of the blood supply, which is further divided into perioperative myocardial infarction or myocardial injury without infarction. So perioperative myocardial infarction is further divided into type 1 and type 2. So the main problem which we face during the surgery is the imbalance between the oxygen delivery and the oxygen requirements of the clinic, or demand and supply irregularities. So what are the causes for decreased oxygen delivery? So decreased coronary blood flow, tachycardia, diastolic hypotension, hypocapnia, which decreases the oxygen delivery. Then there is a reduced oxygen content in the blood, which is anemia, arterial hypoxemia, shift of oxyhemoglobin dissociation curve to the left. Increased oxygen requirements are conditioned by increased preload, sympathetic nervous system stimulation, tachycardia, systemic hypertension, increased myocardial contractility. So when we come to the pathophysiology, during a surgery, it's a state of immense changes happening in the body. So the main 4 stages during an surgery is inflammatory. So the body becomes an inflammatory state, hyperparalytic state, stress state, and hypoxic state. So various markers have been released during the period and stress, and which all causes the perioperative MI during the period. And it is further classified mainly into five types. So type 1, which is MI secondary to spontaneous disruption of or rupture of a vulnerable coronary plaque bleeding. Type 2 is MI secondary to process that result in sustained imbalance within the myocardial oxygen supply and demand. Type 3 is a sudden cardiac death which occurs before blood samples are obtained or result is accompanied by presumably no ST segment elevation. Type 4 is a PCA related MI. Type 4B is MI due to stent thrombosis anytime after the PCA. Type 4C is MI due to instant stenosis. Type 5 is CVG related MI. So coming to our main topics like coronary syndrome type 1 occurs when an unstable or vulnerable plaque undergoes spontaneous rupture, fissures or erosion leading to acute coronary thrombosis, ischemia and infarction. So during the surgery, there is a sympathetic surge which causes tachycardia, hypertension, which results in the plaque ruptures and causing the occlusion of the coronary vessels. And there is a increased perioperative procoagulation, which make it an hypercoagulable state, leading to the thrombus formation and occlusion of the vessels. So the second type, which is the most common type we see in the intraoperative, is type 2. The oxygen demand is increased perioperatively due to the increased heart rate, heart valve tension, preload, afterload, and myocardial contractility. So there is a disruption in the supply due to decreased coronary blood flow, tachycardia, hypotension, hypocapnia, hypoxemia, anemia, etc. can be seen. Tachycardia is the most common cause of perioperative oxygen supply demand imbalance. Heart rate above 80 in patients with significant CAD can lead to prolonged ischemia and perioperative MI. Postoperative hypotension, hypovolemia, bleeding, or systemic vasodilation, or hypertension, elevated stress hormones, vasoconstriction, anemia, hypoxemia, and hypercapnia aggravate ischemia. Preoperative evaluation for any patients before a non-cardiac surgery, we have to anticipate ACCA guidelines on cardiovascular evaluation for non-cardiac surgery. Conclude that 3 elements must be assessed to determine the risk of cardiac death: patient-specific clinical variables, exercise capacity, surgery-specific risk. So patient-specific, there are major, intermediate, and minor. Major includes already present coronary syndromes or any decompensated heart failure or significant arrhythmias or any valvular disease. The intermediate includes mild angioedema, compensated heart failure, diabetes mellitus, or renal insufficiency. Minor, advanced age, abnormal ECG, rhythm changes, or history of strong uncontrolled systemic hypertension. In exercise capacity, we usually take metabolic equivalency where the patient is good functional status having a low risk of complications. Surgery specific risks include the high risk procedures, which include the rate of cardiac death or non-fatal MI is more than 5, major surgeries to the vessel walls or aorta or thoracic surgery. Intermediate risk procedure, low risk procedure. So depending on this risk risk and anticipation risk indices have been developed. So the most common used one Goldman index, which includes 9 factors, which we broadly divided into classes like history, which includes the MI within 6 months, 8 more than 7 years. Physical examination where there is jugular vein depression, significant aortic stenosis. Then ECG changes includes premature ventricular complexes or rhythm changes or other poor medical status, intraperitoneal or intrathoracic aortic operation and emergency procedure. So each carries different points, and depending on the points, we calculate the risk of either surgery. Then the revised cardiac risk index. So it includes 6 points, which each carry separate points, and depending on the points, we predict the risk factors. So this includes high risk type of surgery, ischemic heart diseases, or any congestive heart failure, history of cerebrovascular diseases, preoperative treatment with insulin, preoperative cerebral. Diagnosis of perioperative MI. Diagnosis is complicated by lack of symptomatic presentation in about half of the patients with perioperative MI. Develop propose the following diagnostic criteria: rising troponin plus 1 or more following, ischemic signs or symptoms, new pathology, QRS on ECG, new wall motion abnormality, or fixed defect on ECG. So according to ACC, 2 criteria must match for the diagnosis: increase or decrease in cardiac enzyme in combination with at least one of the following. Typical ischemic symptoms: development of pathological QRS in the ECG, ECG changes indicative of myocardial ischemia, ST segment elevation or depression, coronary artery intervention, pathological findings of acute myocardial infarction. Clinical presentation, which when we take into GA procedures, will not accompany any symptoms by the patient itself. So we have to depend on the hypotension, arrhythmia, signs of congestive cardiac failure to come to the conclusions of any perioperative MI. ECG findings of perioperative MI, ST elevation, no ST elevation at the junction of 2 continuous leads with cutoff of more than 0.2 millivolt in men and or more than 0.15 millivolt in women. ST depression and TVL changes. No horizontal and down sloping ST depression, more than 0.05 millivolt in 2 continuous leads, and a TVL depression more than 0.1 millivolt in 2 continuous leads. Gives a diagnosis. Then we can detect the different, depending on the ECG, ST elevation changes, and other we can depend the wall which is affected and the artery which is blocked due to the reduction in the supply. So anterior wall, mostly we can see the ST elevation V1, V6, septal V1 to V4, lateral wall 1 area V5, V6, inferior 1, 3 area, posterior MI V7, V8, V9, right ventricular MI V1, V4, V4 R. Then the next criteria for diagnosis is cardiac markers. It includes myoglobin, CPK, LDH, AST, TROP-I, and TROP-T. Where TROP-I and TROP-T is mostly elevated in the first 4 to 8 hours, which we consider as the immediate test for the diagnosis. Then transesophageal echo, the development of new regional motion abnormalities is considered to the first detectable change in the left ventricular. Either we can do transesophageal echo or transthoracic echo, depending on the condition of the patient. The management of pain is different as thrombolytic cannot be given and anticoagulant use is within caution. So as soon as the PMI is diagnosed, the MONA therapy should be initiated. M for where the MONA is a mnemonic for M for morphine, where 2 to 4 mg IV every 5 to 50 minutes. O for oxygen support. N for nitroglycerin. If SB systolic blood pressure more than 100, we can start the NDV to improve the perfusion. A for aspirin, 160 to 325 mg is administered orally or through right. Management protocol, immediately in an ICU management, we have to start oxygen, morphine, aspirin, 325, nitric, beta blockers, heparin, any other anticoagulant. So, clopidogrel 300 to 600 mg once, or ticagrelor 180 mg PO once. This is the immediate therapy to start in the ICU after shift to the patient. Then when we have to consider the revascularization, whether it depends on whether it is NSTEMI or STEMI. So NSTEMI, whether it is uncomplicated, we can have time period of 20 to 48 hours to perform angiography, and depending on the wall anatomy, we can consider for PCI or CABG. For STEMI, it depends on PCI available within 90 minutes the window period. So if it's available, we can go for angiography, and depending on the wall status, we can go for PCI or emergency CABG. If it is not available, we have to go for thrombolytic therapy, persistent ischemia. Then we have to go for angiography and PCI procedure. Post-ACL therapy manage reversible risk factors, ACI or ARB for pressure hypertension control, clopidogrel at least for 1 month for bare metal stent, or at least 9 to 12 months for drug eluting stent. GP 2B3 inhibitor for at least 80 to 24 hours. Statins. Thank you.
Good evening. So we took the case regional anesthesia, then GA. Today case report, because we have conception that mostly MI will occur only in GA while we give the atropine or glycopyrrolate or during the induction or by intubation, that arrhythmias can cause the MI. But in regional anesthesia also, even we block the sympathetic system, MI may occur due to hypotension or severe blood loss accidentally. Patient was awake, he was very panicked when ongoing blood loss was more. So MI can occur even in regional anesthesia. That is the theme of the case report today. So we miss one investigation routinely lipid profile. So we won't ask lipid profile routinely. So better you have vessel thickness in preoperative assessment while you assessing the radial artery or brachial artery. You go for lipid profile or any family history prior to the patient. Any familial history of cardiac disease, you ask for lipid profile initially. So don't always be panic that patient telling that I have chest pain intraoperatively, that is surely MI, because during traction of the peritoneum like organs like appendix, uterus, that may mimic MI, but it's not true MI. Always compare pre-op ECG or PSC ECG to the intra-op ECG to confirm maybe it is MI. Okay, don't get panic. And there are two types of MI, ST elevation or ST depression. And ST depression, horizontal or downsloping MI is very significant than the upsloping. No need to worry in ST upsloping MI. Okay, so always keep monitoring ST analysis for all patients, even regional or general anesthesia, to detect 2 mm height of the ST elevation can cause or mimic maybe MI. Okay, so there are two wonderful drugs, esmolol and nitroglycerin. You can start initially if patient has tachycardia. So give esmolol. It won't cause severe hypotension, but it will reduce the heart rate so that oxygen supply demand will be minimized. So what esmolol is a wonderful drug. So another drug was nitroglycerin. So which is routinely available in all operation theaters, which is a coronary vasodilator. So if blood pressure was stable, so use low dose of nitroglycerin if you suspect ST elevation, that will not harm the patient. Instead of it will be definitely useful. Another thing was patient complaining of chest pain. You have to reduce the panic, anxiety, and pain first. So you can give the morphine or fentanyl. So morphine definitely very obviously good drug. It will reduce preload also, cardioprotective. If your morphine is not available, you can use the fentanyl safely. Okay, recently I have femur fracture. My second year postgraduate noticed that heart rate was 160 while reducing the femur. Gross ST elevations were there. So surgery was in nearly about 2 to 3 hours about to complete. So we converted spinal anesthesia to general anesthesia to increase the oxygen supply demand with esmolol. While intubating, we reduced the heart rate to near normal, and we started the noradrenaline to increase the blood pressure, and we converted into GA. After 1 day, we evaluated whether it is a true MI or like that. We confirmed with drop eye, and it is global hypokinesia was also there. But after 2 days, patient was luckily extubated. So never negotiate to keep the patient in only spinal anesthesia. Even patient heart rate was 160, 170, while blood loss was 1.5 liters. Patient getting anxious, surgery was went up to 4 to 5 hours. Don't delay the conversion to spinal anesthesia to GA. Okay, so many cases I have done, like people's disease, peritonitis, sepsis will indirectly cause MI. So sepsis is one of the factor which will cause post-operative MI and global hypokinesia. So be careful about that. Okay, thank you. So in regional anesthesia, aspirin you can do low dose while you have 25 gauge or 23 gauge needle puncture, but it should be low dose aspirin only. But if you have 6 hours time, you can give the loading dose 300 mg and clopidogrel also, statin also can give. But in general anesthesia, it is very easy to give treatment because if coagulopathy was not there, surgeon was allowed heparin, you can start heparin, aspirin and clopidogrel. But in regional anesthesia, it is difficult to start the heparin. Heparin you can start definitely, clopidogrel you can't start. So give only 75 mg aspirin and you can give 5000 units of heparin also after the 2 hours of the spinal puncture. Thank you.
Thank you, sir, for your valuable information, and thank you, madam, for your elaborative presentation. I'd like to request Pradeep sir to say a moment for our felicitations ceremony. I'd like to request Dr. Jayachandra sir, Dr. Srija ma'am, Dr. Shavanti ma'am, and Saiti ma'am to come on the dais for felicitation of beloved Pradeep sir.
We request all our beloved seniors to come onto the stage and join the felicitation ceremony.
I'd like to request Dr. Jayachandra sir to please stay back on the stage. I'd like to request Pradeep sir and other faculties to kindly participate in. I'd like to request my seniors to please give a gift to co-president Manmohan. My senior PGs.
Thank you, sir. JIMS Srikakulam for patiently waiting till this hour. And your most awaited quiz session is going to begin now. I request Dr. Jayachandra sir to take over the quiz session.
So the next event and the final event of the day, that is a quiz for postgraduates. Whomever are there? Naveen Kumar, Lavanya, Lalita, Amla, Deeramadi. ये मात्र मिस है ये मध्य क्लास हाँ अमला ये मध्य क्लास अमला नेक्स्ट गायत्री महेश सतीश Irfan. Instead of Mahesh and Satish, any other PT are there? Who want to participate? Hey Harika? Anusha. These two will participate.
Smith, check your pockets for the micra. But the option to my chair. Smith, you search for another mic. Did someone put in bag? Did someone put in bag? ఎవరైనా బ్యాగ్ లో వేసుకున్నారా ఏంటి చూడు. Smith, see on that dais that what? దాని మీద చూడు ఒకసారి. అప్ అప్.
Okay, quiz round. Total 2 rounds are there. First round is ఇది ఈ రౌండ్ లో ఏ గ్రూప్ కి అవకాశం ఉంటుంది. సో మీకు కరెక్ట్ చెప్తే 10 మార్క్స్, రాంగ్ చెప్పినా నెగిటివ్ మార్క్ ఉండదు. ఓకేనా? సో ఈ క్వశ్చన్ ఈ గ్రూప్ మాత్రం పాస్ అయి ఉండదు. ఓకే, మీరు క్వశ్చన్ కరెక్ట్ చెప్తే ఓకే, రాంగ్ చెప్పకపోతే నెక్స్ట్ క్వశ్చన్ వాళ్ళకి నెక్స్ట్ బ్యాచ్ నెక్స్ట్ క్వశ్చన్ న్యూ క్వశ్చన్ యాడ్ అవుతుంది. ఓకేనా? సో సెకండ్ రౌండ్ బజార్ రౌండ్ ఉంటుంది. సో ఆ రౌండ్లో మాత్రం ఎవరు ఫస్ట్ చేయొస్తే వాళ్ళకి ఆన్సర్ చెప్పే అవకాశం వస్తుంది. బట్ వాళ్ళు కరెక్ట్ చెప్తే ఓకే, రాంగ్ చెప్తే -5 మార్క్స్ వస్తుంది. ఓకేనా? సో ఇబ్బంది అవుతుంది. అప్లై చేద్దామా? అదే ఇది ఆన్ అవ్వట్లేదు. ఆన్ అయితే ప్రాబ్లం ఉండదు. గ్రూప్ ఏ, ఇది గ్రూప్ ఏ. ఏంటిది? ఎన్ఎఫ్ఆర్ యాక్సెస్. ఏ ఫర్ ఎన్ఎఫ్ఆర్ యాక్సెస్, యాస్పిరేషన్ గ్రూప్. B bronchospasm group. Even C cardiac arrest group. D delirium group. Delirium group. Actually, మనకి వీళ్ళకి ఎక్స్ట్రా వేసాం అంటే వెయిట్ చేసాను ఒక మెంబర్ ఎక్స్ట్రా ఇచ్చాం పర్లేదు తను చేయొచ్చు భయ అన్నారు భయ అవ్వట్లేదా అటేసా తన టేబుల్ అయితే ఆ మోటార్ కాదు కొంచెం టేబుల్ అటేసి మీకు అనిపిస్తుందా ఓకే బాబు అవసరం లేదు కొంచెం జరుపుకోండి ఫస్ట్ ఏ గ్రూప్ అడిగా మార్క్స్ వేస్తున్నారు ఓకే ద హైయెస్ట్ కంటెంట్ ఆఫ్ సోడాలైమిడ్ ఈజ్ మా 2 minutes maximum sodium hydroxide, potassium hydroxide, calcium hydroxide, silica. A is wrong. C. Okay, calcium hydroxide equal 0 marks. Next, B group, bronchospasm group. Which of the following is not associated with oxytocin administration? Myocardial ischemia, respiratory depression, hypotension, tachycardia. Very good, correct. So bronchospasm group 10 marks. Okay, C group cardiac arrest. Capacity of oxygen E cylinder is approximately 500 liters, 550 liters, 650 liters, 750 liters. Around 650, it will be around 625 to 700 liters. Okay, so C 0. Next, group D. The storage time for packed red cells at the temperature of 1 to 6 degrees centigrade is option B 21 to 35. Correct answer. Okay, again group A. Detrimental effects of hypothermia include all of the following except A. Increasing cerebral oxygen consumption, B. Increasing surgical site infection, C. Impairment of platelet function, D. Increasing duration of action of muscle relaxants. Okay, A is correct. So in hypothermia usually CMR will reduce as a protective mechanism. Okay. Next, group B. Compared to adults, oxygen desaturation is more frequent in pediatric population because of lower functional residual capacity in children, higher oxygen consumption in adults, lower heart rate in adults, lower FRC in adults. In adult, the answer will be a answer is A. All the error mentioned. It's not computed. So 0. Next, which of the following has a dual effect of increasing gastric pH and decreasing gastric volume to minimize risks associated with aspiration. One minute. Randomly is correct. Okay. Group B. Next question. So therapy for cerebral vasospasm includes A. Hypertension, hypervolemia, hypocarbia, normotension, euvolemia, hypocarbia, hypotension, hemodilution, hypocarbia, hypertension, hypervolemia, hemodilution. C is wrong. Option D, triple H therapy, hypertension, hypervolemia, and hemodilution. ఒక రౌండ్ అయింది. సో ఏ ఫస్ట్ క్వశ్చన్ సెకండ్ క్వశ్చన్ తప్పు చెప్పారా? సో 10 ఫర్ ఎవ్రీథింగ్. నౌ ఇప్పుడు బజార్ రౌండ్ స్టార్ట్ అవుతుంది. సో ఎవరైతే ఫస్ట్ చెప్తారో ఎవరు చూస్తారా? సో ఫస్ట్ ఎవరు చేస్తారో వాళ్ళకి ఆన్సర్ చెప్పే అవకాశం వస్తుంది. బట్ ఎక్కిన తర్వాత మళ్ళీ ఏం చెప్పకపోయినా రాంగ్ చెప్పినా -5. ఓకే, కట్ చెప్తే +10. ఓకే, సో డిసైడ్ అవ్వండి ముందే. సో మీకు ఆన్సర్ చేస్తే రైట్ చేయండి. ఆన్సర్ తెలియకుండా ఫస్ట్ రైట్ చేసి తర్వాత రాంగ్ చెప్పినా రైట్ చేసిన చెప్పినా -5. ఓకే, సో బజార్ రౌండ్ 10 marks for correct answer, -5 marks for wrong answer. Okay, ready? Okay. First question. Which of the following portions of myocardium has a dual blood supply? A bundle of his, AV node, posterior papillary muscle, SA node. చెప్పకపోతే ఆడియన్స్ ఎవరు చెప్పచ్చు. డియా ఆప్షన్ బి -5. ఛాన్స్ ఉంది. ఓకే, కరెక్ట్. -5. ఆన్సర్ ఇస్ bundle of his. Next question, be ready? Okay. So, a 30-year-old man is admitted to ICU, intubated after 14 hours spine surgery in prone position. When he emerges from the anesthesia, he bites on his 200 ET tube, tries frantically to breathe, and panics when he is unable to draw a breath. The nurse bolus propofol and achieves adequate sedation. 5 minutes later, the SpO2 rapidly fell from 99 to 65, and patient apparently became sedated. Pink froth is seen in endotracheal tube. This complication would have been avoided by. Okay. Itama, see here. Sorry, you wrote hand raise to step answer. Okay, C is the correct answer. So it is a negative pressure pulmonary edema. Okay, that's 10 marks. So the efferent limb of the limb of the chloric closure reflex, which is involved in laryngospasm, in the involves term. So efferent limb efferent కాదు ముందు చూసుకోండి. So internal branch of superior laryngeal nerve, hypoglossal nerve, recurrent laryngeal nerve, glossopharyngeal nerve. So A is wrong. B. Yes, C is correct. Okay, efferent limb is mediated by superior laryngeal nerve. Efferent is recurrent laryngeal nerve. Okay, so we will keep 10 marks. So mark minus 5. Plus 10. Mark minus 5. Next question. Be ready. Absolute contraindication for electroconvulsive therapy is A. Hypertension, B. Pheochromocytoma, C. History of MI 9 months back, D. History of stroke 1 year back. చెప్పమ్మా. B. Pheochromocytoma is correct. Okay, so contraindication for pheochromocytoma, recent MI, okay, less than 3 months కానీ or stroke less than 1 month, okay, ICP ఇవన్నీ conditions. Congratulations to C cardiac arrest group. They have done very well. Congratulations. Cardiac arrest has really nailed today and gave attack to other groups. Yes. So ఒక టై అయితే ఇంకో క్వశ్చన్ పెడదాం అనుకున్నాను. ఈ టై బ్రేకర్ ఎవరైనా చెప్పచ్చు. సెకండ్ ప్రైజ్ రెడీ ఉన్నాను ఫస్ట్ ప్రైజ్ బి అండ్ డి టై బ్రేకర్ చెప్పండి అమ్మ. So B group as came second, bronchospasm. So this is completed, and now I request Pradeep sir to give prizes to first team who came first, cardiac arrest. I request Dr. Srija to come and give prizes to second people who came second, bronchospasm group. మీ పేరు లలిత. Okay, I request Dr. Srija to give prizes to Lalita and Amala, who came second. Thank you, PGs, for participating in this quiz. And very well organized CME from Hey, Abra. Volume seconds. So I'm very thankful to all our faculty. I'm very proud of them. And our postgraduates who worked very hard. అందరూ బాగా వర్క్ చేశారు. I'm very happy, especially for anchors who made it a very great success, and they all managed very well. And IT department, Lakshmi, and other departments also. Everyone, thank you. Thanks a lot. IT department for thank you.
Naveen, Rahul, Sandeep, Srinivas, and Jagrati, Anusha, Adasmit, Rahul Simpson. Special thanks for Vidya registrations and Vijana for momentous helping us singing. Thank you very much. Thank you all. Thank you. And duty pays also Lakshmi, who managed the Perioperative. Thank you. Thank you. And passed out PG Tiranga also participated well. Pastor, give us. Sai also, thank you Sai, very patiently you took photos. Thank you very much. PC presenters, K. and Mano, you done a good job.